academic event from Ferty9 organization, FERTYGNAN 2023. Robert Noyce once said, "Knowledge is power. Knowledge shared is power multiplied." We are gathered here today to share knowledge, continue learning, and to empower ourselves. So, without further delay, let us start our CME program.
I am so glad that we are joined by over so many beautiful gynecologists to this session. And to kickstart this session, we invite our chairpersons onto the dais.
So, today regarding the first session, fertility in men and women is regulated by a series of tightly coordinated and synchronized interactions within the HPG axis. So, the operational characteristics of reproductive axis leave little room for error. To chair the first session regarding evaluation of infertile couple, we would like to invite on stage Dr. Manjula Rao. Dr. Manjula Rao is a consultant and HOD at Durgabai Deshmukh Hospital. She's been training DNB trainees and she is the current treasurer of OGSH 23-24. Welcome, ma'am. Next, we would like to invite on stage Dr. Nayani. She is a consultant fertility specialist at Ferty9 Kareemnagar. She did her master's in reproductive medicine at Homerton University, London, and IMA fellowship in reproductive medicine. She also is trained in medical diagnostic ultrasonography. Welcome, ma'am. Next, we would like to invite Dr. Preeti Dayal. She is an experienced obstetrician and gynecologist with over 4 years experience, and she is a current civil assistant surgeon at Jangam for the past 5 years. Welcome, ma'am.
To one and all. At the outset, first let me congratulate Dr. Jyothi and her team for this second CME. I'm sure it's going to be as grand a success. K. Anusha Reddy, who's going to give her talk on male partner evaluation. Dr. K. Anusha Reddy has done her MBBS from Kamineni Institute of Medical Sciences and post-graduation from SVS Medical College, and fellowship in gynec endoscopy with Dr. Manjula Anagani. She has an IMA fellowship in infertility and masters in reproductive medicine at Homerton University, UK, and training in advanced infertility, and she has worked as an assistant professor at Government Hospital, Hannamkonda. And as you can see, she's also clinical head and fertility specialist, Ferty9 at Warangal. So please start your talk.
Thank you, ma'am, for the kind introduction. It gives me immense pleasure to welcome all the delegates from different parts of the country on this pleasant Sunday morning. We promise to make your Sunday count. My topic for today is evaluation of male partner. Yes, he also is responsible. Male as a whole is involved in 1/3 of the cases, and he, as a part of combined factor and unexplained infertility, is involved in more than 50% of the cases. There is growing concern of raising male fertility issues all over the world. Many meta-analyses have reported that sperm concentrations declined by 50% over the past 40 years. Etiology can be pre-testicular, testicular, or post-testicular. We can see that among all the etiological factors, idiopathic infertility is accounting for more than 30 to 50% of the cases. Do we really understand male infertility? Does routine semen analysis can differentiate a fertile man from infertile man? Do we need to do advanced sperm function tests for everyone? When to start evaluating a male in depth? What do guidelines say? What we know is just the tip of the iceberg, and there is much we need to know about male infertility. Among different components of evaluation, history is really important and should be evaluated in depth. Men think that age is just a number, But when his age increases by more than 35-40, even though his counts are normal, there is increased DNA fragmentation which leads to decreased probability of conception, increased sperm chromosomal anomalies and adverse fetal outcomes. As the duration of infertility increases by more than 5 years, there is further decline of fertility by 30%. Sexual history is important. We should evaluate for ejaculatory or erectile dysfunctions. As the frequency of coitus decreases, their probability of conception decreases. Past medical history and associated drug history should be evaluated because most of these drugs are involved in erectile and ejaculatory dysfunctions, causes raised DFI and abnormal sperm parameters. Lifestyle factors should be evaluated in depth. They should be repeatedly stressed upon because they are correctable. Alcohol should not be more than 1 to 2 units per day. Smoking or tobacco in any form, not only in smoking, chewing pan, gutka should be complete no-no. BMI, as it is increasing more than 30%, there is further decline of fertility by 30%, and when BMI is increasing more than 35, there is further decline by 50%. There are many studies which says that increasing stress, pollution, pesticides, excessive mobile phone usages, increased industrialization and increased exposure to endocrine disrupting agents are the leading cause for rising fertility issues all over the world. Co-sibling history should be asked when one of the sibling is affected by any genetic anomalies or cryptorchidism. Physical examination should not be skipped. Semen analysis should always be done in a standardized lab following WHO 2010 guidelines. Abnormal reports should be confirmed by at least 2 reports 4 weeks apart with 3 to 7 days of abstinence. Semen collection may not be easy. There are many studies which says that semen collected in bathrooms or abnormal, uncomfortable places causes, without proper arousal, causes decreased sperm, abnormal false low sperm volume and concentrations. So semen collection rooms should be provided with adequate ambience, privacy and facilities for washing. So those who are opting for home collections should be properly instructed to bring the sample as early as possible within 30 minutes, and it should be maintained as close to body temperature as possible. Spillage should be asked for each and every one because initial few drops has maximum sperm concentrations. These are WHO 2010 reference limits. Out of these, 4 are important: volume of 1.5 ml, concentration of 15 million per ml, progressive motility of 32% and morphology of 4%. These are lower reference limits of normal, just like pass mark in our exam. WHO 2021 has come after 2010, but it is very much similar to 2010. Semen analysis has both macroscopic and microscopic evaluation. Whenever we see decreased, delayed liquefaction and increased viscosity, always suspect infection. When in cases where low volume, very low sperm counts and low pH, always suspect obstruction. Either it can be genetical or acquired due to infections. In cases of low volume and normal counts, suspect semen collection difficulties, spillage or partial retrograde ejaculation. In cases of low volume and partial low counts, androgen deficiency can be there. There is a role of HCG injections, but please don't give testosterone injections. Testosterone injection has no role in male infertility. It causes complete testicular failure. Total motile sperm count is a better indicator than WHO classification system calculated by multiplying volume with concentration and motility. TMSC more than 5 is an indicator for IUI and less than 5 is an indicator for IVF ICSI. Isolated teratozoospermia should not be stressed upon. It is not an indication for TISA. It is not an indication for TISA or IVF ICSI because we are just counting 100 sperms, not the entire sample. Role of pyospermia is controversial. Abnormal immature sperm cells just look like pus cells. It should be differentiated with special stains and when confirmed should be properly treated with antibiotics because pus cells causes increased DFI and causes low success rates even in IVF and ICSI. Routine semen analysis should not be used as a sole criteria to include or exclude a male from further evaluation because it is subject to poorly standardized, not a powerful predictor of fertility, and it doesn't give information regarding the functional ability of the sperm. When to do advanced sperm function tests? In cases of recurrent IUI, IVF failure or recurrent miscarriages or any history suggestive of increased DNA fragmentation like advanced age, infections, varicose seals, drugs, smoking, pollution, or prolonged abstinence, this causes increased oxidative stress in the sperm, which causes lipid peroxidation, sperm membrane damage, DNA damage, sperm damage, leading to infertility. ROS actually has a physiological role, but when it is produced in excessive amounts, when the balance is lost, it causes abnormal spermatogenesis leading to subfertility. DFI actually helps in decision making because when the DFI is more, even though the sperm counts are normal, IU has very low success rates. When the DFI is more than 30, ICSI does better results than IVF. But it should not be used as a routine because it lacks standardization, it lacks definitive treatment, and oocytes can actually repair the damaged DNA. Ultrasound should be used in case of low volume, low pH sperm to rule out obstruction, but it should not be used in varicocele detection because grade 0 varicocele, which is subclinical, only detected in ultrasound, is not an indicator for treatment even in the presence of infertility. So subclinical varicocele, even in the presence of infertility, we are not going to treat it. Only clinical varicocele in the presence of infertility, correction is indicated because post-correction, many studies have shown that there is statistically significant increased success rates in IUI and even in IVF ICSI. Hormonal evaluation should be done in cases of azoospermia and severe oats less than 5 million per ml. It helps us in differentiating obstructive from non-obstructive azoospermia. In case of obstruction, everything is normal. In cases of hypo, all the hormones are abnormal. In case of testicular failure, FSH and LH is more and testosterone is less. T/E ratio is calculated, that is testosterone to estrogen ratio is calculated, and when this ratio is less than 10, which is very commonly seen in obese men who has a lot of estrogen in them, letrozole is used in treatments in these cases. Role of testicular biopsy is minimal. It should always be done in places where cryopreservation is there because first time gives the best result. Even if trial TISA is negative, the sample should be sent for histopathological examination because depending upon the diagnosis, and based on the chance of sperm retrieval in patients who are very keen on self-sperm, they can be given treatment for 3 more months of hormonal treatment and can be advised for micro-TC. Genetic testing is done in case of azoospermia and severe oligozoospermia because it is seen that in 15% of patients with azoospermia and 5 to 10% of patients with severe oats has karyotype and Y chromosome microdeletions, and when we use these sperms in making embryos, they can transmit these anomalies to the offsprings. So in the presence of these genetic defects, couple can opt for PGT-SR, get their embryos tested and transfer unaffected embryos. I would like to end my talk with a controversial topic, whether to treat the man or treat the sperm. Whether we take all the pain in treating the man by correcting lifestyle factors, giving him antioxidants, or sperm vitalizers, antibiotics, or clomiphene in case of unexplained infertility, letrozole in case of obese men, or do microsurgical corrections if required, or just treat the sperm with MAX, microfluidics, IMSI, ICSI, PICSI. Many studies have shown that treating the man before treating the sperm gives us increased success rates. Take-home message is male infertility, a growing concern. Lifestyle factors should be repeatedly stressed upon. Physical examination is a must. Semen analysis only done in standardized lab, and any abnormal report should be confirmed by 2 reports 4 weeks apart. TMSA is a better indicator of severity. Isolated teratozoospermia not to be stressed upon. Pyospermia should be treated appropriately after confirmation. Imaging not as a replacement of clinical examination. Subclinical varicocele not an indication for treatment. Trial TISA should always be done in centers where cryopreservation is available. Donor sperm should be the last option. Thank you.
Thank you, Dr. Anusha. I think you covered it so beautifully with the take-home messages, and it's a very important part of investigation of an infertile couple, and you have covered the topic so beautifully. Thank you so much.
A very good morning to all. Next, I would like to invite Dr. Shashi Priya. She is going to speak on female partner evaluation. She is MS, OBG, MBBS, member of ISAR, IFS and FOXY. She has conducted seminars and teaching classes for various clinicians through IMA and fellowship program. She has an experience in fertility consultant at Ferty9 and is assistant professor at Malareddy Medical College for Women. She was senior resident at Siddipet Medical College. So over to you, Dr. Shashi.
Thank you, ma'am. Very good morning and welcome to the session. So without any delay, let me start my session with evaluation of an infertile female. So coming to this topic, so why is female important? Obviously because our speaker, Dr. Anusha, has elicited very well about why male is important. Now, coming to female partner, around 40 to 50% of the cases of infertility, so female is responsible. So in this age, pertaining to the age, if the age is less than 30 years, the incidence is 1 in 8, that accounts to 13%, and if the age is more than 30 years, it is 1 in 5 people, that is 33% according to CDC. Now, according to WHO, 10% of the reproductive age females are inflicted with infertility and subfertility. So in India, according to NIH, 8% of the currently married women are infertile, out of which 5.8% have secondary infertility. So when to evaluate now and how to evaluate is the question. So according to ACOG and ASRM, so if the woman is less than 35 years and failed to conceive after 1 year of attempts for the pregnancy, then evaluation should be done. So and the evaluation should be expedited if the age is more than 35 years to 6 months, and if the age is more than 40 years, definitely immediate evaluation should be done. And if the female partner has a history of any gynecological conditions earlier, then definitely immediate evaluation should be done by the first line doctor, that is obstetrician or gynecologist. Then coming to our how to evaluate. So coming to this, basic evaluation should be done, taking the history, physical examination, local examination, and pertaining to the etiology of our infertility. So history. So what is important? So in the history should be taken forward with the conditions pertaining to infertility. So that is age of menarche when we are going to the menstrual history, and the cycle length and any dysmenorrhea associated with it, and any positive signs of ovulation, that is cervical mucus changes, should be inquired of. Then again, coming to the history, personal history, especially coital frequency, any dyspareunia, and number of attempts for the pregnancy, and any history of contraception should be elicited. Then along with this, we are going to the past obstetric history, which should include the gravity, parity, and attempts for the pregnancy, for the previous pregnancy, and history of any previous fertility treatments and any complications associated with the first pregnancy. So along with this, now we have to elicit the family history if any treatments have been taken for the siblings, or history of PCO running in the family, and again we have to rule out the surgical history pertaining to especially any abdominal surgeries or pelvic surgeries previously done, and previous medical history is also important for us to rule out any thyroid abnormalities and any history of TB, which is really relevant in our case. So coming to local examination, definitely per-abdomen examination should be done to rule out any abdominal masses, and local examination, that is pelvic examination, should be done to rule out any masses and size of the uterus, any mass occupying lesions in the cul-de-sac, and the mobility of the uterus should be elicited to rule out any PID. Then cervix, definitely per speculum examination should be done to rule out any cervical polyps conditions are there. Then coming to our evaluation part of thyroid. See, when we are doing head-to-toe examination pertaining to fertility, thyroid is the most important thing. So, see, ASRM guidelines and European Thyroid Association have said that, so when the thyroid level is more than 4%, more than 4 international units,
then there is chances of recurrent pregnancy losses in the first trimester, and subclinical hypothyroidism is also one of the cause for implantation failures. So definitely the values when we are evaluating a female partner should be less than 2.5, and if it is more than 2.5, definitely 25 or micrograms, or along with the BMI, the dose should be calculated and it should be treated. So these are few guidelines which is set by the ASRM and ETA. So we can go through it. Then coming to CBC, anemia is also one of the factor. So follicular development is a stage of rapid cell proliferation and increased steroidogenesis. Both cell proliferation and steroidogenesis require ATP energy for mRNA and protein synthesis. So follicle development greatly increases the iron demand. So definitely if we have iron deficiency anemia, it is going to cause any ovulatory dysfunction. So anemia should be treated. So this puts an end to our physical examination, and the more important thing is BMI. Definitely height, weight and BMI should be calculated. If the BMI is more, then the fertility chance decreases and fecundity rates are also very less. So again, when we are seeing the skin, definitely signs of any hyperandrogenism, hirsutism, acne, these all should be ruled out. So even one vitals are very important. Blood pressure, pulse should be monitored, which rules out any subclinical hypothyroidism. Then coming to the local examination, that is our reproductive system, ovarian factor, tubal factor, uterine factor and cervical factor should be elicited. So in the ovarian factor, so what are we going to look at the ovaries? Definitely ovary is the one which will give us the eggs. So ovulation, so these tests are generally done. So basal body temperature and LH kits. Basal body temperature, it is tedious, so we are not going to do it. And LH kits, definitely, if the patient is well versed with the fertility period, then we can recommend giving the LH kits and asking them to evaluate. Then mid-cycle progesterone, yes, it can be done, but not routinely, because it is very tedious for the patient to come on day 21 and to check it. So transvaginal ultrasonography, definitely it is a part and parcel of our treatments. So when we are looking at the ovary, so we have to start a follicular medley doing on day 2. So on day 2, we have to see the ovarian volume, number of AFC. So antral follicular count, normal antral follicular count is 8 to 10 per ovary. More than 20 is regarded as PCO, and less than 4 per ovary or combinedly less than 8 is poor ovarian reserve. So along with this, if we are doing any blood test, so then definitely combined E2 and FSH should be done, not a single thing. Either doing individually E2 or individually FSH on random day of the cycle doesn't fetch our purpose. Then we have to go for AMH. So AMH is a hormone released by granulosa cells of preantral follicles. So it gives us a rough idea about the ovarian reserve. So when we do a scan, so we do elicit any hemorrhagic cyst, endometriotic cyst, CL cyst or luteinized unruptured follicle, which will add to the treatment in the next cycle. So next is the tube. Tube is very important for us because the fertilization does happen in the tube only. So how are we going to evaluate the tube? So conventional methods of HSG are there, and gold standard techniques of laparoscopy are there, but sonohysterosalpingography appears to be inexpensive, minimally invasive, quick and no risk of ionizing radiation and well tolerated. And it is even good in determining the uterine cavity, and it can be performed at the time of ultrasound in the place of HSC and laparoscopy. So when this tubal patency tests are deferred are when the patient is having any signs of infection or previous history of PID, this should be deferred because it causes the dissemination. Then laparoscopy, definitely we can go for laparoscopy. It will give us an additional preference of adhesiolysis or any endometriosis that can be treated as well. So I'm just concluding with the session. So extra factors. So uterine factors, definitely when we are doing an ultrasonography, any Mullerian abnormalities should be ruled out. Fibroids, endometriosis, Asherman's, adenomyosis and uterine polyps should be ruled out. So coming to the last, and the first part, that is the cervical testing. So when we are putting a speculum, what is important for us? The cervical polyps, we have to check for cervical stenosis and hostile cervical mucus, because these small things, if we evaluate, then natural conception will be easy for them if they doesn't have any other abnormality. So take home messages, E2 should be tested along with FSH, and thyroid screening should be done. AMH is an indicator for ovarian reserve, not for pregnancy outcomes. So according to the new ASRM guidelines, infertility tests that should not be ordered routinely are laparoscopy for unexplained infertility, advanced sperm function testing, postcoital testing, thrombophilia testing, karyotyping, endometrial biopsy, and prolactin. Thank you.
Thank you, Dr. Shashi. You have covered all the points, and I think when infertility couple comes to us, it is very important to take the history for male and female partner. So, depending on the history and history, we will evaluate.
So, ovarian reserve is defined as the number of oocytes, or in other words, oocyte quantity in the ovary at any given time. So, this should be differentiated from oocyte quality, which is the potential of a fertilized oocyte to result in a live-born infant. So, why is the ovarian reserve need to be tested? So, any reserve which depletes need to be checked or tested, as ovarian reserve depletes, and it may deplete very rapidly in some women, and this ovarian reserve cannot be replenished by any means. So, ovarian reserve testing becomes important. So, these are risk factors for diminished ovarian reserve, like advanced age of more than 35 years, women with family history of early menopause, with some genetic conditions, or with conditions like endometriosis which cause ovarian injury, and women with history of ovarian surgery, or a history of gonadotoxic therapy or pelvic irradiation, and history of smoking. So, these women will be at risk for diminished ovarian reserve and should be tested for the same. So, what are the ovarian reserve tests which are available? So, first and foremost is the chronological age. So, as you all know, as the age increases, as a woman ages, the ovarian reserve decreases. So, we have the maximum ovarian reserve at 18 to 22 weeks of post-conception, that is in the fetal life. Then at birth it decreases, and after birth it depletes, and then at after 35 years of age it depletes rapidly, and after 40 to 50 years, in between 40 to 50 years, this will be the end of infertility, and end of fertility and menopause sets in. So, the previous slide. The next. Can I have the previous slides? Previous slide. Yeah. So, in some women, as though they start with the normal reserve because of some environmental conditions, or some as mentioned, endometriosis or a history of chemotherapy, the ovarian reserve may deplete rapidly, and they may end up in diminished ovarian reserve. Some women may have a low reserve to start with, as in this curve, these women have the low reserve to start with, but normal depletion, but the end product is reduced diminished ovarian reserve and early menopause. So, coming to the biochemical measures of ovarian reserve, what are these biochemical measures? These are the hormones which are secreted from the oocytes, like primordial follicles, primary, secondary, antral follicles. These are the hormones which are secreted from the follicular pool and the pituitary, which we use, which we assess to assess the ovarian reserve of a woman. So, when this follicular pool is reduced, that is the primordial, primary, preantral, and early antral follicles are reduced, the AMH and inhibin B levels, which are secreted from the follicular pool, are reduced, and as a result, there is a negative impact on the central negative feedback. As a result, FSH is raised. So this AMH and inhibin B can be used as a direct measures for reduced, as the levels decreases, we may, direct measures of the ovarian reserve, whereas increased FSH, because of the reduced AMH and inhibin, negative feedback is reduced, FSH is increased, which can be used to assess ovarian reserve. So as the FSH is increased, there will be early onset of follicular growth and increased basal E2 levels. So there will be a shortened cycle. These can be used as an indirect measures for decreased ovarian reserve. So coming to the details of biochemical measures, FSH to be measured on day 2 or day 3 of the cycle, but there is a variation between cycles. This has high specificity but low sensitivity, which means high values indicates the decreased ovarian reserve, but very early stages of diminished ovarian reserve cannot be detected. Basal serum E2 levels alone may not be useful, but with the serum FSH levels, as you can see here, basal E2 levels more than 70 with the normal FSH on day 2 should not be misinterpreted as a normal ovarian reserve, as a high basal E2 levels masks the increased FSH levels and may reduce the FSH levels to the normal levels. So AMH is a very important hormone. This is secreted by the granulosa cells of the recruited follicles until they become sensitive to FSH. So AMH plays an important role in the maintenance of follicle pool. So normal range is taken as 2 to 6.8 nanogram per ml. The advantages are gonadotrophin independent, cycle day independent, it is relatively constant between cycles, more sensitive than FSH and tends to decline before FSH rises. So the other dynamic tests, these are not used nowadays. And then biophysical markers, ovarian volume, lack of sensitivity, but the mean ovarian volume less than 3 ml or a low mean diameter of less than 2 centimeters predicts poor ovarian response. So antral follicle count. So antral follicle count is the sum of the number of follicles, antral follicles in both ovaries gives the AFC. 2 to 10 mm mean diameter follicles in the greatest 2D plane at early follicular phase is measured. So this has low intercycle variability. Normal considered as 10 to 18, whereas less than 7 indicates poor response. So what do the studies say about ovarian reserve testing? So currently AMH and AFC are most sensitive and reliable markers of ovarian reserve. Combined ovarian reserve tests do not consistently improve predictive ability over that of a single ovarian reserve test. So selecting a marker of ovarian reserve. So AMH, AFC, FSH. So obviously AMH is more sensitive than FSH, tends to decline before FSH rises. But AFC and AMH have been shown to be equivalent in most of the studies. But most of the times, in more than 30% of population, we may find AFC and AMH to be discordant. There will be discrepancy in AFC and AMH. That means AMH in few women, AMH may be high, but the AFC on the scan shows as less AFC. So what to be given importance, AFC or AMH? So when seen physiological point of view, if you see, the AMH is secreted from the resting pool of the follicles, that is before they are recruited, primordial, primary and very early antral follicles, whereas AFC or the antral follicles, these are a recruitable pool which are sensitive to FSH. So both should be seen as a different entities. So if a woman comes with the very less AMH but the AFC are good, so it means that the resting pool, that is the actual reserve, is decreasing. So we have to use the AFC as soon as possible. We have to use the follicle as soon as possible. Whereas when a woman comes with a less AFC, her AMH is good, then inter-cycle variability of AFC should be considered, and then in some cases, the technical aspects, technical variations should also be considered. Then, yeah. So, I will conclude with this important slide. AMH and AFC are currently simplest, most sensitive and specific measures of ovarian reserve. Markers of ovarian reserve shown to be good predictors of oocyte yield, but poor independent predictors of reproductive potential. They should not be used as a fertility test or to deny access to infertility treatment. Age is the best marker for oocyte quality. Ovarian reserve testing allows pre-treatment patient counseling, individualization of stimulation strategy, increased cost effectiveness, and enhanced safety. Thank you.
And the woman should know when her clock is ticking. And thanks to ovarian freezing. Thank you.
Thank you for that talk. I think we have the Dr. Grishma Krishna Medical College, post-graduation from Kasturba Medical College, Manipal, and has a fellowship in reproductive medicine from as an assistant professor in Deccan Medical College and a fertility consultant in Rainbow, senior fertility consultant at KPHP Hyderabad.
So setting up of an IVF lab. IVF lab is an essential prerequisite of a level 2 ART clinic. So coming to the essential pillars of an IVF lab, infrastructure, equipment and staff, these are the essential pillars of an IVF lab. As said by Aristotle, beginning good is very important. That means a good beginning means almost half of the work is complete. So ART lab setup focuses on 3 key areas like place selection and also staff selection and also procedures. There should be a standard set of SOPs for the procedures, and also there should be a good quality control system, and also a good witness system should be there. Coming to the place, any place which is nearer to the chemical factories or petroleum pumps should be avoided, and also first floor is ideal because of less disturbance, and also when selecting a place, it should have a good connectivity with lift or elevators for the transportation of gas cylinders, etc. And also if we are planning a ART setup in a hospital, it should not be nearer to any radiation sources. So the area required for an ideal lab is about 12 into 12 square feet. So this is the basic layout of an IVF lab, where the IVF lab should be always situated adjacent to the OT with a pass window in between for any transportation of substances to prevent minimal contamination. And also there should be an andrology lab adjacent to the semen collection room with a pass window in between. And also freezing room should be separate, carbon dioxide cylinder room, everything should be separate. And also while starting an IVF lab, we should have an action plan like what is the site survey, design selection, budget, overall planning, equipment selection and order. Everything should be thought beforehand. And then coming to the infrastructure, and in the embryology lab, we should be mimicking the in vivo atmosphere. So it is important to optimize the fertilization rates and pregnancy rates. If we take the incubators and culture media, they will be in a controlled conditions, like almost everything will be controlled, like temperature, carbon dioxide. But we have to take out the gametes into the IVF lab for various procedures like ICSI, FERT check, assisted hatching, etc. So maintaining lab atmosphere in controlled conditions in terms of temperature, humidity and ambient air quality is the utmost important thing. So coming to the air quality. Air quality plays a significant role in embryogenesis, implantation and conception. So particulate matter and VOCs, these act as a threat to the air quality because VOCs in turn generate harmful mutagenic chemicals. So all these products which are used at home and work like petroleum products, like nail polishes, fabric cleaners, everything can generate VOCs which are nothing but benzene compounds, aldehyde compounds and alcohol compounds. So for maintaining a good air quality, a proper HVAC system like heating, ventilation and air conditioning system is very important so that it delivers clean air to the room, removes any contaminants and differential air pressure is maintained, and it should also control temperature and humidity. This is the international standard, clean room standard for an IVF lab, which should have a class 10,000 particles, and an ISO 7 room should be there. So this is the clean room concept of an IVF lab, where the outside air entered goes into the air handling unit, that is number 1 and number 3, which is equipped with potassium permanganate carbon activated filters, so that all the VOCs are filtered, and the VOC filtered air will come into the box 5. This is the HEPA filtration system. So all the particulate matters can be filtered from HEPA filtration system, and the clean air will be entering into the embryology lab and the OT room. So this is the air cycle changes per hour, and also the air returning duct will be number 7. So what we should remember is HEPA pore is like 0.3 micrometers. So VOC molecule is smaller than that. So a HEPA pore cannot filter a VOC molecule. So coming to the air quality in IVF, so a clean room IVF lab, it can increase the pregnancy rates, and it will decrease the miscarriage rates. So according to the international consensus like Cairo consensus and ESHRE guideline groups, so the air quality particulate should be ISO 7, and the microorganisms should be less than 10. VOCs should be around 400 to 800 parts per billion. Air changes should be 15 total air changes with 3 fresh air changes per hour, so that 20% outside air can enter, and pressure is around 30 pascals, temperature is around 20 to 24 degrees centigrade, and relative room humidity is around 40 and 45 degrees centigrade. So coming to the infrastructure, all the infrastructure which should avoid VOCs should be used, like water-based paints, and laboratory walls and ceilings should have minimum penetrations with silicone materials used as sealants, and wood should be avoided. Steel or powdered coated aluminum furniture should be used, and there should be a proper step for vermin proofing. And this is prior to starting, at least 2 to 4 weeks prior to start of an IVF lab, we should increase the lab temperature by 10 to 15 degrees centigrade, and also increase the air cycles to remove the contaminants. Coming to the equipment, according to the ART Act, this is the minimum equipment required after starting an IVF lab, like there should be at least 1 stereo zoom microscope, and incubators at least minimum 2 in number should be there. And this is the box incubator, that is a carbon dioxide only incubator, where 3 partitions are there. And the next down one is the triple gas incubator, K-system incubator, where we can see 10 different wells, so that 10 patient culture conditions can be done at a time. And also there should be a laminar airflow, sperm counting chambers. So these all should be included in the equipment required. So coming to the quality management, so appropriate steps should be taken, mainly for the correct identification of gametes. So in any cost, we should avoid mix-ups. So all this laminar flow hoods, everything what we are using should be checked every month for any microbial contamination by a swab test. And also every day after coming to the lab, we should check the incubator's temperature, carbon dioxide, everything, and whether proper laminar airflow pressure system, everything is maintained or not. So this is what we do is, before commencing, this is for the, in order to avoid mix-ups, we give a unique identification code for the patient, and then we verify the unique identification code in the lab along with the patient, and then we label. So during any procedure, we label all the containers with the unique identification code, and then we do a double witnessing system. And now this is the important thing, which is the advanced RI witness system, which uses an electronic witness system, that is radio frequency identification. So before the start of the cycle, we will be giving an RFID cards to the patient, and everything lab, everything will be RFID equipped workstations will be there. And also RFID generated tags will be, so while doing any procedures, these tags will be used for all the consumables or disposables used for the patient. And then so in the workstation, only those patient samples can be used. If the other patient sample by mistake, if it is kept, it will show as mismatch. So the quality of consumables, everything, plasticware, everything should be produced from reliable manufacturers, and also the culture medium, everything should be tested before using. Staff, this is the bare minimum requirement, like gynecologist should be there, andrologist, embryologist, counselor, anesthetist, and a medical director should be there. So after starting an IVF lab, the project does not end there. It rather begins there. The success depends upon the competence of the team, training, quality control, proper SOPs, timely audits, and patient-centered approach. So this is our Kukatpalli IVF lab, which we have started. So this is the IVF lab, and this is the alert system. So this is the OPU OT and the patient recovery room. And then this is inside the IVF lab, cryo room, and this is the carbon dioxide incubator, Hera cell incubator, and this is the K system incubator, that is the triple gas incubator. This is the ICSI machine, and this is the RFID, RI witness system. This is the RFID equipped controls, everything is there. And this is the pass box where we have a 2 open door pass box. When one door is open, the other door is automatically locked for exchange of material between the embryologist and the OT staff. So these are just the pics. I just wanted to show the clean air RFID room. So this is all, this thing is the RFID equipped system. Thank you.
Thank you, Dr. Grishma, giving us first the most important aspects of managing an infertility couple, which is evaluation, and finally the IVF lab setup. I, on behalf of the co-chairpersons, thank Dr. Jyothi and her team for giving us this opportunity. Thank you all.
Thank you, speakers, and all the chairpersons for a wonderful session. Unexplained infertility is a frustrating diagnosis to receive, but is also a common one. Here's our attempt at explaining the unexplained. To chair the session for today, I take immense pleasure and pride in inviting the next chairperson, Dr. Vijay Lakshmi, also my mom. So Dr. Vijay Lakshmi has a vast experience in the field of OBG for 27 years. Established Sanjeevani Charitable Trust in 2017, and she is a recipient of many awards like National Mahira Ratan Gold Medal Award and APJ Abdul Kalam Memorial Lifetime Achievement Award. Welcome, ma'am. You are a super mom indeed. Next chairperson is Dr. Rajni, Assistant Professor, Mahatma Gandhi Memorial Hospital, Warangal, Consultant at Mahi Hospital, Warangal, and she has published various research papers in national and international journals. Dr. Rajni ma'am, please welcome. And the next chairperson is Dr. Suma ma'am, fertility consultant at Ferty9 Fertility Center, Vijayawada. She has done her Masters in Reproductive Medicine, Homerton, UK, and she has conducted 1-year IMA fellowship at Reproductive Medicine and trained several gynecologists at Level 1 ART clinic. Welcome, ma'am.
Good morning, one and all. First of all, I would like to congratulate the whole Ferty9 team and the director, Dr. Jyothi, for organizing this wonderful CME, FERTYGNAN. I thank the organizers for making me a part of this conference. And I have attended the previous conference also at Marriott, Hotel Marriott in 2018, which was a huge success. And I wish this conference to be a blockbuster success. And one word about Dr. Jyothi and her team. She is a very passionate teacher, and she has trained many consultant gynacs in infertility. She believes in teamwork and helps her juniors to grow along with her. And these qualities made Ferty9 a top brand in infertility. Now, coming to the session, I am privileged to introduce. You are introducing, right? Mine is the last speaker. Okay. Dr. Maunika. She has done her MBBS from Usmania Medical College, Hyderabad, and she has done her post-graduation with a gold medal from JSS Medical College, Mysuru. And she has fellowship in reproductive medicine at Oasis Fertility, Hyderabad. And she has FRM diploma in ART, Kiel University, Germany. And she is a fertility consultant, Ferty9, LB Nagar. And now she will talk on unexplained infertility, what's new. over to you, Dr. Monica.
Today is about unexplained infertility. Unexplained infertility is a topic where there's a lot of anonymity surrounding it in terms of its diagnosis, management, or at the very onset, even the definition. Now, the definition of unexplained infertility has evolved over time. The oldest standard definition given by RCOG in 1998 stated that a couple, in spite of trying, if they're unable to achieve a pregnancy even after 1 year, and all their routine, basic, or standard investigations end up being normal, we can attach the diagnosis of unexplained infertility to them. When I say routine, basic, or standard, we are talking about one, from the lady's side, documentation of ovulation; second, the tubal patency being checked; and from the husband's side, a basic semen analysis. Now, after this, IC Martin 2017 went a little in depth. It stated that in women, the entire ovarian anatomy, the tubal function, and also the uterus, cervix, vagina, and the pelvis also needs to be normal. And from the men's side, the genitourinary anatomy, the normal testicular function, and a normal ejaculate as per the WHO norms. Later came ASRM. The practice committee of ASRM in 2020 stated that as long as there is at least one patent fallopian tube in the lady, with all the other parameters being normal, even then we can consider them to be having unexplained infertility. Whatever might be the various definitions that are given, nobody really attached the significance of the age factor. So the age factor has been studied by the latest ESHRE guidelines published in 2022. They tried to figure out that what could be the significance of this age factor. They found that among all the compiled studies, in women where there was less than 35 years, the unexplained infertility was given falsely the diagnosis in 10% of the cases. And in women, the age factor where they were above 40 years, they were wrongly diagnosed as unexplained infertility in nearly 80% of them. If we go a little in depth, what could be the reason for this false diagnosis? Probably any declining ovarian reserve or underlying endometriosis and various other factors. The incidence now, what we should think is with passing time, we are having advanced technologies, even we are going further in terms of evaluation. We should understand that probably this unexplained infertility diagnosis incidence should be decreasing so that we are finding out what could be the reasons. But however, it still stands as high as 30 to 40% of the couples. What could be the possible factors, the underlying factors in them? What we can see is the tubal patency, the semen analysis, and a documentation of ovulation. What we are unable to see, has the egg properly after rupture entered into the tube? What was the tubo-ovarian function? Was the tubal fimbriae able to collect the egg? And after entering into the tube, now millions of sperms are deposited in the uterine cavity. How many of them were able to navigate the uterotubal junction and reach the oocyte? And after reaching the oocyte, fertilization is a complex event, capacitation, sperm acrosome reaction, the oocyte zona penetration has to take place. So all these, are they occurring well? And after formation of the embryo also, it needs to traverse the remaining length of the tube and ultimately reach the uterus. And the dialogue between the embryo and the uterine endometrium needs to be successful. Only then the implantation event occurs and the lady ends up with the pregnancy. So they said that probably in majority of the couples where unexplained infertility is given as the diagnosis, these could be the possible undetected factors. They are subtle tubal dysfunctions, endometriosis, premature ovarian insufficiency, and immunological factors. These are the gamut of investigations as basic which are required both from the women's side and from the man's side before we give them this diagnosis. Apart from the above tests, ESHRE also stressed the importance that we could add on 3D scans, so we are excluding uterine anomalies in these ladies. What is the role of a routine diagnostic laparoscopy or a screening hysteroscopy? They said it is not needed as long as the HSG report is normal. Only in the event the HSG report there is some abnormality that we find, or they have a history of any ectopic pregnancies on endometriosis, to rule them out, yes, we can go ahead for a laparoscopy or a screening hysteroscopy. Various investigations apart from what we have discussed prior, all these investigations, testicular imaging, the sperm DFI or anti-sperm antibodies, thyroid screening or anti-thyroid antibodies, celiac disease screening, genetic testing, all of these do not have a role in unexplained infertility. Coming to management, unexplained infertility couples, most of them, they do not prefer expectant management. They have been trying naturally, the ladies having regular cycles, in the sexual act they do not have any problems that they are facing, and in spite of that, if they are unable to achieve a pregnancy and they come to us, when we give them this diagnosis and tell them you go back to trying naturally, they do not like it. Whether we have to initiate or delay treatment for the couple, it depends on various factors. We need to individualize. What is the age of the lady? How long has she been having the problem of infertility? And what is her desired family size? Expectant management, one of the studies showed that in the first year, if they were asked to try naturally, nearly 14% of them conceived. And in the next 2 years, 35%, and over a span of 3 years, nearly up to 80% of them could conceive naturally. NICE guidelines in 2013 stated that they should be allowed to try expectant management for 2 years, and after that also if they do not get pregnant, maybe we need to go ahead and advise them IVF, especially in women less than 35 years of age. Numerous prediction models have been designed in order to predict the chances of a spontaneous pregnancy over the next 1 year. Most popular model being Hanault model or the synthesis model. This model took into consideration certain factors like female age, the years of subfertility, primary or secondary, percentage of motile sperms, and the referral status. This referral status also carries importance because they found that if the couple was being referred by any random clinician, the chances of spontaneous pregnancy was much higher in comparison to a couple who was being referred to the fertility experts by a gynecologist. Coming to management in couples with unexplained infertility, broadly the treatment we know is, one is the ovulation induction, next going ahead for a IUI, and last being IVF. Now in the beginning part they found that all this ovulation induction combined with the timed intercourse, whether we are using oral ovulogens or gonadotropins, all of them did not prove any superiority to a expectant management. And the same goes for even a natural cycle IUI. When an IUI is not combined with any ovarian stimulation, performing in a natural cycle, IUI also showed no superiority in terms of live birth rate to expectant management. A strong recommendation and a grade A level evidence shows that what is proven to have a role is a IUI combined with ovarian stimulation. This could be probably because we are able to make sure more than one follicle is growing and more number of oocytes are rupturing and ovulating so that they have higher chances at a pregnancy. And in IUI combined with ovarian stimulation, again the doubts arise whether we need to limit them with oral ovulogens or go ahead with gonadotropins, or is it a combination, and what kind of gonadotropin? Should we do a human menopausal gonadotropin or a follicle stimulating hormone? Here also they found that all these have similar success rates in live birth rates. There are differences in terms of multiple pregnancy rates and also OHSS rates. Otherwise, the ultimate outcome that we are aiming for, live birth rate, is not very different. Single IUI versus double IUI. Here also, single IUI versus double IUI, there is no much significance in terms of clinical pregnancy rate. The recommendation according to the practice committee ASRM 2020 states that we need to go ahead for at least 3 to 4 cycles of IUI combined with ovarian stimulation, and even then if the couple is unable to achieve a pregnancy, then follow it up with an advice towards IVF. There were trials that were conducted, one of it being fast track and standard treatment trial. This was published in Fertility Sterility Journal 2010 August issue. Here they tried to evaluate what is the role of an FSH IUI in women suffering with unexplained infertility and particularly belonging to the age group of 21 to 39 years. All these couples, the women, they were randomized to 2 arms. One arm, they followed the treatment of 2 cycles of clomiphene citrate with IUI, followed by 3 cycles of an FSH IUI, and even then if there is no pregnancy, followed up with nearly 6 cycles of IVF. And then we have another arm that was the accelerated arm. Here, they first tried with 3 cycles of clomiphene citrate IUI, and if there was no pregnancy, omitted the role of FSH IUI and directly proceeded towards IVF. When they compared the cumulative pregnancy rates in both the arms, clearly the latter arm, that is the accelerated arm where the FSH IUI was omitted, they showed higher cumulative pregnancy rates. And also they found that that particular arm, the cost of treatment to achieve one live birth was also comparatively lower, and the time to achieve the pregnancy was faster. Next came FERTY trial. This was again unexplained infertility, but the women belonging to a higher upper spectrum, that is 38 to 42 years, where their ovarian reserve is rapidly declining. So here they considered as long as if they were unable to achieve within 6 months after marriage, they can go for the treatment. Now in this treatment, they were again randomized to 3 arms. One arm went for 2 cycles of clomiphene citrate IUI and then followed it up with IVF if there was no pregnancy. The second arm, it was 2 cycles of FSH IUI followed up with IVF. Or the third arm, it was a direct IVF that they attempted. In the first arm, the cumulative pregnancy rates was 21.6%. In the second arm, it was 17.3%. In the last arm, where they immediately were advised IVF, it was nearly 49%. Clearly, immediate IVF demonstrated superior pregnancy rates in comparison to the other arms, even with fewer treatment cycles. What could be the reason? Now, we saw that the women belong to the latter spectrum, that is 38 to 42 years, where their reserve is rapidly declining. If in these cases, if we are attempting the IVF early, probably we could retrieve more number of eggs, make more number of embryos, and give them a higher cumulative pregnancy rate. So this could be a thought that we can follow, like what is the justification in advising a couple to rapidly or directly go for IVF? This could be based upon the diagnosis of what is the ovarian reserve in the lady. So I would like to summarize my talk by stating that unexplained infertility couples have to be stressed over and over again that they do have a chance at a natural pregnancy or natural conception. There is no role of a natural cycle IUI. What is recommended is a stimulated IUI, that is IUI combined with an ovarian stimulation. Whether we need to directly advise or wait before we advise IVF in couples, it depends on numerous factors, like the age of the lady, what is the duration of infertility, and what is the desired family size. She wants to stop at 1 child or have 2 kids. So all these factors need to be taken into consideration when we advise them. Thank you.
Tubal disease. And I had a case of minimal endometriosis where I had small endometrioma. So I did that, and I have sent immediately to Ferty9 for the ART procedure. So there she conceived with IVF in a single shot, single attempt. And thanks to Ferty9 and your team. Thank you.
Thank you, ma'am, for your wonderful words. Thank you.
With great pleasure, I'd like to invite the next speaker, Dr. Charulata Chatterjee. She is the scientific head and consultant embryologist at Ferty9, a top-class experience of last 22 years in the field of ART. She's been the treasurer of IFS Telangana chapter 21 to 23. She is a faculty speaker who participates in many workshops, CMEs and conferences, and she has many publications in national and international journals. So, Madam is going to talk on sperm preparation techniques. Over to you, Madam.
Good morning all. So male partner is evaluated, female partner is evaluated, and lab is all set. So what next? Next is let's prepare the sperm. So the normal conception, what happens? The sperm moves from vagina to cervix and tube, it will fertilize, form the blastocyst, and then the baby is born. So this is the diagram of natural sperm selection, from where the sperm has started the journey from vagina, and it will be a beautiful baby if it is implanted and all the events goes well. So next is the aim of ART. What's the aim? Not only the pregnancy, but the birth of healthy baby. So for that, both the gametes, female gametes and male gametes, both are equally responsible. But today I'm going to talk about only the sperm preparation. The semen analysis, Dr. Anusha has spoke about it. It's the first step for the sperm preparation, where we check the macroanalysis and microanalysis of the sperm, and where we count the total count, motility, sperm vitality and sperm morphology. There are various ways to collect the semen. The best way is to collect with masturbation. The next is coitus interruptus. The third is, if they cannot collect with that too, then there is a spermicidal condom which can be used, or vibrator, or the medicine. WHO analysis from 1980 to 2020, if you see, the sperm is declining. The normal morphology value is 4% only. That means if you see the 4 normal sperm into the 100 sperm count, it considered as to be normal. This is the normal sperm, head, midpiece and the tail. The head morphology is also very, very important because DNA material is there in the head, the tail and the midpiece. There are different abnormality which can be seen, which has shown in this diagram what kind of head abnormality, what kind of midpiece abnormality and what kind of tail abnormality, what we observed under the semen analysis. But we need to take, in case of the ICSI, the normal morphological looking sperm. So the sperm preparation is, there are many basic method and advanced method. Basic methods, and there will be sperm selection. I am not going to talk about the sperm selection, sperm preparation, only advanced and the basic which I am looking for. So first of all, why we need to prepare the sperm? Can't we directly inseminate the sperm in case of IUI? That means no. The answer is no. So we have to isolate the motile and the normal morphological spermatozoa. We have to eliminate the dead spermatozoa, other debris and everything that which is hindering in the semen. So that we have to prepare the sperm for either IUI, IVF or ICSI. The prepared sperm should mimic the condition of in vivo, means sperm capacitation process should be done in vitro. The lab requirement, what are the lab requirements to prepare the sperm is, first of all we have to have air control environment, the clean room air system. We should have the laminar airflow. We should have the microscope, either normal or there should be a computer aided semen analysis, what we call is CASA. We should have the incubator. We should have the centrifuge, either it should be room temperature or the temperature control. Again, what kind of motor is there, swing in model, swing out model, and all that has to be considered when we are establishing the lab for the andrology. There will be a Markler chamber to count the sperm sample and total count and motility. There should be media and disposable. So these are all the requirements to prepare the sperm in the laboratory. Now the basic few sperm preparation method which there are most popular and which is not popular. One of the oldest method for prepared the sperm is called glass wool technique for the sperm preparation. In this, motile spermatozoa are separated from the immotile by means of densely packed glass fiber wools. But this is now outdated, nobody is using this technique. The other technique was sedimentation method for layering under paraffin oil. The semen sample should be, prepared sample should be layered with the paraffin oil, and which are the fastest and motile sperm which come up that should be used for ART. Now the most popular method is swim up method. What we do here is, if the sperm count is normal, means normozoospermia, we mix with the sperm preparation media, we rotate them with the definite RPM, that is rotation per minute, and the supernatant is discarded, the sediment is overlaid with the sperm nutrient media, and the best motile spermatozoa will swim up, and that can be used either for IUI, IVF or ICSI procedure. So every technique has their advantage and disadvantage. The advantage for this method is we get a good crop of the motile spermatozoa, but the disadvantage here is sometimes in the oligospermic sample it will not give a good retrieval, and other disadvantage because here we centrifuge it, so that may be chances of we are having the oxidative stress, and that ROS may hamper the fertilization process or the implantation process. The best method for preparing any kind of spermatozoa, either normozoospermia or oligozoospermia or any, is a density gradient. The principle of this technique is based on the density of the sperm and the media. So what we do, either single density or double density. There will be a ready-made commercially available media which can be used to prepare this kind of method. So in the diagram it is showed the upper layer, the down layer and the sperm. So 80, 90, 80, 40 or 45 or 90 is the density gradient, percentage of the density gradient. So we take 80% down, then we overlay the 40% and the sperm. That is a double technique. First we do the density and then we again do the normal swim up method. This method is really good. It gives us a good retrieval of the motile spermatozoa. It can be used for any kind of insemination, either conventional IVF, IUI or the ICSI. Again, many literature, if we see, it has written that centrifuge your semen sample at 300 G. What does it mean? It is a gravitational force. But again, when we see the literature about our centrifuge, it is given as a rotation per minute. So rotation per minute and gravitational force is little different. This graph shows that how to convert the gravitational force into the RPM. So based on that, any technique you are performing the lab, we should convert that gravitational force into RPM, because all the centrifuge which is available in India, it is fixed on the RPM basis. Now in case of the retrograde ejaculation, if patient comes for the retrograde ejaculation, first is we have to do the urine alkalinization, then urine centrifugation, and that sample is used for ART. So even this sample can be used for the ICSI sample. Now what we have discussed is basic sperm preparation technique. There are many basic preparation technique, but advanced sperm preparation technique which is included into ART. So what does the advanced means? This means this procedure gives a good yield, but sometimes nowadays because of the life cycle or many other factors, sperm DNA is getting fragmented. So when the sperm DNA is getting fragmented, either it hampers the fertilization, implantation. Even if it is implanted, the lady might end up into the miscarriage. So if the DFI is high, there are many techniques available, as Dr. Anusha has also told, that treat a man or treat a sperm. We should do both. First we should treat a man, and the second is treat a sperm into the laboratory. So first is the MAX, which is called magnetic activated cell sorting. Another is microfluidics. This is Zymote is another brand which is used as a filter system, and then is a Zeta method which is also used but not very popular. So in case of the Zeta, it based on the electrical charge of the sperm, and there is the electrophoresis method also. What we do in the magnetic activated cell sorting, here because the sperm, there are many factors that sperm DNA is get damaged. So one of the causes is apoptosis, because it is a programmed cell death. So to avoid this, there is a coated bits in that column. If you pass the prepared sperm, whatever apoptotic cells or the sperm which we think that it is the DNA is fragmented, that will combine with that bits, and whatever end product we get, it is a good normal morphological sperm with the less or no DNA fragmentation. And there are many evidence which says that they have checked the semen sample in the DNA fragmentation, and after the preparation they have checked the sperm DNA into after the max, so it is becoming less. So that way we can have the confidence that sperm is good, and we can use for either insemination, or we can use for the ICSI. So these are the literature which says that max preparation can avoid the DNA fragmentation and can be used as a one of the technique, advanced technique, to prepare the sperm into the ART laboratory. There is another microfluidics. This technique is based on the sperm motility. This microfluidics which is there, but the outcome is so less volume that can be used only for the ICSI. It cannot be used for the IUI, or sometimes it cannot be even used for the conventional IVF. The most popular method these days is microfluidics by a technique called zygote. In that case, the sperm volume, the final volume is more than 0.5 ml. This we can use either for IUI, conventional IVF, and for ICSI also. And these are the few literatures which says that microfluidics, again, it has, give the evidence base that it reduces the DNA fragmentation and it can be used as an advanced sperm preparation method into the ART laboratory. So this is the diagram and some video that how, because there is no centrifugation involved here, so there is no sperm fragmentation further, and we can reduce the, there is no centrifugation step here. So this is no DNA gate fragmentation, and even we routinely do in our laboratory, and we have seen that it has improved our outcome in terms of not only improving fertilization rate but the pregnancy rate. So this is the technique for this, and the take-home message is there are number of preparation methods are available, but we should see the whether sample is oligozoospermia or normozoospermia or oligoasthenoteratozoospermia. Based on the best semen analysis, we should choose the semen preparation technique in the lab, and if the sperm DNA fragmentation is a borderline or something, we should choose between max, microfluidics, and that can be useful for the advanced sperm preparation techniques. That's about my talk. Thank you.
Session is Dr. Spurti Chindamaneni, also happens to be my colleague during the times of PG. She has done her MBBS at Chelmada Anandarao Institute of Medical Sciences and DGO at Gandhi Medical College and Masters at Osmania Medical College, and she also holds a fellowship in reproductive medicine from Oasis Fertility Center. And she also has worked an associate consultant in Cloud9 Hospital, Bangalore. And she's going to speak on unruptured follicle syndrome, which is a very common problem we generally encounter in our day-to-day practice. Over to you, Dr. Spurti.
Thank you, ma'am, for the kind introduction. And a warm welcome and good morning to all the delegates. Thank you. So, my topic for today's discussion is luteinized unruptured follicle syndrome. So this term is coined in 1975, and it is defined as failure of ovulation in which, despite absence of rupture of the follicle and release of the oocyte, the unruptured follicle undergoes luteinization under the action of LH. And there is a normal production of progesterone, and the luteal phase of the cycle is normal. So what is the incidence? So I'm sure most of the gynecologists have encountered this problem in regular day-to-day practice, and even in 10%, the incidence is about 10% in normal fertile women, and the incidence is higher in the infertile women. So studies have quoted that the incidence ranges from 6 to 25%. And endometriosis is one important risk factor where the incidence in endometriosis patients is up to 35% in few studies and ranging to alarming 75% in few studies. What is important here is the recurrence rate. So the recurrence rate is 30% after one LUF, and in consecutive cycles, that is after 2 and 3 cycles of LUF, the recurrence rate increases to almost 75 to 90%. So before talking about luteinization, I want to discuss a little about the basics of ovulation. So ovulation is the most crucial event of the menstrual cycle, and it is dependent intricately on the balance between the central and ovarian hormones, growth regulators, enzymes, prostaglandins, and steroids. So when in a normal menstrual cycle, so once the dominant follicle is recruited and the dominant follicle starts producing estrogen, so with increased estrogen, rising estrogen, there is positive feedback on LH, and for LH surge to occur, the estrogen level should be at least more than 200 picograms per ml and sustained for a period of 50 hours. So once this peak has occurred, the LH has started producing an LH peak has occurred, ovulation is said to occur after 10 to 12 hours of LH peak and 24 to 36 hours after the estradiol peak. So with LH surge, there are 3 important steps. One is resumption of meiosis in the oocytes, luteinization of the granulosa cells to form corpus luteum, and it starts producing progesterone, digestion and degradation of the follicular wall to release the oocyte. So the threshold of LH for the first 2 steps is lower as compared to the third step, that is the release of the follicle. Therefore, at blunted LH levels, luteinization of the granulosa cells occur and there is elevation of progesterone, but without initiation of the process required for the breakdown of the follicular wall, resulting in the trapped follicle. So lower mean peak LH level, it occurs in the LEF cycles as compared to the normal ovulatory cycles. So what are the causes? So it is most commonly associated with patients with unexplained infertility, in endometriosis. So in endometriosis, as I have discussed, it is the incidence ranges from 35 to 70%. There is aberrant expression of various interleukins and TNF alpha, and there is decreased LSCGR, aberrant expression of LSCGR receptor expression that results in improper LH action. And also the COX-2 enzyme is aberrantly decreased in patients with endometriosis. So it inhibits the release of prostaglandins, and that is one more cause associated with it. And same as with the chronic NSAID use. So patients with inflammatory arthropathies, they take chronic NSAID use, so it inhibits, especially the COX-2 inhibitors, selective COX-2 inhibitors, it inhibits the release of prostaglandins and resulting in the LUF. So other causes are like pelvic adhesions, PCOS patients, hypoprolactinemia, and ovulation induction drugs. Studies have shown that especially clomiphene citrate, it has higher incidence of LUF because of the action. It inhibits the central E2 receptors in the hypothalamus, and because of the long half-life, there is inadequate estradiol production, and that leads to improper LH surge, and that leads to LUF. So the exact mechanism leading to LUF is unclear, but as studies have said that impaired, that is advanced mid-cycle LH surge, but low LH peak is one factor, and lower concentration of the LH receptors in the corpora luteum, and there is decreased mid-luteal progesterone levels have been observed in patients with ovulatory LUF as compared to ovulatory follicles. And others are primary granulosa cell defect and abnormalities in the prostaglandin synthesis, aberrant prolactin release, and studies have shown that 2/3 cases of LUF is associated with LPD. So how do we diagnose the LUF cases? So a serial ultrasound is required to diagnose the case of LUF. So a normal follicle, mature follicle of at least 18 to 20 millimeters is known to contain mature follicle and the serum estradiol of at least 400 picograms per ml. So we see a sonolucent halo 24 hours prior to ovulation and a cumulus-like shadow 36 hours prior. When a Doppler is done, there is rising in the PSV with low resistance index suggests that the follicle is close to rupture. So ovulation is confirmed by disappearance of the follicle or collapsed follicle or corpus luteum with internal echoes and presence of hyperechoic smooth secretory endometrium, presence of free fluid in the cul-de-sac. So in ultrasound features, for diagnosis of LUF, we see that there is no failure of follicular rupture. With the follicular wall, the thickness increases. There is thicker follicular wall and presence of echogenic fibrin-like strands in the follicular antrum suggestive of hemorrhage. There is no free fluid, but because of production of progesterone, the endometrium is echogenic. When we do a Doppler, because there is hardly any angiogenesis, the color Doppler, it shows RI is more than 0.5 and PSV is less than 10 centimeters per second. And progesterone, if the value is done, it is more than 1.5 nanogram per ml. So these are the ultrasound pictures which shows the ovulatory follicle turning into LUF. So the thickness has increased and the size is increased and presence of echogenic foci in the antrum suggestive of hemorrhage. So we differentiate corpus luteum from LUF by Doppler mainly. There is peripheral vascularity, the ring of fire appearance in the corpus luteum which is not seen in LUF. So we have diagnosed. Now the patient bombards us with the questions. When we break the news that the follicle is not yet ruptured, so counseling is important, that especially in patients with risk factors, patients with endometriosis, or when with a previous history of LUF. So one must counsel that about the recurrence rates. And once, if we encounter the patient in a natural cycle, if an LUF is seen, HCG trigger alone is sufficient for ovulation. This causes reduction in LUF by 46%. And letrozole is better than clomiphene. If we are going for ovulation induction, studies have proven that letrozole is better than clomiphene in reducing the incidence of LUF. And HMG is better than CC letroz in LUF, and that is HMG for ovulation induction, and HCG trigger is efficacious for LUF reduction. So these are certain studies, they are published. This is a prospective study published in 2009, which has studied the impact of luteinized unruptured follicle on the outcome of controlled ovarian stimulation. So is there any relation to stimulation protocol? And they have found that the incidence in CC HCG cycles is 16% as compared to sequential CC HMG with HCG it is 5%, and in HMG HCG it is 0.1%. And this particular study is also published in 2009, and they have studied particularly in PCO patients, and they have also found the same, that is the incidence with CC is more when compared to CC HMG or HMG only cycles. And they have also found that this LUF cases, they have significantly low mean mid-luteal progesterone levels and shorter luteal phase length and zero pregnancy rate. So this randomized trial, it is published in 2016. This has studied, because we normally, because of the cost ineffectiveness or because of the side effect profile, we do not generally give only HMG cycles. So we tend to combine CC with HMG or Letrose with HMG. And they have found that Letrose with HMG have got lower incidence of LUF when compared to CC with HMG. And is there any role of booster dose of HCG for an unruptured follicle in non-IVF cycles? So this is a randomized study. This is published in 2021, and they have concluded that booster dose of HCG for unruptured follicles has no benefit in ovulation triggering nor in the prevention of LUF syndrome. So is there any role of GCSF? So GCSF is a pro-inflammatory cytokine. It is found in increased concentrations in follicular fluid. It leads to increase in the neutrophils, which causes degradation of the follicular wall and subsequent rupture. So a few studies have been done. This particular study by Shibata et al. In 2019, they have studied the effect of GCSF as a potential inducer of ovulation in women with LUF, and they have taken two regimens. So one is to give 100 micrograms of GCSF 24 to 48 hours prior to trigger, or to give direct 300 micrograms at the time of trigger along with HCG. And they have found that it significantly inhibited the LUF syndrome induced by the overall ovulation induction drugs. So is there any role of analog trigger? So GnRH analog, it induces final maturation of the follicles through surge in both FSH and LH. So this is, when we see in the normal menstrual cycle, there is a small FSH LH along with that. So, and this study has shown that in LUF patients, it can be given as an option. And when we give agonist trigger, we have to give luteal phase support. And in case of persistent cycles, cycle of OCPs does. And to summarize, one must diagnose, the diagnosis should be proper for LUF, and appropriate follicular monitoring and timing of the trigger is important. And associated hyperprolactinemia, hypothyroidism must be treated. And in case of ovulation induction, letrozole is better than clomiphene citrate. And even if we see that, even after that, HMG is better. And for ovulation trigger, HCG single dose is enough. But even if with HCG, if we see, agonist trigger or adding GCSF will do. Thank you.
Thank you, Dr. Spoote, for that clear and elaborative, informative session.
A good human being. So I have, under your able guidance, my daughter, my angel, Dr. Shruti, will attain greater heights in life as well as in profession. Thank you.
Yeah, indeed, Chief. Thank you. Thank you, speakers and chairpersons, for an illuminating session. Now, ladies and gentlemen, I know the sessions are really interesting, but we would be proceeding with a ton.
Myoma, on the other hand, of any size, can impair the fertility and require hysteroscopic or resectoscopic resection. In case of multiple myomas of varied sizes, a preoperative MRI for mapping is justified. So incision, vertical, transverse, elliptical incisions, all of them cause similar blood loss because the normal vascular anatomy is distorted by the fibroid. Use of an ultrasonic scalpel and aqua dissection or careful vasopressin infiltration. So normally we just inject normal saline to prevent the side effects of vasopressin, or you can just dilute it in 5 units and 200 ml of normal saline and inject 10 milliliter per centimeter size of the myoma in the right plane. This can reduce the blood loss and improve the wound healing. So the pseudocapsule is avascular and the myometrium surrounding is hypervascular. So closure can be done in multi-layers, ensuring proper hemostasis, elimination of dead space. So baseball suturing can decrease the risk of adhesion formations, particularly when you are using barbed sutures, as it will avoid the exposure of the suture to the peritoneal viscera. So this is uterine ligation or occlusion, which is done at the origin from the internal iliac anterior division to reduce the blood loss. So this case was done just 3 days ago by me. This particular fibroid was 8 centimeter myoma. Here we have started with the retroperitoneal dissection just lateral to the infundibulopelvic pelvic ligament. So there is some controversy that the occlusion can affect the ovarian reserve or the placental perfusion. So therefore there is a shoelace technique as well. It is an alternate method that can facilitate temporary occlusion. So here we can see, oh, I cannot forward this, okay. I can't forward that video. Is there any way? Just the previous video. The back, no, not this one. Is it possible to forward? Okay, never mind otherwise. So if the endometrial cavity is breached, play this video. Close the endometrial defect using a running 2,0 polygalactin 9-10 suture, taking care to avoid suture entry into the uterine cavity in order to prevent intrauterine adhesions. Close the hysterotomy incision in layers using a 14 by 14 bidirectional barbed PDS suture number 0 on a 36 mm half circle taper point needle. So this will help in the suturing and closure of the endometrial cavity. Plan to facilitate the conception of such a woman 3 months after the surgery. So this you can see it is so close to the endometrial cavity, the myoma, and this can be closed with a bidirectional barbed suture. So adhesion prevention is, you have to adhere to the microsurgical principles, peritoneal instillation with ecodextrin 4%, surgical barriers like Interseed, Gore-Tex, Ceprafilm. There's no conclusive evidence to support the effectiveness of heparin. So installation of antibiotics in the peritoneum or hyaluronate or fibrin sheets, they are all tried, but there's no evidence. Hydrosalpinx. So this is another case report where a 35-year-old para-1 live one presented with history of infertility since 4 years. Ultrasound findings reveal retroverted fixed uterus, bilateral hydrosalpinx. So this is the video here. It's a Fitzhugh-Curtis syndrome. So the widely accepted implication of reproductive surgery is performing salpingectomies in order to optimize IVF outcomes in the patients with hydrosalpinges. A study demonstrated that oocytes retrieval done 4 to 6 months after the salpingectomy yields in higher cumulative pregnancy as well as the live birth rates. As you can see, this is the left side, huge hydrosalpinx which is retort shaped. There are bowel adhesions in the pouch of Douglas. There's a seedling myomas, right side hydrosalpinx as well, low ovarian volume, adnexal adhesions. So these were all dissected. Now endometrial polyps, multiple clinical studies have shown that surgical removal of polyps in patients prior to IVF or IUI can improve the reproductive outcomes. They are localized outgrowths of the mucosa consisting of glands and stroma. So the formation of the polyps can be related to inflammation, mechanical damage, disturbance of local hormonal environment or excessive growth of the basal layer of the endometrium, imbalance between cell proliferation and apoptosis. You have to tell this when the patient asks you, why is the, what is this condition, why is it happening due to? So they have been diagnosed hysteroscopically in 4% of all women with unexplained infertility and 15% of women with eumenorrhea. So it can affect with implantation, it can become a physical obstacle. Their studies have shown increased level of glycodelin, which inhibits the natural killer cells. So polyps are unresponsive to progesterone stimulation. This can lead to defective implantation. So this is another hysteroscopy video for polyp. So it's a gold standard for diagnosis as well as therapeutic excision of the polyp. Here we are excising it using a 5 French scissors. You can also use a resectoscope. Type of polyp doesn't matter for the recurrence, whether it is pedunculated or sessile. It can also be due to genetic aberration of the endometrial cells if it is not removed completely the stalk. Type of nature of the polyp, if it's hyperplastic polyp without atypia, it has a more chance of recurrence than that of benign polyp, that is 43.6% versus 8.3% in a study. So healing occurs within 1 month. And infertile women should be ideally instructed to achieve a pregnancy 1 to 2 months after the polypectomy before the recurrence chances can increase. Avoid the use of diathermy to prevent adhesion formation. So coming to adhesions, 30-year-old para-0 abortion, one woman came with secondary infertility with a scanty menstrual flow. So there was a history of DNC. Let's come to the video. Hysteroscopy was performed using a 4 millimeter 30-degree rigid telescope. This is the internal os. What you see is just a pinpoint. It looks like an ostia, but it's actually the internal os. So here we have done the scar excision in order to pass the telescope inside. Even though we have done preoperative preparation with the mesoprostol, the internal os is almost cicatrized, right? So these features are suggestive of Asherman syndrome, and in this particular case, it is stage 3B. Then what we have done is perform the adhesive lysis with the 5 French scissors. If you think initially, you may think that that's the fundus, but as you go on dissecting, you understand that the fundus is further beyond, and that's actually a complete obliteration of the anterior and posterior walls. So what you need to do after this adhesive lysis is just you can keep a intrauterine Foley bulb or some sort of hyaluronate gel, and this can prevent again recurrence of these adhesions. There is also a special type of a catheter, hysterocatheter, and along with that you can start oral the hormonal pills which can proliferate the endometrium, promote in the healing, estrogen and progesterone pills. So overall conception rate after the adhesive lysis is around 50%. Most of the successful cases will conceive within the first 12 to 18 months, sooner more than later. So hysteroscopy can improve the menstrual pattern, conception rates. So just note that once you have done this intrauterine adhesive lysis, patient can have ectopic pregnancies, increased risk of placenta previa, accreta, abruption. So now coming to uterine malformations, it is associated with recurrent pregnancy loss, obstetric complications, miscarriages. So the prevalence is around 4.3% in fertile women, 3.5% in infertile, and 5 to 25% in patients with RPL. So it's known that the sensitivity of the endometrium to the pre-ovulatory hormonal changes and vascular epithelial growth factors receptors are lower in the septal tissue than versus the normal. So pregnancy rates are shown to be higher after the septal resection. That is the ultrasound showing the different Mullerian abnormalities. So now this is the laparoscopic view. This was a case we have done just last week where there is a bicornuate uterus with multiple seedling fibroids. And this patient was actually posted for laparoscopy to medialize these uterine horns because there was a difficulty in passing of the embryo catheter at the time of embryo transfer. So it was almost on the lateral pelvic walls at the external iliac vessels. So what we have done is we have medialized these vessels from the lateral wall and put the Merceline tape in order to fix it after the bladder dissection and the retroperitoneal dissection. So septate uterus is associated with reproductive wastage, but you know, before operating these cases, just rule out other causes of RPL. So this is a video of hysteroscopic metroplasty where the avascular central portion of the fibrotic septum, it is divided, and after this division, the conception to the patient is advised on 5 to 6 weeks gap. So this can be achieved by mechanical scissors, lasers, or resectoscope electrodes. We use generally bipolar underwater electrodes. So here you can see clearly there is a midline septum. So here I am lysing this with the 5 French the scissors with the operative sheath. concomitant laparoscopic as well as ultrasound monitoring can increase the safety and security during the septal resection. How do you know when to stop? You start seeing some capillaries, and that is the point where you are almost at the level of the ostia. That point you must stop. See, here you can see there are some capillaries that are starting to come. This is the point where the septal resection is complete. And then you can keep a Foley's and start the OC pills to the patient. Adenomyosis and endometriosis. 29-year-old woman has presented with severe dysmenorrhea, dyspareunia, primary infertility, trying to conceive since the last 5 years. Saline infusion ultrasound revealed blocked fallopian tubes. 3D ultrasound reveals a 7.2 by 5.8 centimeter left ovarian endometrioma as well as a fundal adenomyoma of around 5 centimeters. The MRI confirmed increased junctional zones thickness, 12 mm. Laparoscopy was planned. So treatment are controversial. Medical therapies can be given with GnRH analogs, progestins, COCs, NSAIDs, aromatase inhibitors are under study. Selective progesterone receptor modulators such as misoprostol, uliprostol, they are under investigation. Drawback is only temporary relief of symptoms and lack of evidence. So this is for adenomyosis. Now this is the laparoscopic video of this case, who has presented with grade 4 endometriosis, and the patient has a large left ovarian endometrioma. So excisional adenomyomectomy involves removal of the focal lesions, while myometrectomy is the surgical debulking of the diffuse adenomyosis. Non-excisional treatments aim to induce necrosis of focal or diffuse adenomyosis through selective vascular occlusion, or by the use of focused ultrasound or thermal energy. So in some cases, a combination of surgical and non-excisional methods, okay, the ablation that is used to achieve maximum cytoreduction and reduce the amount of damage to the myometrial tissue. So remember, when you have a case of adenomyosis, the uterine muscle becomes brittle. It is more prone for rupture. So please consider the obstetric outcomes and then plan your surgery. Here we are dissecting the pararectal spaces. We are exposing the ureter to prevent its injury in the case where we have planned the cystectomy. Is there a way to fast forward the video a little bit? Yeah, so, okay. No, don't change the slide. Fast forward the video. So here I am opening the left ovary. So you can see there's a clear-cut chocolate cyst. So we are going to peel that away. So the only thing is it can cause a little bit drop in the ovarian reserve. So that is why we prefer now carbon dioxide laser. So conception can be planned as early as 10 to 12 weeks. Endometriosis, you can use CO2 laser vaporization. So the endometriotic lining can be removed or fulgurated. That's how the laser works. A study concluded that excising deep endometriotic lesions can improve IVF outcomes. PCO, just do the laparoscopy only when it is justified. For example, the patient has uterine malformation concomitantly with the PCO or for tubal patency diagnostics. So just ensure that the patient is selected carefully for this drilling. Don't just do it as a routine. So obesity, low basal LH levels, that is less than 10, and marked hyperandrogenism, high AMH more than 7.7 ng per ml are predictors of poor response. So 40 watts, 4 seconds, 4 punctures per ovary. Cool the ovaries by dipping in normal saline. So it is crucial, this is the conclusion, it's crucial to keep in mind that regardless of the underlying illness, wisdom lies not in knowing when not to operate, when the risk outweigh the benefits. So thank you for your attention. That's it.
Is there any other way that we can, like supposing we do a balloon tamponade of the vessel during surgery and then maybe release it, would that be helpful, using an interventional radiology for that? Would that be helpful too?
Definitely. If a tamponade is advised, there requires to be a large setup. It's a big facility, and the cost to the patient is also more. So if you can reduce the financial burden of the patient by just putting a simple shoelace knot, it will provide for the temporary occlusion, and you can just pull it out and ensure that okay, all these controversies of the placental perfusion, these are not going to affect the patient.
Yeah, thank you.
Thank you.
Any questions from the audience? So thank you so much, and we'll move on to the next speaker.
Yeah, good morning, everyone. Thank you for inviting us to chair the session. Next speaker is Dr. Shravya Talupureddy, and she is MBBS, OBG, FNB Reproductive Medicine, Senior Fertility Consultant, Ferty9 Fertility Center, Secunderabad, FNB Reproductive Medicine, Milan, Bangalore, MS OBG, Government Medical College, Vijayawada, MBBS, Usmania Medical College, Hyderabad, Academic in charge IMA short-term and fellowship courses Ferty9, member ISAR, IFS and FOXY. Dr. Purnima Natkarni Best Paper Award in ISA 2019, Division 2019, ISA 2020, conducted and coordinated advanced ART and basic fertility courses for clinicians from various countries and areas of interest, recurrent implantation failures and PCOS.
Thank you, ma'am, for the kind introduction. You find it boring, but yes, we need to know much about law, especially for ART practice in the era of current litigation. So, infertility, according to Ernst & Young survey done in 2015, 8 years ago, around 23 million people suffer from infertility in India. So, to regulate the ART practice, the government, along with many professional bodies, has been putting tremendous efforts, and the fruit of this tremendous efforts over 20 years is that we have a law finally. On 20th December 2021, the Government of India released a Gazette notification regarding the ART Regulation Act. On 26th December, we were given out a Surrogacy Regulation Act. And to guide us in this Regulation Acts, we have been given ART rules and surrogacy rules in the month of June 2022. So, what does the law say? We'll understand the law through different case scenarios. So here is our first case scenario. Mrs. X, aged 25 years, is married to Mr. Y, aged 27 years. And the couple are trying to conceive since the past 2 years. She is a case of polycystic ovarian syndrome. So we are planning to give her ovulation induction. So does your clinic require ART registration? So the law states that what is ART? So ART, according to law, is defined as any attempt to obtain a pregnancy by handling sperm or oocyte outside the human body and transferring the embryos or the gametes into the reproductive system of a woman. So any clinic which handles this procedure is called ART clinic. So according to this law, for simple ovulation induction, you need not have a ART registration. So if you are planning for IUI or IVF or other ART services, definitely your clinic requires ART registration. So what are the authorities that regulate ART? We have a national ART board, state ART board, and also national ART and surrogacy registry, and also the appropriate authorities. So where do you register your clinic? We have a website, artsurrogacy.gov.in. So you can log into the website, and the registration process is fairly simple. You fill out a form Form 1, wherein you apply for registration, and your clinic premises will be inspected, and you will be given a certificate of registration in the form of Form 3. So your registration is valid for a period of 5 years, and every application for registration should be accompanied by an application fee of 50,000 for level 1 and 2 lakhs for level 2 clinic. So moving on to the next scenario, we have a 26-year-old PCOS. She was hyperstimulated on ovulation induction with gonadotropins, and Dr. X has a certified level 1 clinic, but he also has an IVF setup. So he is planning to convert his IUI to IVF. So can he do it? So what are the levels of clinics according to ART law? We have level 1 clinic wherein IUI is done, level 2 clinic where we can do surgical retrieval of gametes, handle oocytes outside the body, IVF ICSI, that is fertilization of gametes, embryo transfer, and cryopreservation of gametes or embryos. So what is level 1 ART clinic? The mandatory staff requirement is just one minimal gynecologist with a postgraduate degree in obstetrics and gynecology, and the minimum equipment required is a microscope, centrifuge, and a refrigerator. Level 2 clinic, yes, you need a team, a multidisciplinary team of gynecologist, andrologist, embryologist, counselor, anesthetist, and a director. I would not be going much into the equipment because it was already dealt with in the IVF lab setup. Moving on to the next case scenario. A couple, 40-year-old lady and 56-year-old gentleman approached to you for fertility treatment. They quote regarding a case which happened few years back when a 70-year-old lady delivered. All of us have seen it in news. So they ask, why can't we go? Can we go ahead? What do you say? Earlier, there was no law. We had only ICMR guidelines regulating our practice. So ICMR guidelines, established guidelines, will help us in ethical practice. But law is different from guideline. Law mandates that if you cross the law, you will be punished. So according to the current ART law, we can provide ART services to a couple or a woman who is between 21 to 50 years and a man between 21 to 55 years. So what are the other duties of ART clinics and banks? The clinics shall provide professional counseling. They shall ensure confidentiality of the couple or the women, except in cases where you have to give out the data to National Registry, and also in case of medical emergency on application from the couple or on a legal notice. The clinic should maintain a grievance cell, provide ART services to the age group mentioned above, and also provide discharge certificate for all the procedures done at your clinic. Moving on to the next case scenario. We have a couple who are both O positive blood group. They took treatment, IUI with husband sperm 5 years ago. But now they have filed a case against you for placing a wrong gametes as the child has O negative group. Now the court has ordered you to provide the case history. So what are the regulations regarding maintenance of records? According to the ART law, we have to maintain records for a period of 10 years duration. And these records, in case your clinic closes before that time or beyond 10 years, should be transferred to the National Registry. So when we talk about records, what are the things? One, we have to give information to the patient regarding all the procedures done at your clinic and even before the treatment starts. When you look at it, you have to start off with the procedure, what is the limitation, what are the charges, what is the success rate, side effects, availability of counseling, what is the rights of unborn child, and you need to maintain registers at your clinic. So regarding the consents and documentation, consent is a cornerstone for our practice. Informed and written consent should be taken prior to the starting of procedure in a language the couple can understand. And proper documentation explaining the risks, success rates, alternate procedures available should be maintained, and also progress notes also should be maintained. So these are the forms for a level 1 clinic that should be available. Form 7 is regarding the IUI consent with husband sperm. Form 8, IUI with a donor sperm. Moving on to the next case scenario, we have Mrs. Sonu. She is para 2 live 2. She had previous cesarean sections, both female child. She approaches you for ART with a desire to get a male child. She argues that all the celebrities have made children to ART, why not for me? What do you explain to her? The ART services are covered, are subject to provisions of the PCP&DA Act. So we should not knowingly provide, prescribe or administer anything that shall ensure or increase the probability of an embryo that shall be of a particular sex. Sex selective ART is punishable under law, current ART Act, with imprisonment of 5 to 10 years or 10 to 25 lakhs or both. Moving on to the next case scenario, we have Miss Ria, 21-year-old lady. She wants to donate eggs to her sister. Her sister has a premature ovarian failure, but Miss Ria is unmarried. She wants to donate eggs before her marriage and is ready to sign any document to avoid legal complications. So would you consider Miss Ria? What are the regulations with regard to donors and ART banks? All the donors must be sourced from an ART bank. So if someone is willing to donate, they should come through the ART bank. And what is the age criteria? Males for sperm donation between 21 to 55 years. Women for oocyte donation between 23 to 35 years. So sadly, we cannot take Miss Ria. Sperm or oocyte of a single donor should be allotted to only one couple. And oocyte donor can give oocytes only once in a lifetime, and we can retrieve only 7 oocytes in one stimulation. Moving on to the next case scenario, we have Sonia and Rakesh who have been married for 5 years. Sonia has primary ovarian insufficiency and Mullerian agenesis. So the couple's parents are insisting for an heir. So what do you advise? Ideally in this scenario, the lady has no eggs, no uterus, but the man has sperm. So ideally you would probably advise a donor egg and a husband's sperm with a surrogacy. Can we do it? So womb on rent. Probably we need to get sensitized regarding this issue. So surrogacy requirements for the couple. For the couple, we have a certificate of essentiality and a certificate of eligibility. So certificate of essentiality is related to certificate from the district medical board regarding their proven infertility, order of parentage and custody of the child passed by the magistrate court, and also insurance coverage for a duration of 36 months. Certificate of eligibility is an Indian citizen, married, 5 years clause has been removed in the current Surrogacy Act, wife aged 23 to 50, husband aged 26 to 55. And they should not have any surviving child, with a few exceptions being the child has a fatal disease or child is disabled for life. And they should not have a surviving child, be it adopted through surrogacy or through any way. So what are the requirements for a surrogate mother? Surrogate mother is someone who is a willing woman, married, with a child of her own and age group between 25 to 35 years. She should have a certificate of medical psychological fitness, but she cannot provide gametes of her own and only once in a lifetime. And regarding the case that we have discussed now, there is a new amendment which was given on March 14th, which states that couple undergoing surrogacy must have both gametes from the intending couple and donor gametes are not allowed. So a single woman in the exceptional scenario is being single woman who is a widow or a divorcee undergoing surrogacy must use self eggs and donor sperms to avail surrogacy procedure. So sadly, this case we cannot advise her any option except for adoption. Right now, many people are approaching the Indian courts regarding this issue. Probably we will have future clarity in the coming years to come. So regarding the offenses and penalties, we have been telling law. So what are the offense, what is the penalty? Offenses could be anything from sex selective ART to sale of gametes to misuse of gametes. So the first contravention would be a fine of 5 to 10 lakhs, but the subsequent contravention you will have a fine of 10 to 20 lakhs and imprisonment of 3 to 8 years. So I will end my talk with a saying from Plato: laws are of no use because good people do not need laws, while bad people will find a way around laws. So one needs to be true to our own conscience and take the right decision. Thank you.
Dr. Shravya, excellent, excellent. This is the topic that was needed today, I think, because no one should get into trouble. All the laws are for us, I think so. And you have explained in a simple way and using the case scenarios, and it was very clear for us. It was excellent. Thank you.
Thank you.
And it's my pleasure to welcome Dr. Jyothi Budi. I congratulate you. You are a charisma by seeing the crowd and the delegates here. She's very down-to-earth person, helpful, very helpful, warm and affectionate. Thank you for the opportunity. And to 49 fertility centers and 7 centers across Telangana and Andhra Pradesh, ISAR Telangana Joint Secretary, ISAR Scientific Committee 2020, MS in Reproductive Medicine UK, Certified Clinical Embryologist, chapter contribution to several books, invited guest lecture at international and national conferences, presented many papers at national and international conferences, Times Best Fertility Clinic in South India 2021, emerging, Times Excellency Award 2018, the Best Fertility Clinic in 2018, HMTV Best Health Services Company Jury Award, BEA 2018, Indian Excellence Award 2017, National Healthcare Excellence Award 2016. I welcome you, Dr. Jyothi.
Thank you so much. At the onset, I would like to thank all the delegates here. I'm so overwhelmed today. Thank you so much. Amidst the Sunday busy schedule, you're all here. So we value your time, and we have wonderful national speakers who have come all the way here. So I will not take 30 minutes. I'll try to wind up in 20 minutes and give time for our national speakers to move ahead. So they say
it takes 8 years to be a gynecologist. But to be the best version of our own self, it takes lifetime. In this space of making of our own self, there are lots of mentors, seniors, or many teachers here who I have a lot of respect. It may be our parents. So with a big salute to them, with a bowing hand, I start my presentation. I'm talking about initiation of IUI with ovulation induction and folliculometry. So we'll start with a real-time case scenario, which happens day to day in our practice. Just to make a more connected, I've chosen an arbitrary name, Sagar and Shilpa. These loving couples have, she is 32 and Sagar is 36 years. They're married for 10 long years. And they're very anxious to have a baby. Since 7 years, 7 long years. Everything is fine in this couple. Husband's sperm parameter is perfect. Her tubes are patent. But only problem what this Shilpa has is, she has irregular cycles. Once in 3 to 4 months she has cycle. So this is the most common scenario what we see in our in a gynec OPD. So every time I feel patients are our best teachers. Whenever we see a patient, we learn a lot from them. So from her, I learned 2 important things. What are those things what I learned was, first thing was, why did it take 7 long years for Shilpa to conceive? Only problem she has is irregular cycles. Then I was wondering what went wrong. I just went 2 pages and I started seeing her case notes, what happened for the 7 long years. Again, end of the day, when we talk about folliculography or folliculometry, physiology plays a very pivotal role. So after a beautiful talk by Dr. Shravya, which was, challenging cases, I'm taking into physiology, little subtle subject, but without understanding physiology, we can't be good in ovulation induction. So it's so important to understand little basics about physiology. So whenever I think about physiology, I have fallen in love with this subject. Because it's so important what happens in the ovary day-to-day basis. It is something very, I call it as a story of scientific romance. So what actually from the patient, what does patient want? From patient perspective, they want fast success rate with less side effects. This is what they want. So from Shilpa's case, what I learned 2 things was, whenever a lady comes with irregular cycles, say suppose she has come to me on day 2, we start her ovulation induction medication. We call her usually on 7th or 8th day. Then we do a scan. When we do a scan, what do we want to see? We all like to see a selected follicle. A follicle, at least it is around 12 mm. But if at all, if there is no follicle on 7th or 8th day, if all the follicles are less than 10 mm, what do we do? Okay, there is no dominant follicle for you, you come again next cycle. Now in case like Shilpa, if we don't give a withdrawal flow, when will she come back to us? She'll come after 4 months. So we are losing 4 months, 4 precious months in her. So we as clinicians should be able to find the threshold dose for that woman. And also there is something called as window period, very, very important. These 2 small concepts, I won't bore you. I'll try to, in 5 minutes, finish this concept, which is very important. So from times immemorial, from decades, 20 decades, everybody knows the study in 1996, Tomilson et al. To today, everybody knows to increase the clinical pregnancy rates. With 1 follicle, it is 8.5 pregnancy chances. When it's 2 follicle, the success rate doubles. 3, they say triples, but I don't suggest 3. We have to plan for 2 follicles, but for whom I will be telling you in later slides. Of course, after 3, it doesn't increase at all. So 2 is the ideal number. Now, what is this window period? When you see, every house has a window. Okay, video. Okay, so every house has a window. Even ovaries have their own window. And the window doesn't open every time whenever we want. So why do we all know then we stimulate the ovary on day 2, 3 or 4 or 5. Why do we do it? When a lady comes to us on 14th day, okay, she has come, she doesn't have time, shall I stimulate her ovary? Have we ever done that? We don't do it. Why is it? It's because if you see physiology, the window of the ovary is open only at that point of time. What is that point of time? It is the menstruation. See, there is an ovarian cycle, there is a uterine cycle. Creation of God is so nice. Whatever is happening in the ovary, it is not seen until we do scan. But in physical way, the endometrium sheds and we can see its menstruation. So window period, whatever happens in the ovary synchronizes with the uterus. So that is the time, a menstruation, what we call. So if you see this slide, a lady with a normal reserve, window period is during menstruation. A lady with PCOS, she has a prolonged window period. That's the reason even in PCOS, we can start the stimulation little later. In women who has very less reserves, 1 or 2 follicles, window period is shortened. What is this window period shortened? You see on a day 2, if you do a follicular study on a lady with less reserve, you already see one of the follicle dominant. That means to say HPO axis is starting faster. And already on day 2, it is a 14 mm follicle. Most of the time we see what is this. That is the first time when we catch a lady that, oh, this lady is, ovarian age is advancing. If it is more than 10 mm, ideally for a normal responder, on day 2, the follicles should all be quite less than 10 mm. But if a lady with 2-3 follicles and one follicle is already dominant, 12 to 14 mm, then her window is shortened. She comes, usually if you see her history, she comes with shorter cycles. From 30 it has become 24, 25, 15. That means luteal phase is fixed, but her follicular phase is shortened. And these ladies, 7th or 8th day itself, they ovulate. So it's a challenge for us. And what happens in folliculometry? If you see the follicles there on day 2, we would always like to see a follicle which is very quiet, no activity at all, resting phase of the follicle. Each follicle is less than 10 mm. And then you don't like to see a dominant follicle on day 2, right? If you see the endometrium also, endometrium will not be triple line, it will be shedding. It will be less than 3 to 4 mm. That is what we see in a uterus. Then ideally on day 2, if you have to combine the ovarian cycle with the hormonal cycle, if you have to do a estrogen and a progesterone test, study, estrogen is less than 50 picograms per deciliter, progesterone is less than 1 nanogram per deciliter. That is the lowest level of hormones in the body, and all the follicles are very quiet. And then what happens whenever the estrogen and progesterone is so low, the endometrium shed because it's a withdrawal of hormone, and then HPO axis starts pulsatility, and then one of the follicle becomes dominant. If you see on day 5, the follicle which was less than 10 mm on day 2 becomes around 10 to 12 mm. That means selection has started. Day 5 or 6, selection starts happening. Then what happens on day 5? When a follicle gets selected, it starts producing estrogen. It becomes an estrogen microenvironment. So estrogen which was 50 has become 75 to 100 now. Whenever estrogen becomes little high, this dominant follicle wants to be a queen. It does not want other follicles to follow. So it sends a negative impulse to the brain, HPO axis, that is called as, the negative pathway of the estrogen. What it says to brain is, hey, I'm there here, I don't want other follicles to come, FSH, please come down. Immediately FSH comes down. So the other follicles, if you see on day 7, which were supposed to become dominant follicle, they go for atresia. Only this one becomes, starts growing 1 to 2 mm. See example in other animals like cows, cats, dogs, elephants, this negative inhibition is not there at all. That's the reason they get 6 or 7 follicles, and that's the reason they have multiple pregnancy. And thanks to our uterus, it can bear only 1 or 2 kids. So this negative pathway is so important to cause monofollicular growth of the follicle. Now on day 7, the follicle is already around, it's like around 12 to 14 mm. This too starts working. It starts increasing estrogen itself. Here if you see on day 10, follicle becomes around 14 to 15 mm. Now estrogen which was 50 on day 2 has become around 200 picograms per deciliter. All the books say, Spiroff, every book says 200 picograms of estrogen sustainedly maintained for 50 hours the LH surge happens. This is the, one point which triggers the LH surge. So by then it is already 2.5 days. So from 10th to 12th day, the follicle has become 18 mm now and it is ready to rupture. So once it ruptures, if you see in this video, okay, there it is. Yeah, so the follicles escapes from the primary oocytes escape from the follicle and there is a Graafian follicle. If you see, just I'll fast track this. This is how I call, to understand easy, a marble in a balloon. The marble has to go outside now. So the follicles come and the balloon opens up and the primary oocyte which goes outside the ovary and it is picked up by the fallopian tube, and then this primary oocyte, if you go in depth, how fast it multiplies. The Graafian follicle which is covering the primary oocyte is washed away by the tubes. That is what we do in IVF. We take the primary oocyte, wash it away. Then there is resumption of meiosis. The metaphase 1 oocyte becomes 2, so immediately it's done, and then there is, if there is a pregnancy happens, that's what happens in the tubes. Now next is about threshold dose. So on day 2, if you see all follicles, you don't see all follicles same size, 4 mm, 5. They are different. One may be 2, one may be 3, or one may be 5, 6, 7. So each follicle has their own threshold and its own size. See, what is threshold? Threshold is very important. If you see the follicle here, they all have receptors. The larger the follicle has more receptors. What is this follicle? This follicle has more FSH receptors. It means it has the lowest threshold. So each follicle has a threshold dose. And then the threshold dose, once it is attained, how is threshold dose attained? In the body, because of the HPO axis, when FSH pulsatile is there, the threshold dose is attained in most of the ladies. But in some ladies, when they don't ovulate, we find the threshold dose for them. We either give letrozole or clomiphene or gonadotropin, depending on so many other factors. So finding the threshold dose for that ovary, for that lady, is the most challenging step in ovulation induction. Our whole responsibility is to find the threshold dose for that follicle. So once the threshold dose is met, say suppose for some women it may be 5 mg letrozole, for some it may be 2.5 mg, for some it may be 7.5. So this is very important to find the threshold dose. Once threshold dose is met, there is rescued by the FSH. And then the selection happens, the follicles start growing, and rest of the follicles go for atresia. So now important concept of this threshold dose is in the window period, very challenging. If the threshold dose is met of one follicle, we get monofollicle. If the threshold dose is met for 2 follicles, we get 2 follicles. But it's so important, especially in PCOS, most of the follicles have same threshold dose. They all go together. You give a dose, all the follicles come up. So it's very important to find the threshold dose. Now individualizing the therapy is the need of the hour. How to find the threshold dose? Each ovary is different, so it depends on the age of the woman, the AFC count, her AMH, and what was the previous response. Whenever we see a woman, please make sure you go back to her history and see previously what was her threshold dose. If you have seen a beautiful follicle, then you already know the threshold dose. It becomes very important for us. And then BMI also plays a major role. Now, what is an ideal protocol for IUI? How I do is, I first see women whether she is ovulating or she is not ovulating. If she is not at all ovulating, she is having irregular cycles like Shilpa, my idea is to give one follicle, monofollicular. If a woman is already ovulating, that means every month she is releasing one egg already. What am I doing? I try to get, especially in unexplained infertility in endometriosis, I try to get 2 follicles for her to find the threshold dose. So selection, of course, does matter, whatever said and done. See, in IUI especially, best success rate is for a younger woman with an acceptable AFC count. Most of the time tubes are patent, but when we do the scan, we see the tubo-ovarian relation is altered. There is a lot of adhesions. So very important even, scan. And of course, male factor plays a very important role. And then less success in little older women with less AFCs, and though tubes are patent, but still a lot of adhesions are there. I think Dr. Raji will be covering all about IUI optimizing. I'll stick on to ovulation induction itself. So what about when should we do the first scan? Very important. See, 10 years before, when I started my center, I didn't have scan. at the very beginning. I was sending all my patients for one of the, one of the radiologists to do a scan, day 2. They were refusing me. How can you do scan for day 2? They are bleeding. Please don't send her now. Folliculography, you call only on 10th day. I was, no, we are fertility expert. Day 2 is very important for us. So in 10 years, so much has changed about day 2. I think if we take a raise of hand, everybody wants to do day 2 scan, right? Most of the time, I think we have a scan machine with us. We should do a day 2 scan. Basic it is. Why is it so important? If you see on day 2, all the follicles should be quiet. There should be no more than 10 mm. Ideal time to start the ovulation induction. Say suppose in this woman, she has already a follicle which is 14 mm. She has come to you, you have seen her on day 2. What do we do now? Ideally, I would like to postpone the cycle. I will tell her there is some follicle. I don't know whether it's follicle or cyst. But then she says, no, it's very important. My husband has come only for 1 month from out of country. Please induce, do something. Then what should I do is, I should find out whether it's a secretory follicle or not a secretory follicle. How do I know that? We know that on day 2, estrogen is less than 50, progesterone is less than 1. I do these 2 simple tests, call her next day. I tell her, okay, your both hormones are okay. This is a non-secretory cyst. It is not secreting, it's simply sitting there. So then I start my ovulation induction, call her on 10th day. Now on 10th day, I should on day 2 mark this follicle as non-secretory. On 10th day, she comes to me, and if I see this follicle, already follicles are there, then we give HCG trigger later, it won't rupture. This is because non-secretory follicle. On 8th day, I should see another follicle along with this which is growing up. That is very important point. And then, of course, when it comes to, there are a lot of armamentarium of ovulation induction. If you call who is the best, everybody is good in their own way. Of course, success rate of IUI, if you see compared to oral ovulation, gonadotropins, you add, definitely it increases the success rate. When it's come to ovulation induction, what I would like to announce today is, see, all of us gynecologists, you are the first place where an infertile lady comes to you. So 80% of the women needs ovulation induction. So this still has it plays a major role like a queen. So this ovulation induction is very important. And then clomiphene citrate. Ideally we start with 50 mg, and then on day 7 if there is no dominant follicle, we can increase it to 100 mg. We should not waste time for her. Why is this? There is something called a stair-step protocol. You call her on day 3, give 50 mg, call her on day 7, the threshold dose is not met. There is no dominant follicle. Now you can increase it to 100 mg itself. Why do you want to waste your time? Again, after that, call 7 days later. You see, if there is no dominant follicle, you can make it 150 mg itself. So in this stair-step protocol, what is the difference? It doesn't increase the pregnancy rate. It shortens the time to pregnancy. 3-4 months, you are not wasting your precious months. That's what all the study says. About tamoxifen, I won't talk much because letrozole is already there. So efficacy is similar to clomiphene citrate. What about letrozole? There are lots of ways of using letrozole. The regular standard way, I have one short 5 protocols what I will just explain you. First is the standard protocol where 2.5 mg they say according to the academics, but I usually don't use 2.5 mg. I start with 5 mg. So 5 mg, this is another protocol, 2.5 mg if you give. She comes on 7th day. Please don't tell her you don't have the threshold dose. If it's not met, if there is no dominant follicle, don't tell her to come back again. Extend it, give for 5 more days and see. Then 3rd protocol, start with 5 mg itself. And then 4th protocol is, in some ladies where threshold dose is not met, you can increase the dose 2.5, 2nd day 5, then 7.5, and then make it 100. And then say suppose in this woman all 4 protocols have failed, there is no dominant follicle at all. Go with the higher dose, 7 point, because in her 7.5 mg would be the threshold dose, because 5 mg also she has not got dominant follicle. So start with 7.5, but not for every woman. First time you see, please don't start with 7.5. When it is failed, then that's the last chance what we have. You can go with 7.5 mg. So then now everything is done. Letrozole I have used everything. She's still not ovulated, what do we do next? Else is available? Second line therapy is gonadotropin. In gynecologist level, we are little hesitant to start off gonadotropin because of risk of OHSS. So I was thinking, most of the time we always in all seminars we compare clomiphene with letrozole, which is best. But I thought, let us see if they work as friends together, what can happen. So some studies says even before going for gonadotropin, there are 3 case scenarios where you combine them as friends. One case scenario is when a woman is not ovulating with letrozole, combine with clomiphene. Most of the studies says whoever is not ovulating, we have a word called as clomiphene resistance, but we still don't have a word called letrozole resistance. So you can combine, sometime ovulation happens and then we can go ahead. Then second scenario, when insulin resistance, still clomiphene has a role. Third is unexplained infertility. When you want little 2 follicles in the window period, you can give both the medication. Now gonadotropins, because of the paucity of time, I'll just go ahead fast. When you start gonadotropin, very important is in a window period, don't give very high dose. That is the reason where all the threshold dose of all the follicles are met, you will go with OHSS. If you want to see FSH or HMG, which is better, both Cochrane says both are equal. Whether recombinant or urinary, there's no clinical difference in pregnancy rates. And daily using, once you start FSH, should you continue it daily? Study says if you continue, clinical pregnancy rates are better. Antag I was using before, but it's not improving pregnancy rates. We have stopped, even the study says same. About this one slide, I will just brief you with. Very beautiful normogram. How to start the dose of letrozole. We all know how to say, suppose a woman has come, she is 55 kgs and she has 10 follicles, 75 is her first dose. Same 55 kgs woman has 20 follicles, then 50 is her starting dose. This is a normogram where you can choose which, thanks to Jatin Shah sir, this is a slide from your own presentation. Thank you so much. Yeah, so step-up protocol. Ideally, if you want to use gonadotropin, start with lower dose, 50 units is ideal, but it's very expensive. If you have to use 50 units, you have to go with a recombinant pen. It becomes very expensive for our country. Most of the Western people, where they have a recombinant pen, they use this protocol. In our country, we use standard step-up protocol using 75 gonadotropins and then call them on 7th day. If there is one dominant follicle, it means threshold dose is met. If there is no dominant follicle, we have to increase the dose to 150 and call her again to see whether the threshold dose is met. So everything depends upon the threshold dose of the follicle. And then now chronic low dose, they say for PCOS, you give a very low dose for longer time, 80% of the women will ovulate, and even clinical pregnancy rates are good in these ladies. So then there is all step down. I won't go into depth because we don't use it now. It causes a lot of OHSS and multiple pregnancy risks. There are many protocols if you have to say. But in our Shilpa, what happened was, she was PCOS lady. For her, what we did was, we started with the letrozole and then continued HMG, she conceived. But if it is unexplained infertility, I always start with gonadotropin in the window period, so that if I put gonadotropin on day 3 and day 5, I may get 2 follicles. So this is, and then every time we concentrate on the follicles. What about endometrium? Most of the time follicle is 18 mm, endometrium is still 5 or 6 mm. So how do we do? If you delay 1 or 2 days, make the follicle 20 mm, endometrium may catch up. That is the first way. Second is, you should know whether a follicle is culprit or endometrium is culprit. Say suppose follicle is 18 mm, endometrium is 6 mm. I do a test, again estrogen. Estrogen, if it is 250, that means the follicle is mature, it's releasing hormones. But endometrium is the culprit. Even with 250 estrogen, endometrium should have been 7 mm. It is not working well. Then I subject them for hysteroscopy. That means to say there is something issue in the endometrium. If the estrogen level is 100 or less, then I know follicle is the problem. It's not releasing estrogen. So I give more time for endometrium. Now, this is one typical example. This was some 3 years back, I got this prescription. They have started letrozole. They have started with 5 mg 3rd, 4th, 5th, 6th, 7th day. Without doing follicular study, they have started progynoa, estrogen also. So what wrong it is here? All threshold dose is not met. You are already suppressing. See, once in letrozole you are giving and causing anti-estrogenic effect. FSH start pulsatiling. By the time it is getting selected follicle, you are dumping estrogen. So follicle gets confused. So very, very important, wrong usage of estrogen can even hamper the normal folliculogenesis. So in hypo, we have to use HMG preferably. So conclusion slide is gonadotrophins definitely gives increased pregnancy rates in IUI. So when to use gonadotrophin, only thing we should remember is window period. We should not overshoot the dose, and that is the only time when if you, all the follicles get selected. So thank you everybody. So they say spirit of physician is to be a permanent student of science, because the absolute truth of today is a relative truth of tomorrow. Thank you so much.
Thank you, Dr. Jyothi. IUI, ovulation induction and folliculometry, it was very crystal clear, given us very practical points, and your slides are also excellent. It was an excellent presentation. Thank you so much. Any doubts?
Hi ma'am, I have 3 doubts. One is whether the cyst on day 2 is functional, non-functional. Can we see the endometrial thickness and decide it, or it is needed to do only estrogen?
On day 2?
Day 2.
Okay, very valid doubt. Day 2, usually endometrium should shed. It should become less than 3 mm. It's a very valid point. But in, say, suppose PCOS, what happens? 3 months she doesn't menstruate at all. So endometrium is so thick, these people will have cystoglandular hyperplasia, along with Steen-Levitard syndrome, we used to call it before. Big ovary with irregular cycle, thick endometrium. So in most of these PCOS, what happens on day 2 also, endometrium is 7 or 8 mm. It doesn't shed properly. So as a marker, according to any studies, endometrium can't be taken totally to find out whether it is totally in the, it is in the resting phase. Okay. So combined together, as a clinician, the more scan we do, we know, okay, the follicles are all white, endometrium is white, so I don't want to do hormone test. Yeah. Ideally, I don't believe in doing too many tests. But in certain situations, when we need to know what the diagnosis is, these come to play.
And one more doubt. These gonadotropin injections, do you give daily or alternate days in any protocol?
I will be very honest here. I don't give daily, because cost also plays a major role. If you weigh and balance, giving daily, I started for few patients long time back, but the expenditure what they have and they don't become pregnant, it's like IVF money and they don't become pregnant. We know for ovulation induction, so I ideally don't give
if you give 1 or 2 injections also, they are ovulating.
What I do is ideally I start with oral ovulogins, because it sensitizes the gonadotrophins. The dose becomes, the requirement dose becomes very less. So I combine most of the time with letrozole, and then once the follicle is dominant, then I add the gonadotrophins.
One more doubt, ma'am. Does Proguanil has no role, madam?
No, not exactly no role. I'll come to it. Proguanil means estrogen basically. So estrogen has a role. It's like a weapon. You should be very strong in your academics. If you see a dominant follicle, already selected follicle, only endometrium is a problem. Again, when it go to academics, it becomes very debatable. Most of the study doesn't support estrogen. But if you know this follicle is dominant, it's doing very well, ideally the endometrium should catch up. Estrogen in the follicle would have been 250, endometrium should have come. There is some issue. So ideally, it's better to avoid estrogen. But, so many times it happens that, okay, 1 or 2 days we will give. But again, it's always a debatable topic. Yeah, thank you. Thank you.
Ask you, how's the Josh? How's the Josh? Thank you.
We apologize for the inconvenient understanding. Our next session for the day is all about decoding PCOS and optimizing IUI outcomes. To chair the session, we would like to invite on stage Dr. Balamba Madam. She is former HOD of Gynec, Superintendent at Government Maternity Hospital, Nayapur, and Additional Superintendent. And we would also like to invite next Dr. Welcome, ma'am. Next, we would like to invite Dr. Sirisha Mantena. She is Assistant Professor at Kakatiya Medical College, Hanmakonda. She is General Secretary, Warangal Obstetric and Gynecological Society. She is also a State Council member for IMA Warangal. She has made publications in various journals, and her interested fields are in high-risk pregnancy, adolescent health, and adolescent counseling. Welcome, ma'am.
She has a fellowship in reproductive medicine, infertility training at Brussels, Belgium, diploma in gynec endoscopy here, Germany, diploma in USD, Chennai, editor decision making in infertility, director International Fertility Academy, editor decision making in infertility.
నా పేరు డాక్టర్ అపూర్వ పల్లం రెడ్డి. ఐ థింక్ కొంచెం ఇన్ఫార్మల్గా ఈ కాన్వర్సేషన్ ఉంచేదానికి ఐ వుడ్ వాంట్ టు కంటిన్యూ విత్ a little bit both in English and Telugu. I hope that is all right with all the audience here. I think all the speakers who have spoken before me have made my job very, very easy because next 20 minutes low, most of them have covered about it in their topics, but I will try and assimilate all of it and put together. Resistant PCOS. So this is a concern for most of us. Ovulation induction anedi, sorry. One second. So whenever we decide that okay mana dagariki patient ochindi mana medications ivali ovulation induce cheyali ante, how do you take that choice? Do you just flip a coin and say that okay first patient ochiniki clomiphene citrate istamu, next patient ochin valliki electrolysis istamu, you know, if it's heads I am going to start with 2.5 mg or tails I am going to start with 5 mg? It's not like that. We come up with a strategy that what kind of drug and what is the dose that we are going to give. Dr. Jyothi has Dr. Jyothi had very clearly elaborated. I think ovarian resistance or clomiphene citrate resistance anedi మనం decide చేసేదానికి ముందు we have to see what is the dose that was given to them in the past. 1 year back, 2 years back, in case if they have taken medications, 5 mg of letrozole తీసుకున్నారు, they have not ovulated, please don't go ahead and start with the same medicine again unless there has been significant weight loss or they have had other adjuvants in the course of point, they have made some amount of lifestyle changes. In case if they have done all of this, there is no harm in starting that dose all over again. But in case if they have not, malli ade dose repeat cheyadamu, malli months on months waste cheyadam anedi, it is not a great way to start. Now sometimes mana all medications anni ichamu, despite that ovulation doesn't happen, we know that we are in trouble. What do we do next? అసలు ఈ ప్రాబ్లం పీసీఓ పేషెంట్స్లో ఎందుకు వస్తుంది అనేది మనకు అర్థమైతే దెన్ వీ విల్ బీ ఏబుల్ టు కైండ్ ఆఫ్ కమ్ అప్ విత్ అ బెటర్ సొల్యూషన్ ఫర్ దెమ్. మనందరికీ తెలుసు మోస్ట్ ఆఫ్ దెమ్ ఈవెన్ ఐ థింక్ ఏఎంహెచ్ అన్న టెస్ట్ రావడానికి ముందు ఎల్హెచ్ ఐ థింక్ వాజ్ అ హ్యూజ్ బిగ్ టెస్ట్. ఎవ్రీ మంత్ ప్రతి నెల వీ వర్ గెటింగ్ FSH అండ్ LH టెస్ట్ డన్. దట్ LH ఎక్కువ ఉంది అంటే ఈవెన్ ఇఫ్ యూ డోంట్ డూ అ స్కాన్ వీ యూస్ టు టెల్ దట్ ఓకే షీ హ్యాస్ PCOS. Now we have a better test to kind of give us an understanding or diagnosis about PCOS, that is your AMH. So AMH ekku undi ante PCOS undedaniki possibility undi ani. Now AMH and LH ee rendu they increase the stromal volume, cause obesity. For some patients there is thin PCOS also present, and ultimately I think andariki almost about 85% of women with PCOS have elevated androgens, any kind of androgens. These 5 or 6 factors put together is what is hampering us from achieving a good ovulation in PCO. So if we are able to tackle all these parameters, then I think it's going to become, you know, a smooth walk for us or a smooth sail for us to achieve ovulation. One point I would want to make here is, మనం అందరం చెప్తాం, you know, ovulation, follicular study, every month cheyali, we are seeing in all of this ani. And for men we tell that, you know, 3 months, it takes almost about 80 days for sperms to form and so on and so forth. But we need to remember that even for women, it takes almost 80 to 120 days for a recruitment to happen. మనం అందరం చూస్తుంటాం, సెకండ్ డే మనం స్కాన్ చేసినప్పుడు కొన్ని సైకిల్స్లో AFC చాలా బాగుంటుంది, కొన్ని సైకిల్స్లో ఇట్ విల్ బి వెరీ బ్యాడ్. So why does it happen? Because that cycle is a poorly recruited cycle. It's possible that 3 months back or 4 months she has had fever, or she had some other variation or hormonal abnormality because of which the recruitment was bad. So if I need to achieve ovulation for a patient, let's say 3 months from now, I should have had a good recruitment in the last couple of months. Keeping that in mind, so elevated AMH. Anni PCO patients ki manaki high AMH untadani kaadu. I think the maximum that I have seen for a patient was about 28. And there was a patient even with 4.5 or 5 AMH also who was still having a PCO morphology on the scan and who was having difficulty with ovulation. But in the high AMH unna patients lo, AMH in itself will cause a follicular atresia or antral follicular atresia. It will just not let it grow. FSH, మనం ఎంత ఎక్కువ మెడిసిన్ ఇచ్చినా FSH రిసెప్టర్స్ అనేవి ఫాలికల్స్ మీద లేకపోతే it will not be able to take the drug into the follicle, it will not let it grow. So AMH అనేది ఈ antral follicle atresia cause చేస్తుంది. It's ironical because it's being produced from the preantral follicles and it kind of causes the depletion or inhibits them from going. So AMH ఎక్కువ ఉన్న వాళ్ళని ఎట్లా ట్రీట్ చేయాలి, or how do we treat? As Dr. Jyothi has excellently spoken in her lecture, extended letrozole protocol అనేది is a very, very I think safe, simple and cost effective way for us to start off. See, మనం చేయడానికి చాలా చేయొచ్చు, injections చేయొచ్చు, or we can do a whole lot of fancy things, but what is the easiest and simplest and cost effective thing that we can do for a patient? Just increase your letrozole for another 3 to 5 days. So already మనం 5 days ఇస్తున్నాం. 5 mg again is something that I start for all patients. I don't think I have given 2.5 mg even for a 45 kg or a 50 kg patient. And as gynecologists, manaki there are only 2 things that we fear about. Okati ureter, inkoti OHSS. I think this is one thing that we are always scared about, but we have very, very effective ways about handling OHSS. And in simple IUI, I think it's very, very unlikely for you to really have an OHSS kind of situation. So do not worry about it. 5 mg is a good dose for you to start off with. And then, yes, go ahead and take it up to 7 days or 10 days to see and decide if ovulation avutunda leda anedi. Remember, ovulation is not the final endpoint. Pregnancy is the endpoint. Why aren't we using clomiphene citrate for 10 days or 15 days? Or why aren't we using letrozole, let us say, for 15 days? Sare 10 రోజులు ఇచ్చాం కదా, ఇంకొక 5 రోజులు కూడా ఇచ్చి చూద్దాము, అది కూడా ఇంక్రీజ్ అవుతుందా అంటే it is not going to happen like that. Because the T-half of letrozole is about 45 hours. Remember again, letrozole is an aromatase inhibitor. So మీరు 10 రోజులు letrozole ఇచ్చారు అంటే follicle అయితే మీకు కనిపిస్తూ ఉంటుంది, it will be growing. Probably it will become 18 mm, 19 mm వరకు కూడా వచ్చేస్తుంది. But E2 will not grow because your estrogen is not being produced. E2 రాలేదంటే endometrium thickness కూడా రాదు. So if the lining doesn't build up, your implantation is not going to happen. Fortunately for us, unlike clomiphene citrate, which has almost a 14-day T-half, letrozole has only a 45-hour T-half. So technically manam trigger ఇచ్చేదానికి ఒక 1 day ముందు, even if we kind of stop your letrozole. So 10 days కంటే ఎక్కువ it's definitely not recommended. And 13th or 14th day, if we see the follicular scan and see that egg development మనకు మంచిగా అవుతుంది అంటే, then we will be able to go ahead, give the trigger and plan for pregnancy. So that is the reason why almost an ovulation rate of 92%. So this is all in resistant patients. 92% is achieved, a cumulative pregnancy rate of 31% and a live birth rate of almost 25% can be achieved. Now, as I said, when it's too good to be true, we need to make sure that the endometrium also is kind of following it up. And I think this is a good space. Someone was asking about estradiol valerate. This is a good place where we can consider using estradiol or your proganova, as what everybody says as, that deenlo manam estrogen add cheyadam valla some amount of, ante dominant follicle వచ్చిన తర్వాత కొంచెం estrogen యాడ్ చేసుకోవడం వల్ల లైనింగ్ తొందరగా వస్తుంది. అగైన్ ఎగ్ డెవలప్మెంట్కి, ఓవులేషన్కి, ఇంప్లాంటేషన్కి 7 days టైం ఉంది. సో దిస్ ఈస్ ద టైమ్ దట్ వీ నీడ్ టు బిల్డ్ అప్ యువర్ ఎండోమెట్రియం ఫార్ ఇంప్లాంటేషన్. Letrozole and clomiphene, I think before letrozole became so popular, I was using clomiphene citrate with tamoxifen. 40 mg of tamoxifen, 100 or 150 mg of clomiphene citrate based on their weight is what I was using at that point. But I think letrozole వచ్చిన తర్వాత the number of patients who have ovulation resistance is come down significantly. But if you do intend to use, I think using clomiphene 100 mg and letrozole, but again clomiphene only for 5 days, and that too don't go beyond 100 mg, and letrozole you can use for 5 days or 10 days based on how you feel she is responding, and that is something that you can definitely try, because both of them have different mechanisms of action. PCOS గురించి మాట్లాడి మెట్ఫార్మిన్ గురించి మాట్లాడకుండా ఉండడం అనేది జరగని పని, and I am always a little skeptical about literature. Every time, some speaker comes and, foreign speaker, national speaker, they'll come, they'll present very fancy data, randomized control trials, cohort studies, meta-analysis, so on and so forth. But I think some amount of it, we should trust in our practice, in our experience also. Because I think evidence goes up, comes down, goes up and comes down. It always comes in waves. There was a point when we believed there's nothing better than metformin for PCOS. There was a phase that we saw that everybody said, metformin is nothing, and, minoxidil is the thing, and, that is the only thing that you need to take. And now again, everybody is like, no, okay, metformin is something that you need to do, and minoxidil probably is not very effective. So evidence is good, believing in it good, taking some points from it is good, but that doesn't mean that you should close your eyes and ears to your general practice and go ahead with it. I completely believe in metformin because the physiology behind it is unparalleled, and if we have to just simply talk about metformin also, 80 days of use. ఒత్తి మెట్ఫార్మిన్ అనుకొని ఒక 250 mg or 500 mg అలా ఇచ్చేస్తే it is not going to be sufficient. A minimum effective dose is 850 milligrams, and this you can kind of increase up to 2 grams per day also based on the tolerance of the patient. You can just take it as a step up. So again, dose duration 80 days, that is at least 2.5 months. So 2 months ఇచ్చేసి నెక్స్ట్ మంత్ తను ఎనీవే ఓవులేషన్ స్టార్ట్ అయింది, డే 2 వచ్చి ఓవులేషన్ అయ్యేసరికి ఒక 15 రోజులు పడుతుంది కనుక ఆ టైం వరకు అచీవ్ అయ్యేది 80 days ఇస్ అ గుడ్ టైం. సో 2 cycles of metformin is mandatory if you want to see any results in it. So in this simple study which evaluated, let's not look at metformin వల్ల ఓవులేషన్ అవుతుంది అని ఎవరు చెప్పట్లేదు. Okay, please be clear about that. Metformin to part 2, you have to give either clomiphene or you have to give letrozole, what you're comfortable with. But metformin is the side actor who is going to make the main lead look good. He is like the Katappa for Bahubali, who is going to kind of help or enact in their goal. So in this study, we can significantly see that జాయింట్ గ్రూప్ అంటే మెట్ఫార్మిన్ ప్లస్ లైఫ్ స్టైల్ చేంజెస్, కంట్రోల్ గ్రూప్ అంటే ఓన్లీ లైఫ్ స్టైల్ చేంజెస్. సో లైఫ్ స్టైల్ చేంజెస్, వెయిట్ లాస్ అంతా అయినా కూడా ఇన్సులిన్ రెసిస్టెన్స్ లెవెలు, ఎల్హెచ్ లెవెలు, ఎఫ్ఎస్హెచ్ లెవెలు ఇవన్నీ బెటర్గా ఇంప్రూవ్ అయింది, కొలెస్ట్రాల్ లెవెల్స్ ఇవన్నీ బెటర్గా ఇంప్రూవ్ అయింది ఈజ్ ఫర్ ద పేషెంట్ విత్ ద మెట్ఫార్మిన్ గ్రూప్. ఈవెన్ AMH లెవెల్స్, నౌ యూ కెన్ సీ హియర్ నార్మల్ వెయిట్ గ్రూపు, ఓవర్ వెయిట్, ఒబేసిటీ. Obesity patients low average AMH was 12, but 80 days of treatment with metformin got down the AMH to 7.5. Ante ovarian reserve taggipinda? It's not that. It has reduced the number of available antral follicles, and it is going to improve the FSH sensitivity for what we are giving. Again, I candidly keep telling my husband, whenever I praise you in front of someone when you are not there, and I come back home, you invariably have a fight with me over something which is very silly. So metformin is also like that. Don't think that it is all good and it is not going to have any negative impact or there is no this thing. One very important factor is vitamin B12 deficiency. We know that there is nausea, we know there are diarrhea issues, all of that is because of the intestinal motility. You can consider adding Sporelac or any probiotic for them to improve. But apart from that, vitamin B12 deficiency, especially, ippudaithe andru vegetarians, andru vegans అయిపోతున్నారు. I'm feeling very bad. I hope the trend is not as bad in Hyderabad as it is in Bangalore. But please be very careful about vitamin B12 deficiency because they will have significant weakness. That's about elevated AMH. Now, LH ఎక్కువ ఉంటే, సో AMH ఎక్కువ ఉంటే మెట్ఫార్మిన్ యాడ్ చేయండి, ఇట్స్ డెఫినెట్లీ హెల్ప్ఫుల్. లెట్రోజ్ ఎక్స్టెండ్ చేయండి, డెఫినెట్లీ హెల్ప్ఫుల్. LH ఎక్కువ ఉంటే basically if you can see the 2-cell 2-gonadotrophin theory, LH ఎక్కువ వచ్చినప్పుడు ఆండ్రోజెన్స్ ఎక్కువ ఫామ్ అవుతాయి and FSH తక్కువ ఉన్నప్పుడు it's not able to convert all these androgens into estrogen. So it keeps throwing it into the bloodstream. దానివల్ల is why you have hyperandrogenism. And this hyperandrogenism is what will cause your anovulation and everything else. Now, androgens have ovarian origin, adrenal origin, and peripheral. Peripheral is where, you lose weight and everything, it will come down. But what would you do with the ovarian and adrenaline one? I think all of us have used OCP at some point to kind of reduce LH. It definitely reduces LH, no doubt about it. 2 months of using OCP for someone who has significantly elevated LH, let's say 15 or 18 or 20, is going to be beneficial. Kani, PCOS and metabolic syndrome are very, very synonymous these days. So we do know that hypertension, cholesterol levels elevation, diabetes, obesity, anni parameters PCO patients lo untai. So when you are giving OCP, please make sure that you get a small checklist done like this, wherein you are evaluating them for the risk of a venous clot or a thrombosis. So, మన ఎంటైర్ కెరియర్లో ఐ థింక్ ఒక్కసారి అయినా కూడా చాలు, ఇట్ ఈస్ ఎనఫ్ టు రెడ్యూస్ అవర్ లైఫ్ స్పాన్ బై a couple of months. So it's not a bad idea to have a checklist before you go ahead and start. You don't need to fill it. You can just give it to your patient or you can give it to your staff and they can get it done. And if you feel there are more than 2 risk factors that are there, you should rethink before going ahead and continuing OCPs for them. Steroids అన్న మాట మనం విన్న వెంటనే everybody kind of gets worked up, including doctors, but it's not always bad. There is a reason why they are there. And yes, using dexamethasone in small doses of 0.25 mg at bedtime for about 10 days from day 5 to day 15 can reduce adrenal androgens and thus help in achieving ovulation. Generally, to kind of touch about antioxidants in PCO. Antioxidants, I think, affect everything. They kind of are bad for everything. Likewise, especially for PCOS, it's a very, very pro-inflammatory condition. So, antioxidants use cheyadam anedi manchide. Kani, ye antioxidants use cheyali. CoQ, inositol, D3, omega, melatonin. So, if you have a look at what is the impact on what? Testosterone levels, triglyceride levels, insulin resistance and BMI. I am not talking about ovulation because ovulation is a final aspect. These 5 parameters or 4 parameters, androgens tagite ovulation easy avutundi. Triglycerides or cholesterol tagite weight tagite ovulation easy avutundi. Insulin resistance tagite ovulation easy avutundi. So these are aspects that you need to focus on. Again, the dilemmas of a student: good grades, enough sleep, and having a good social life. You can never have all the 3. You have to sacrifice one. Either you can have good grades, have a good social life, and you won't be able to sleep at nights, or you choose the ones which are important for you. Likewise, I think when you're looking at your gonadotrophins also, you have to look at basic dose, FSH or LH, FSH or HMG, recombinant urinary, or what are the main regimens that we have. Again, you know, I almost felt that Dr. Jyothi completely spoke whatever I wanted to talk regarding PCO resistance gurinchi ani. But yes, again, giving you a pictorial representation of the same thing. FSH threshold is required, so you need a certain dose to kind of achieve it. FSH window, that is the duration that you need to kind of give for you to be able to achieve it. ఇది మనకి న్యాచురల్గా అవుతుంది లోపల జనరల్గా. దీన్ని మనం పెంచాలి, ఆర్ ఇఫ్ యూ నీడ్ టు అచీవ్ మల్టీ ఫాలిక్యులర్ జెనసిస్, ఆర్ ఇఫ్ యూ డూ ఇట్ అంటే దెన్ యూ గివ్ అ హైయర్ డోస్ ఫర్ అ లాంగర్ డ్యూరేషన్ ఆఫ్ టైమ్ సో దట్ యూ గెట్ మోర్ ఫాలికల్స్ for going through and the remainings undergo atresia. Quickly going through the protocols. So I think conventional step up, step down, ivanta evaru ippudu cheyadledu. This is like you know, Dr. Deepthi is also agreeing with me. Nobody does it anymore. The first cycle when you use gonadotrophins is going to be the toughest cycle, and that is the cycle you need to prepare your patients mentally. 3 రోజులన్నా, I mean, so yeah, we give 5 days of letrozole and then we start them on gonadotrophins. We always use a combined protocol itself. So I tell them 3 days అయినా పట్టొచ్చు, 7 days అయినా పట్టొచ్చు. Dose 150 తో basic line లో start చేస్తున్నాము. Tell them I don't want to start with a high dose because I feel it might have side effects. We will see what is the best dose that is possible for you. If you tell them in the beginning itself, they will not be disappointed in case if you feel they don't achieve an ovulation. So tell them in the beginning itself that what you're doing. Because if you 5 రోజులు 7 days ఇంజెక్షన్స్ ఇచ్చేసా తర్వాత ఎగ్ రాలేదమ్మా, నెక్స్ట్ సైకిల్లో నేను మీకు మళ్ళీ డోస్ పెంచ్ చేస్తాను అంటే, మేడం ఈ సైకిల్లోనే డోస్ ఎందుకు పెంచలేదని అడుగుతారు. So you tell them in the beforehand itself that you didn't want to do it because you value for their health and you don't want to start a very high dose for them right away, is going to be a better approach. Honestly speaking, we have even started off with 150 international units also, but I think 75 is a safe space, and we have to welcome PC Mahapatra sir. Thank you so much sir, it's a pleasure. I'm glad you're I have the pleasure of talking in front of you at least for another 8 more minutes. So the last 7 minutes of the talk, resistant PCOS ante manam 150 units ichesam, metformin ichamu, weight loss changeamu. We've done everything, you know, other than changing the husband, we have technically done everything for the patient, and she has still not got pregnant. Will anyone of you have it in you today? We have not, ovulation avaledu inka IUI sanga tarvata. So will you have it in you to tell the patient, let's do an IVF? Ferty9 aithe andaru okay antaru, rest. So it is not that fertility specialists always believe in IVF, or you know that gynecologists are more inclined towards an IUI. Manam em cheyagalamu anedi shouldn't decide what we do for the patient. You know, we can do a whole lot of things, but that doesn't mean that we should do everything for the patient. What is best for the patient? It is not a bad decision to kind of decide that you want to do an IVF for her. We've had a patient, she was about 95 kg, married for about 5 years, never achieved ovulation. You know, we gave her oka IUI cycle ki we went ahead and we did, and she required almost 200 international units for about 8 days, 5 days of tablets and so much to just get 1 follicle or you know 2 follicles I think. We did an IUI and you know she didn't get pregnant. So in a certain profile of patients, it is not required for us that andariki 4 cycles of IUI ayin tarvate IVF cheyali leda andariki oka 10 years of marriage tarvate IVF recommend cheyali anem ledu. If the patient is an older patient, so it's not just సర్లే 35 ఉంది కదా AMH 6 ఉంది ఓ ఇంకా చాలా టైం ఉంది అనేది కుదరదు, బికాస్ క్వాలిటీ ఆల్సో మ్యాటర్స్. ఇట్స్ నాట్ జస్ట్ అబౌట్ క్వాంటిటీ. Tubal factor, someone who has only one tube, you know that there is an endometriosis, you know that pelvic factor is there. Male factor, I think all of us have seen patients wherein the woman has even undergone surgeries and still the husband has not got a semen analysis tested. Forget about a DFI. So if there is a male factor, and he is requiring very high doses of gonadotrophins for achieving ovulations and has long-standing infertility, 10 years, 15 years of infertility, and never got pregnant even once. So in these cases, I think trying to, keep repeating the same things, even if you achieve an ovulation, even if you do an IUI, the probability of pregnancy is going to be only about 10 to 15%. So don't waste more time on it. So it is, you can still consider doing an ART in certain patients for resistant PCO. I strategically kept drilling as the last thing that we are going to discuss on PCOS. Do I believe in drilling? Yes. Do I believe we should do drilling for all PCO patients? No. Has the role of drilling in current practice come down? Yes. Was it very effective in the past? Again, yes. Because when my mom is also a gynecologist, she is from Nellore, Andhra Ipudu, but so in her generation, I think the marriages were happening at a younger age. Women were planning to get pregnant earlier, and the scope or use of laparoscopy was much more then. Considering drilling at that point was a much better option. If a patient is coming to you at 32, okay, even if her AMH is 9, there is no reason why you should consider doing a drilling, because in another 2 years, as another previous speaker of mine said, enta ekku AFC unna kuda, it's possible that the baseline might be very low, and it's possible that she might end up with a premature ovarian failure very soon. So these are my 5 tips for considering drilling. డెసిషన్ ఫర్ డ్రిల్లింగ్ అనేది పోర్ట్ వేసేదానికి ముందు తీసుకోవాలి. పోర్ట్ వేసిన తర్వాత అరే కొంచెం అనెస్థెటిస్ట్ చెప్తారు, స్పెషలీ మేడం కొంచెం ఓవరీ బల్కీగా ఉన్నట్లుంది కదా మేడం అంటారు, దెన్ అసిస్టెంట్ అంటారు, దెన్ వీ డ్రిల్. దట్ ఈస్ వాట్ హ్యాపెన్స్. సో ప్లీజ్ డోంట్ డూ ఇట్, అండ్ ఐ హోప్ దెర్ ఆర్ నో అనెస్థెటిస్ట్ ఇన్ ద క్రౌడ్. బట్ ఎస్, డెసిషన్ ఫర్ డ్రిల్లింగ్ హ్యాస్ టు బీ టేకెన్ బిఫోర్ యూ పుట్ ద స్కోప్ ఇన్. ఓన్లీ ఎంత పెద్ద ఓవరీ అయినా కానీ, ఎంత ఏమేజ్ ఉండనా కానీ, ఇఫ్ షీ ఈజ్ ఓవులేటింగ్, యూ డోంట్ నీడ్ టు డూ డ్రిల్లింగ్. If the age is less than 30, if she is having significantly elevated LH, and she has a short duration of fertility. Yesterday, in my OPD, we did a fallopian tube testing, hycosi for a patient. Tubes superb, spillage was good and everything else. And then I was explaining to her, tubes are great, and then she started crying loudly. I was like, what happened? Is it hurting? Is it paining? Didn't they give you injections, on and so forth? She was like, no, madam, naake enduku ila avutundi madam, pregnancy enduku naaku kavatledu. She's married for 1 year. She's 26. Her tubes are good, sperm parameters are good. I literally lost it. But still, you had to kind of keep your cool. So, shorter duration of infertility, for those kind of patients to consider a pelvic factor or to kind of improve the ovulatory effect, yes, you might consider. But for someone who's married for 7 years, 8 years, 10 years, please don't do it. I think Dr. Shashank had discussed regarding how you need to do the drilling. I am scared to put on, the day when it comes when I gain weight, because if I gain weight and if I tell my patients lose weight, I feel, they are not going to agree to it at all. It is impossible to lose weight. I feel it's so difficult. I feel sad to tell patients to lose weight. So just don't tell them lose weight. Do something about it or help them do it. Orlistat is a great lipase inhibitor. It is not orlistat undigani, it's not a statin kind of thing. It's a lipase inhibitor. You can use it for women who are planning for pregnancy. Welcome Shanta ma'am. Thank you so much for coming over. And again, yes, I have another 1 more minute before finishing off with you. So Orlistat is a good anti-obesity medication which you can kind of go ahead and give at least for 2 months. It is equally effective as metformin with lesser side effects. Be open to the idea of, even if you have to recommend a bariatric surgery for a patient, it's not a bad idea. It's very difficult. It's very difficult to lose weight, and you say 130 kgs unna patient ki nu weight loss ayi ra ante, how is it even possible, or how is the patient going to feel? It's, we might feel that it is like this, but I have had patients who've cried because senior consultants have told, no weight loss avakapothe no pregnant kaavamma, no inga vellesra. They've told it, and which is true. But it's not something nice you would want to hear, especially when you are struggling with weight loss. So I think we should have a great program for it. I'm done. Decision making in infertility. This is a book that myself and Dr. Rajiv, we had authored. And I think this is one of our proudest moments. I was randomly kind of going through stuff, and then I got this algorithm. So the entire book is about 100 algorithms about managing different case scenarios, right from evaluation to fertility. It is available on Amazon, so I'll be more than happy if anyone sees it. So it's very simple. There are things which are evidence-based. This is my last slide. So there are things which are evidence-based, and there are things which require a little more evidence. So clomiphene citrate kani, obesity kani, resistance unte, we can consider use metformin, minoxidil. Remember the dosages. Anti-obesity medications like Orlistat can be used in a certain dose to lose the weight. Patients who have elevated DHEAS, which is adrenal source of androgens, we can consider using baseline steroids. Women with elevated LH, androstenedione levels or testosterone levels, we can consider using 1 or 2 cycles of OCP so that the total androgen levels will come down. Thank you so much for a patient hearing. I always love to come to the Telugu states and speaking, because this is such a pleasure to talk to a full house, and I have to thank Dr. Jyothi Budi for calling me here. She is truly an absolutely loving person and very, very kind-hearted. Thank you so much for the entire team.
Thank you,
Thank
Dr.
you, Chairperson.
Apurva.
Good afternoon all. Now, I take the privilege of inviting Dr. Rajiv Agarwal Garu on the Fertility Committee member from 2008-11 and 2023, member Andrology Committee, ISAR, Joint Organizing Secretary for ISAR 2018. He had more contributions towards academics, and he is the Director for Renew Healthcare Kolkata and International Fertility Academy. Now, Sir will be delivering lecture.
Good afternoon, distinguished chairpersons, delegates, the house people, sometimes even on stage. The common thread is that IUI pregnancies don't happen. It's really a waste of time. It's very frustrating to have patients coming back again and again. I, in fact, had a discussion with a senior business development officer of one of the IVF chains in Kolkata. And he said, we don't promote IUI at all. Really, it doesn't work. So, and after doing 2 to 3 cycles of IUI, these patients tend to go away. So we directly talk about IVF. I think today is a time to understand why these people are wrong. IUI definitely works. And there is a lot of benefit in doing an IUI, which we'll try and understand in the next 30 minutes. In 2013, NICE came out with guidelines which said, IUI is trash, do not work with IUIs. It had certain reasons to do so, and G. Bahadur et al., a very prominent andrologist in UK, wrote this letter to the editor, wherein he said that you've based your entire guidelines on the article of one Bhattacharya et al., which I think is wrong. Bhattacharya et al. Had a pregnancy rate of 6% in that article, wherein the national average of IUI for UK that year was 13%. One of the things which the article said also was that multiple pregnancy rates is very high. In that article, they had wrongly taken clinical pregnancy rates as the endpoint and not live birth. And we all know that not all twin pregnancies which are confirmed land up as twin pregnancies when they deliver. There is a spontaneous reduction which happens. The next question which G. Bahadur et al. Asked was, we do transfer 2 to 3 embryos during IVF. And we do create, or we ideally try and create 2 to 3 embryos, 2 to 3 follicles in an IUI. Then how come transferring those 2 to 3 embryos in IVF does not land up with all twins and triplet pregnancies, and we're talking about 2 or 3 follicles in an IUI creating twins and triplets? Lastly, G. Bahadur et al. Also presented his own data wherein he achieved a pregnancy of 20.1% per cycle, such that 39% of women less than 35 years old actually getting pregnant, speaking volumes about the benefit of IUI. The next year, someone did a study and asked all the fertility clinics across UK saying, look, NICE has come out with guidelines and says IUI is not to be done. So what is it that you people are following? 70% of the clinics responded and said that 96% of them are still doing IUIs, speaking volumes about the wrong message that NICE guidelines were putting out. This is a very nice article which came on 2018. It said that live birth was 31% with IUI, and that the cost of doing an IVF was 2 to 3 times higher than doing an IUI, which we all know, and that 20% of couples who would otherwise have to do an IVF got pregnant with IUI itself. Why is the success rate of IUI so bad? Of course, we'll be looking at a lot of other things, but we always look at the West and say, the West must be doing the right things. And this is a very interesting article which was done based on a Netherlands study, wherein they tried collecting data from all the IVF specialists, laboratories, on how they do IUI. And the heterogeneity was absolutely crazy. So much so that if you see, only 25 or 50% of the clinics were actually looking at morphology as being important. And we know that morphology is one of the most important parameters to look in a semen analysis. And there was considerable heterogeneity. This is, of course, a very busy slide, but just to show you that there was disparity in everything that they did. Obviously, it's going to result in probably low IUI percentages for a lot of clinics. Dr. Jyothi Budi and Ferty9 hasn't reached here obviously in one day. She's put in years of hard work, small little stepping stones, every day putting in their hard work. And that's how you get success. And that's how we need to look at IUI success as well. So we need to look at a good evaluation, a good selection, a good workup of that couple, good ovarian stimulation, monitoring, semen preparation, IUI, and a post-IUI management. Every single step has to be taken and looked into carefully to ultimately achieve an IUI success. Patient selection. Maternal age becomes one of the most important things which you look at when selecting a patient for IUI. And if you see here, the pregnancy rates for a woman less than 30 years of age has much higher pregnancy rates as compared to someone who is aged higher than 30. And the pregnancy rates continue to drop. And understand that this is a study with Caucasian women. And I don't know how many of you are aware that the ovarian reserve is 6 years different or higher, or rather 6 years lower in Asian women as compared to Caucasian women. So here they might still even consider IUI for someone who's 40 years old. But in the Indian and Asian scenario, someone above 35 would obviously or already have their ovarian reserves lower. When we come into the factors which decide or which patients you would put into IUI or expect a higher IUI success outcome, you see male infertility gives you a lower pregnancy rate as compared to a female infertility. Within the female infertility itself, ovulation disorders give you about 19%. As Dr. Purva has also spoken, if you work up your PCOS patients well, the pregnancy rates and the ultimate satisfaction you get after looking at these patients is brilliant, and the pregnancy rates, even with IUI, will be much higher. The success rates with unexplained infertility are obviously the lowest, also because what we knew as unexplained only are defects and problems that we've yet not discovered. And that is why the pregnancy rates are lower in these cases. You've already selected your patients. Now you need to do a workup of these patients before you take them up for IUI. Good clinical practice would say never do an IUI without doing a tubal patency test. As simple as it may sound, I'm sure a lot of you would have seen prescriptions where the patient has undergone IUIs without doing a tubal patency. In my opinion, the only place where you could probably do one single IUI without doing a tubal patency is a complete male factor infertility, azoospermia. You could probably try doing one cycle of IUI. Why is tubal factor test important even in an azoospermia case? Is because we know that spontaneous pregnancies also increase merely by flushing the tubes when you do a tubal patency test. And thus, even for a case of azoospermia, you might actually improve the pregnancy rates when you do a tubal patency. Now you've already done 3 cycles of IUI, you want to take this patient up for maybe 1 or 2 more cycles of IUI. You might want to consider doing a laparoscopy to look at the peritoneal factors, endometriosis, because we know that a lot of these things are not picked up in your regular tubal patency test. Semen parameters for success. Initial sperm count should be more than 10 million. Initial sperm motility should be more than 30%. Post-wash, so maybe you want to go a little further and say, will this patient do well? And there's so much of count and motility and morphology and everything else which is coming in. Just do a wash. And if you find that the post-wash 100% motility is more than 1 million, you could probably subject this patient to an IUI. Now this is again something that I've been using in my practice all through, that once you've done your semen preparation, before insemination, leave a small little bit in that test tube and tell your embryologist to incubate it for the next 24 hours. See the sample the next day. Usually 70% of those sperms should survive. Morphology, if there is one thing that you're going to look in your semen analysis before subjecting the patient to an IUI, it should probably be the morphology should be more than 4%. We've always spoken of the age of women. More and more studies are now coming in saying the paternal age is also important. As this slide shows, if the male age is more than 35, the duration of infertility is more than 3 years, a high DFI, or were all poor prognostic factors. I remember having discussions with an andrologist at the beginning of my career when there was just talk of DFI starting. And he had said, DFI is absolutely humbug. There's nothing you can do about it, so why bother even talking about DFI? Today you ask an IVF specialist, and we are all doing DFI in our practice regularly. Can you use DNA fragmentation to also decide if you'll subject this patient to an IUI? You can. Most of us would be looking at a cutoff of 20 to 25%. If it is more than that, the patient would probably do better with an IVF than with an IUI. This article tells you that probably the threshold should be even lower. A 10% cutoff should probably do better. Someone who has a DFI of less than 10% will have a higher pregnancy rate as compared to someone who has more than 10%. So we've always been taught as surgeons that, what to do, how to do a surgery, what are the correct steps, and so on and so forth. But the hallmark of a good surgeon also will be to know what not to do. Similarly, in the case of an IUI, in a stage 3 and stage 4 endometriosis, do not subject this patient to an IUI. Very poor sperm parameters, again, it's not going to work. Age more than 39 years. Probably in the Indian or the Asian scenario, such patients will do much better with an IVF, but this is of course about counseling. This is not an absolute term to be taken as something written in stone, something that you need to discuss with your patients. And of course, continuing IUI beyond 4 to 6 cycles probably is not cost-benefit effective. The only place, and we've all been speaking about using gonadotrophins and more injections will give you more pregnancies. The only place that probably less is more is if you have mild semen parameter problems, and that is why you're doing an IUI, because they're creating more follicles, will divide your sperms between all these follicles and probably reduce your pregnancy rates. So if you have mild male factor defects and you're doing an IUI, reduce your stimulation. Probably using only a letrozole or clomiphene will do. In unexplained infertility, it is very, very important, and I think all of us have reiterated that ovarian stimulation is very important. Maximizing the number of quality oocytes is the single most important factor for success. And ask yourself, have you not seen prescriptions, or some of you even may have done it yourself, just given letrozole or a clomiphene and subjected the patient to an IUI? Those patients are going to have a very, very low success rate, as we're going to see the numbers in a while. Pregnancy rates with 3 follicles is about 37%, with 2 follicles is 26%, and with 1 follicle, which is what we're going to achieve mostly with the letrozole, is only 7.6%. It does not justify the cost of an IUI. Beyond 3 follicles, the pregnancy rates don't increase. The multiple pregnancy rates might be higher. Ovarian hyperstimulation may happen in rare cases, so it's best not done. And when gonadotrophins are used, it must be on a daily basis. Now, this is something that I was kind of smiling when Dr. Jyothi Budi said, I'm not using gonadotrophins on a daily basis. Please understand the difference from her to me. When she's saying I'm not using it daily, she means from day 2, right probably till ovulation, like we do in an IVF cycle. When I'm saying we use it daily, it is in a sequential form, as Dr. Apurva and Dr. Jyothi said. Use your oral ovulogens first from day 2 to day 5 or day 6. After that, add gonadotrophins. Don't do it like a day 2, day 4, day 6, and day 8. It doesn't work. When you add, you have to add on a daily basis. Now, when you do an ovarian stimulation, clomiphene alone, as I said before, only gives you a low pregnancy rate. When you combine the 2 oral ovulogens with your gonadotrophins, it gives you about a 12 to 13% success. If you use gonadotrophins alone from day 2, right for 10 days to 12 days, you will get not only 19%, we've even had 25-30%. But whether you would like to do that or switch them to an IVF is a call that you have to take. Downregulation, again, Dr. Jyothi Budi has already said, downregulation doesn't work. Most studies have shown that IUI does not require an endogenist usage unless you're using a daily injection protocol, you have multiple follicles developed. In those cases, use of an antagonist may be justified. Does size matter? Of course, in an IUI, size matters. So normally we've been told that give your ovulation trigger when the follicle is about 17 to 18 millimeter size. Does it hold true for all cases? So if you're using oral ovulogens, probably it makes sense to take your follicles to a slightly higher size of 20 or even 21 before you consider giving your HCG trigger. But when you're using a lot of gonadotrophins, probably you can bring the size down to a 17 or 18 millimeters before you give your HCG trigger. Is size the only important thing that you're going to look at? No. Again, we know now that Doppler is very, very important in deciding when you're going to give your HCG trigger. If you do nothing else, if you just look at the perifollicular flow, if you get a 75% halo, along with everything else being in the right place, you know that this is a good dominant follicle and your chance of achieving a pregnancy is on the higher side. Some recommendations from ESHRE 2018. What is the best timing of insemination? And after the HCG is given, an IUI done between 24 to 40 hours, usually at 36 hours, will give you a good pregnancy rate. An IUI done probably before ovulation would have more success than an IUI done much after ovulation has already occurred. When a patient comes to us for an IUI and the patient goes to the andrologist or the embryologist for a semen collection, you don't even get a call saying the patient has come and the semen preparation is happening. You receive the call only after the sample is probably ready. You already have 3 patients lined up, you're probably running late for that particular day, and they keep calling from there and you keep saying, I'll just come, another 10 minutes, another 15 minutes. Does that matter? Again, we go back to what we had said initially. Every small little stepping stone, every step that you take is going to be a building block towards your IUI success. So maintaining a very short interval from semen collection to semen wash, that is about 30 minutes. From sperm wash to IUI, usually the best thing is to do it immediately. And from semen collection to the final process of doing an IUI should ideally be less than 90 minutes. If you try and maintain that, you will find your IUI successes to be higher. Semen preparation, Charu has already spoken volumes on that. I don't want to get into it. What we need to understand is, as far as IUI is concerned, they've shown that no one particular method is superior to the other method. Whatever works for you and your laboratory is good enough. IUI catheter, again, this article shows that whether you use a soft one or a hard one probably doesn't make a difference as long as it works for you and you don't create a trauma. But from common sense and practical purposes, a soft catheter would probably cause less trauma than a hard one. Catheter toxicity, this is again something that I don't know how many of you practicing IUI would be doing, but we lay a lot of focus on the consumables when IVF is concerned. But as far as IUI is concerned, probably some vendor walking into your clinic and saying, madam, this catheter is only for 20 rupees, the one you're using is for 40 rupees, and you would say, I'm saving 20 rupees, let's use this catheter. You can, provided you do a sperm survival on every single consumable that you use in your lab. So the semen preparation that you had made, and you realize that it survives for 70%, the 70% of it survive, leave a small bit of it in your catheter for 24 hours and leave it in your incubator. The sperms should survive the next day. And if your consumable that you're using, if that catheter that you're using has sperm surviving inside it, it's a catheter which is good to use. Steps of IUI, if you see this picture, we've always been told one of the first things we were taught, and I have my teacher, Sujata madam, sitting here as well, that empty the bladder. Any procedure that you do as a gynecologist, and probably all of us would have failed our PG exams if we did not say empty the bladder in the first case. For an IUI and a lot many procedures today, we say, please don't empty the bladder, and you will see why. Can we go back to the previous slide, please? And can you play the video for the second picture, please? So if you see this bladder is only half full, the catheter is trying to enter, the uterus is antiverted, and the catheter invariably hits the posterior wall of the uterus. You'll keep struggling, you'll get frustrated, there'll be a lot of bleeding as well, and you will not achieve a good pregnancy out of this. Before getting into your IUI, before actually loading the semen sample, what is it additionally that you can do to increase your pregnancy rates? Some studies have shown that washing that catheter with some media would actually improve your pregnancy rates as well, because it would kind of balance the pH inside the catheter. Could you play the video again, please? Here you see the bladder is optimally full. We know that the uterus is now pushed back because of the overfilled or properly filled bladder. And you will see that the catheter is gliding in far more smooth. And these are just those basic 50 rupee catheters that we all use, and without any trauma to the patient, making it very, very easy. Steps of IUI, patient position, it can be a lithotomy or a dorsal position. Cervix position should be midline. You'll realize there's sometimes just a simple cough can make things so easy for you. It can put your cervix absolutely in the midline. Sometimes if you're not being able to negotiate the catheter, keep the catheter at the internal os inside the cervix and ask the patient to cough. And you'll see pop the os opens up and your catheter will glide in that very moment when the patient makes a cough. Clean the cervix. The nurse must confirm the patient identity. Load the catheter, and of course, check the mark of the catheter for antiverted. You would want to know if the uterus is antiverted or retroverted and guide your catheter accordingly. Importance of the guard. Now you will see that there is a small little guard which is there on the catheter. Most of these guards are fixed in such a way that your catheter will just go beyond the internal os and not hit the fundus. We all know that we don't want to touch and hit the fundus because the uterus is going to contract and throw whatever you're going to put inside the uterus, whether it is going to be a processed semen sample or your embryo for an IVF. So these guards are kind of in the right position. Introduce your catheter inside, keep the guard there so that the flux of the semen sample or the processed sperm does not come back from the external os. Hold it there for a few seconds and then you can withdraw your catheter very gently. Sperm survival testing I've already spoken to you about in a few minutes ago. Fallopian tube sperm perfusion. Now, obviously, when everyone is trying to improve their pregnancy rates, a lot of studies said that one of the reasons why in unexplained infertility, pregnancies don't happen is because the amount of sperms you're putting in is not good enough. Normally, we put about 0.5 ml of inseminate. These studies said that put about 4 ml, flush the tube with sperms, and you will find your pregnancy rates going up. Of course, the latest studies have shown that the 4 ml of flushing of the tubes is not good enough. But G. Bahadur et al., and you can go and look this up, came up with a very interesting talk. And I think it holds water because he said, when you take only 0.5 ml of inseminate, a lot of it actually remains inside your catheter. And what goes inside the uterus may not actually be 0.5 ml. So he said, why not start taking 1 ml of inseminate? That would leave some amount in your catheter, and the rest of it then would go inside your uterus and improve your pregnancy rates. Point to think about. Does the use of ultrasound help IUI pregnancy rates? We all use ultrasound for doing our embryo transfers. Some of these studies have shown that if you use an ultrasound guidance, and most of the clinics would have an ultrasound in their clinics, and if you place the sperms in a proper manner, in a proper place, the pregnancy rates go up. However, there are many other studies which have said that there is no benefit of using an ultrasound. Difficult IUI, we all experience difficulty while doing an IUI. One of the most important things to think at that point in time is be patient. You can use an Ali's forceps to gently pull the cervix. Remember, if you're very harsh with pulling your external os, the fundus will contract and will throw the semen sample out. Check the bladder. As I've said before, I explained why the bladder becomes important. Use an ultrasound guidance if possible. Ask for a cough reflex. Wait for some time and try again. Sometimes fatigue sets in. You get upset, you get angry, and you want to force the catheter inside. Just wait for some time. Maybe have a cup of coffee, let the patient rest, come back and try again. Use a uterine sound. Sometimes a uterine sound can just create that right passage, and then your catheter moves in very smoothly. If nothing works, make the patient head down, and you can probably do an intracervical insemination and let the gravity allow the sperms to move inside the uterus. Of course, if you've had trouble in this particular cycle, make notes of it and see what you can do in the next cycle to make at least the next cycle IUI much better. Maybe doing a cervical dilatation on day 7, day 8, day 9 would make sense because the cervix actually remains open and makes it easier for you to do the IUI the next time. Intercourse avoided or forbidden. It has been shown that obviously, again, common sense, if someone has a low sperm count, adding a natural intercourse to it would improve the pregnancy rates. But does it help for unexplained and other kinds of indications where you do an IUI? Yes, it does. Doing an intercourse probably even the day before you do an IUI, because we know that semen sample remains in the cervical mucus fold and stays there for about 72 hours. So you would have an extra amount of sperms being present even if you've gone wrong with your IUI timing. What is the optimal number of inseminations per cycle? Most studies have shown that doing an IUI just one time in that cycle is good enough. 2 IUIs do not make sense. I personally like to do 2 IUIs when I do a more aggressive stimulation and we have 3 to 4 follicles present at that time. But most studies, of course, have shown only single IUI is good enough. Is there a benefit of bed rest after IUI? A 10 to 15 minutes of lying down after doing an IUI definitely optimizes your IUI success. What is the ultimate number of consecutive IUI cycles that you should be performing? Some studies have said that you cannot really define how many IUIs need to be done. But from a cost-benefit ratio, doing an IUI after 4 to 6 cycles of IUI does not give your patient any extra benefit. Luteal phase support, I know we all give it. Most studies have also shown that doing some sort of luteal support after an IUI would make sense. Newer concepts, I of course read about it. I didn't even understand it. I asked a couple of my colleagues, they've never heard about it. But elastography is something which some people are doing via ultrasound, and they're saying the more stiff the uterus, the more the pregnancy rates. This is again something interesting. Now, when we do an embryo transfer, we are very careful about the uterus not contracting. We even give maybe injectable progesterones on that day. We give some other drugs as well to make the uterus more quiet. How come we don't think about the same when doing an IUI? In my practice, we give a piroxicam tablet on the day of embryo transfer before taking up the patient for an embryo transfer. This article says that piroxicam can be used in IUI as well. Of course, they've used it 4 to 5 days after doing an IUI, but my logic would make more sense to probably give the piroxicam on the day of IUI at least, if not after. There are various websites today. If you go there, they will be, if you feed in the patient data, they will give you the success rate arising out of an IVF cycle. Unfortunately, we don't have such a robust system for IUI, but there are a lot of people nowadays who are working with algorithms for IUI. Probably in the years to come, we would be having such robust algorithms wherein even before we start work, we can tell a patient what the success rate would be for that particular patient out of an IUI. To summarize, IUI is definitely a good modality of treatment provided you use it well. Having a gun is no good unless you know how to fire it properly. Gonadotrophin stimulation is a must if you want good success. Use Doppler for deciding the day of trigger. Use good practice guidelines like doing a tubal patency test. Last but not the least, you must know when to stop and convert to IVF. Thank you so much for the patient hearing.
Admirable keynote speakers, Dr. Jatin Shah, welcome, sir. Well, now let us all proceed with lamp lighting. We request all esteemed dignitaries to be seated. Now let us have the pleasure of listening to the opening remarks of Dr. Jyothi, Founder, Medical Director, Ferty9 Fertility Chain. To accomplish great things, we must not only act but also dream. Not only plan but also believe. She is a believer, brilliant team leader, always leading by example, passionate regarding teaching and compassionate with patients. Welcome, ma'am.
Thank you so much. A very good afternoon. I'm so overwhelmed by the response. I can see a lot of knowledge everywhere. Thank you so much. They say, Vidyam dadati vinayam. Education leads to wisdom. Education is the only tool where we not only achieve success, but also happiness and peace. So peace is very important. So education is a very important tool for that. From times immemorial to today, the words of great Henry, he says, anyone who stops learning is old, whether it happens at 20 or at 80. And anyone who keeps learning is young and also becomes very valuable, regardless the physical capacity. So with flowers and with folded hands, I welcome each and every delegate here amidst a busy Sunday and amidst your busy schedule. You have all taken time and you're here to learn from each other. That means already we are young, we are energetic, we are happy, we are successful. Thank you so much, each and every delegate, for having come and made this a very, very happy moment. I also want to salute all the teachers here. The first lesson what I learned from my legendary teachers are, a tree which wants to touch the sky must extend its roots into the earth. The more it wants to raise upwards, the more it has to grow downwards. So to raise in life, we must be down to earth, humble and grateful. And again, I salute all the teachers, all my mentors for having come and you're here. And of course, I'll take this privilege to thank my dear friends, Dr. Apurva, Dr. Ashish and Dr. Rajiv Agarwal. Such a beautiful lecture you gave. When we decided, I just took my phone and called these three people. They did not even see their calendar. I was so happy. Thank you for trusting us and thank you for giving such a beautiful lecture. Now, I would take this privilege to introduce Dr. Jatin Shah sir. He's a master when it comes to IVF. In fact, today morning I got to hear somebody was calling him Shah Rukh Khan in IVF industry. That's what he's called as. So he has got a lot of, very deep in academics. So about the regular introduction, everybody knows about him. But what pleased me was, in one of an international forum, in an international conference, a speaker from Spain, he was repeatedly naming sir. He was like, okay, for the good works, what he does. So thank you, sir, for making us proud, not only in our country, outside as well. We wholeheartedly welcome you. So I had to pester sir 2-3 times. He was so busy. He's like, Jyothi, Sunday, how is it possible? I told sir, our Hyderabad doctors, delegates needs to hear IVF protocol from the master's mouth itself. So thank you, sir. Thank you again. And now I will take this privilege to introduce Dr. Mahapatra sir. Who doesn't know him? I have grown up hearing his lectures. And words flow magically from his mouth. When he starts talking, some magic happens. And everything, his life achievements are there. But what I like the best is, he says his life mission is born to serve, living for others, working till the last breath. And teaching is his passion. We can see that. And most importantly, he says, to be a man rather than a great man. But sir doesn't know he's already a great man. Thank you, sir, for taking your precious time and you have come. Anytime we hear his lecture, there is something we go back and change our practice. So he has some, contribution to the society. Thank you, sir. And now, I would take this privilege to welcome the one and only one. Does she need any introduction? No, not at all. Madam is the only woman who has represented our country as a gynecologist outside. She is a treasurer in FIGO. What else we need? She is already taking our flag and going outside. Thank you, madam, so much. She is the president of our Obstetric Gynec Society. Of course, she has many achievements. I think this day is not enough if I start talking about it. But what is important is, they say, normal people don't make history. Bold people make history. She has made history. And she carries the confidence with her. Two things, just I'll end it here. Two things what I like about her is her teamwork. Whenever, wherever she goes, she carries her team. She makes sure people around her is uplifted. That I really liked in you, madam, I have learned. And then second is, in fertility space in Hyderabad, I knew friends. I used to tell hi, bye, like Himadipti is here and most of my friends. But she got ISAR to Hyderabad and all fertility experts, she made us sit together and we are thick friends now. So she has given me a lot of friends in this space. Thank you, madam, for that. And then, of course, regardless her team. We go to OGHS office, it's, you know, so, what a beautiful aura. Each of them are there behind her, working for that. And now we have AICOG in Hyderabad. 2024, please each of you register and be a part of this. There's a lot of learning for 3 days. So I watch for this, please do register, it will be a fantastic event. Now, 1 minute about this baby which started 10 years back. It started like this, Ferty9. It started crawling, not knowing what to do. Only thing it wanted to stand on a proper support. So when we started our small center, which was in Sikandrabad, the whole purpose was in our mind when we started, it should be service oriented, it should be transparent, ethical practice. And I respect a lot my father-in-law. Anything he does, he tells first, make a good name, then everything will follow. So that was the starting journey. And of course, I am also a very, very big fan of Abdul Kalam. I read a lot of his books. So I have a living Abdul Kalam at home, my father-in-law. So I derive aspiration from them. What they say is, any profession you choose, wherever you are, whatever you do, there should be an element of service in the profession. You should be able to touch hearts of millions of people. Then you don't have to run behind success. Nature sets in and makes sure what profession you have chosen become popular. So that is what we followed, and thanks to all of your support, and we are here now with 7 centers. Thank you so much. And then everything is a team again. These are my 16 wonderful consultants. From morning you are hearing them. I was so surprised to hear them speaking like this. Thank you so much. And each of them in their own centers have this moral responsibility. The important is patient first, everything next. We have put that so much in all our consultant that patient is like a god to us. That is most important. Next, of course, our embryology team who works behind us. I take this privilege to thank them. And just this on a lighter note, if you, I can't hear the voice. Okay. Volume, anybody can play the video and volume, if possible, otherwise I'll skip it. So this was one movie which, okay. Yeah, so we handle gametes outside the body. It's so important, you know. Most of the patients who come to us first ask, what do you do with our gametes? How safe is it? So in this, see, these movies, we should not encourage. They have just, this doctor comes and talks to these people and say there is a gamete mix-up. So it's so important for us to deal with the gametes very well. So I'm very happy in our center, now in Ferty9, we have introduced RI witness system, where we have a barcode, and it's a cutting edge technology where, it's a gold standard to prevent gamete mismatch. I'm so happy about that. And of course, if we have to say, in these 3 years, we did not have data before. Now it's a data-driven company. In these 3 years, we did a study. 5,858 happy couples have been produced from our center, and thanks for all the trust from all the gynecologists here. And of course, it's a very proud moment. 200 plus gynecologists have been somewhere touched upon from our center. They are trained in the basic programs, advanced programs. So thank you for trusting us, and I can see all of you are here. Thank you so much. And of course, lot of camp. And then I end my today's that we are what we repeatedly do. Excellence then become not an act but an habit. So we want to do in this field of reproductive medicine the best, and thank you my team who are always there. So now the baby which was small has now grown. It is a tree now which wants to, a 10 years old tree which can do better. So I also take this opportunity to thank all of you who have supported and trusted us, and from our city we want to go beyond. So please continue supporting us. We want to do the best. Somewhere as madam went from Telangana to outside country, I was so proud. So similar things should happen. I wish all blessing and warm wishes from each of you. Thank you so much. Of course, day doesn't end without thanking my family who are constantly there, like you go, you achieve whatever you want, I'll take care of the family. Thank you so much. Thank you. Yeah. Dr. Jatin Shah sir to speak a few words.
by the success of this conference, and of course I'm very grateful to the entire team. Actually I'm quite, I'm going to talk on ovarian stimulation, but on a personal basis I'm quite hyper stimulated since morning because I'm absolutely swept away by the dedication, the sincerity and the discipline with which the entire delegate audience was seated in full capacity at 8:30 a.m. in the morning on a Sunday. It's unbelievable and unparalleled. And I think all credit goes to, of course, our very efficient, dynamic, always dopamine and adrenaline charged super achiever, the epitome of perfection, and probably the best scientific organizer our country has ever seen. So thank you, Jyothi, and thank you, Ferty9. Thank you, everybody, for coming in such large numbers. Thank you so much.
For your kind words. The next distinguished to honor us with his presence is a name that needs no introduction. Welcome PC Mahapatra sir to say a few words to the gathering.
Salute to the organizers of this brilliant academic conference, an education, full-day education on infertility, organized by Ferty9, the leader, Jyothi, and distinguished people in the dais, my sister Santa Kumari, Yateen, the Sarut Khan of Fertility IVF in India, and all the delegates coming over here, teachers, sub-teachers present over here. Well, this podium is not new to me, this audience is not new to me. I think it's like a homecoming to Hyderabad every time I come. But this time there is a slightest difference. I think Shanta was the person who always emotionally blackmails me so that I come to Hyderabad. Now he has become from national to international. And he has a team, he has given the baton to the new brigadiers, Jyothi, and see how Jyothi is doing this conference for that. I think salute to Shanta as well as Jyothi and all the team for conducting this educational program and conference and CMEs and everything for the betterment of skill development of all the people for that. And therefore, I was supposed to be in Coimbatore today, so Jyothi has emotionally blackmailed me so that halfway I come back from that to Coimbatore to be with you, to learn, not to give something to you for that. Thank you all of you for giving me a place for you in this event, academic event. I sincerely love it for that.
In inviting our guest of honor, Dr. Shantakumari Madam, to address the gathering.
Good morning, everyone. I bring warm greetings from FIGO, Foxy, Telangana Society of ONG and Obstetrician Society of Hyderabad. Indeed a pleasure to be here and to welcome all of you to our lovely city of pearls and biryani, Hyderabad. Thank you PC Mahapatra sir for being with us, Dr. Jatin Shah for being with us. I congratulate Jyothi and the whole team of Ferty9 for coming forward to do this wonderful program and associating with the Hyderabad Obstetrician Society to do this wonderful academic program. Tirupati called me and said, Madam, 400 mandi vachchiru, jaldi randi. So that was, he said, the more than 400 people come quickly. I was in a different program and I had a Zoom meeting in the morning. So I said, yes, I'll be there. I would really like to take the opportunity to welcome all the guests who have come here. Ashish, Apurva, and our own Hyderabad son-in-law, Rajiv Agarwal. Okay, so his wife is from Hyderabad, so he's our boy. And a warm welcome to all of you here. And you have heard lovely lectures. All of them are extremely good in the scientific knowledge. And we have our own Shah Rukh Khan and of course our own Amitabh Bachchan who is there, our PC sir. Thank you all for, I think the presence of all of you has made it possible for the hall to overflow with people. So Vindhya told me when you're coming, you get your chair and come. There are no chairs in the hotel. So thank you Vindhya anyway, you gave me a chair. So I'm quite privileged. Sir, I have to tell you all something. I have seen IVF specialists from long time, from the time I entered Hyderabad. And I've seen, not only Hyderabad, everywhere. I've never seen the IVF specialists being very close and pally to each other. Many of them, they're all by themselves because everybody thinks they're God's gift to earth and all. That's what I have seen. Previously it was the laparoscopic surgeons also, then the IVF also joined. Then I used to wonder, and it's okay, we are all the ordinary Aam Janta doing ordinary OB-GYN work, so we were okay. Then actually, what I learned in my journey in Foxy is to make a team. Unless you have a second generation, you are finished. And that is what I learned from Mumbai. My seniors in Mumbai, Dr. C.N. sir and all the others, I learned because you always have to invest in your second generation, which was not very much there in many parts of the country, which was there in Bombay, which I actually picked up, and that is very, very important. Today, Hyderabad society is very strong. It is because of this. So unless we have a second team, third team ready, we will not be able to make a difference in the academic or the administrative level. And ISAR 2020 was a fantastic conference. I was a non-IVF guy who won the bid and got it to Hyderabad, and I told all the young IVF girls, we call them the infertility girls. I said, all of you are very good academically and everywhere. Now I need all of you to come together. We are here to be the pillar. And they all came together. I'm so glad that we have a very good team of tier of the young infertility girls. We still call them girls. And being together, I think, is the secret of success of any society. And Hyderabad's, the younger generation of specialists have shown that together we can make a difference. Nothing will happen, you all. Don't get worried by being this thing. What destined practice you're going to get will be there. Whichever patient has to get operated by you, it's already destined. They will come to you. I think being together with the colleagues, having a positive attitude towards colleagues and a positive attitude of practice is the most important sutra of development. And that is important. Just when a patient comes from some other case, please don't say, oh, this should not have been done, we should have done this. That is something we should never be done, and I'm happy now we don't find many such things. Slowly it's decreasing. So keep it. Any doctor, if you find that there's something not very correct, take that effort, just pick up the phone and talk to the doctor, don't tell the patient. So probably maybe we can relook at it that way. So that is the most important small tip which I would give to my colleagues, because that will make a difference in the way we practice. And now Jyothi. Jyothi, I have to really congratulate you. She's been very close with all of us at Team Hyderabad OGHS. All of them will watch for me. They're very, very nice, simple girl who will always come, I want to do this, I want to do that, I want to work. And that positive attitude is something which is the secret of your success. I congratulate you. As PC sir and I was just talking that very nicely she has grown, and the most important thing is about her is her soft attitude and very humble nature. That is the most important. So when I was coming up on the stage, my madam, Vindhya madam, Vindhyopadesham she did to me. Don't talk loudly, talk slowly. Okay? It is this which will actually keep us grounded. Vindhya, Jamuna and all of them, Ayush, Krishna, they keep me grounded. And because when we talk sometimes, the voice is loud. But that doesn't mean that we are loud. It's the way we communicate, the way we connect. I was in Vietnam on Thursday in the dinner. There were two UK guys, one wife and husband. They have been living in Vietnam 15, 16 years. So she came in, but very prim and proper British woman. So she was saying, oh, is this your first visit to Vietnam? I said, yes, I came for this meeting. Well, they are so very loud and this thing. I said, excuse me, we Indians also are very loud and colorful. And because of that, you guys came over. And okay, maybe we hope that we have added some color to your lives, because they're very dull and drab lives. So that is the essence of our country and our lifestyle. So good to have you all, and I would like to remind you all, we have an interesting Foxy Figo Congress which is happening in Hyderabad on the 15th and 16th of July. We really look forward to having you all in big numbers. Our President-elect, Professor Ann Chiara, is going to be with us in person in Hyderabad. So it's an opportunity to be with us, to meet the elite Foxy Figo. And we have, coming soon in the October in Paris, we have the Figo Global Congress in one of the most beautiful cities of the world, Paris. So all of you who would like to visit Europe, have a holiday and academics, take the opportunity, kindly go into the website and you can register for the FIGO Congress. There are group registrations, 25 to 30 people, you get about 20% reduction. There are 2-3 groups which are already formed in the Foxy. You can also get connected to them, so you may get a little reduction for the registration fees. And don't miss the opportunity to enjoy the evenings in Paris. I look forward to have you all there as the treasurer of FIGO. I am just hoping that we'll have a good contingent. My FIGO team, my president was asking me, Shanta, how many people are going to be there from India? You have 40,000 people. I said, usually we have a very big contingent. You know, Brazil, we had about 1,100 people from India. So this time about 200 odd have registered. So I said, don't worry, our people are all a little late in registering because they're all waiting to get registered. So hopefully by the end of another 1 or 2 months, we'll have a huge crowd. And I'm really hoping that more than 1,000 people from our Foxy will be attending the FIGO Congress in Paris. And friends, after that, January, Jyothi has already told you we have got our AI COG. So Foxy and everyone is looking forward to a wonderful AI COG in Hyderabad, and I'm looking forward to full participation from all of you. We have about 300-400 people. Many of you have not registered. Kindly do register at the earliest today if possible or within this week, because your registration will matter. Very important that the Hyderabad Society and the Telangana and AP societies register at the earliest. So that will give the support which is needed for the Congress. So congratulations Ferty9 and the whole team. I took a little time more, but I thought I have to tell about all these conferences and all. Wish you all the best, and I hope you all do good work and every patient goes back with a baby, because that's the most important and the best gift anybody can give, and wish you all the best.
Let us mark the end of the inaugural ceremony with the national anthem. I request all the audience to stand up for the national anthem.
पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Dr. Trishan at Apollo Health City. She is the member of ICOG Governing Council, faculty at various state and national conferences, and executive member of Vijay Foundation Trust, an NGO for women and children. I take the opportunity to invite Dr. Famida Banu ma'am. She is director, Femicare Hospital, consultant obstetrician, gynecologist, laparoscopic and robotic surgeon. She is a surgeon faculty for postgraduate training. Next, we call upon Dr. Hema Varangal and Joint Secretary of Varangal High Risk Pregnancy, Adolescent Health and Infertility. Welcome, ma'am.
Friends, now we go on to the most important topics of today's CME. We have the master who is going to talk about fertility masterclass, the IVF protocols. So, Dr. Jatin Shah, Director of the Mumbai Fertility Clinic and IVF Center, member of ISAR, Foxy, MOGS, ESHRE, and founder member of Aspire. He has established more than 20,000 pregnancies through IVF, ICSI, third-party reproduction over the 30 years. He has helped to establish IVF technology in a lot of places like Kerala, Agra, Erode, Madurai, Chennai, Pune, Bajitpur, and
This topic is because ovarian stimulation is the very foundation of ovarian stimulation, so that you get the most competent oocytes, giving you not only good genetic outcomes but even good mitochondrial integrity, so as to generate top quality embryos in good numbers, so that you have enough fresh and frozen transfers to give your patients a good cumulative high birth rate. Of course, just to divert a little, because Dr. Shanta Kumari told us about Dr. Rajiv's strong association with Hyderabad, I am also proud to say that recently my son, who is also an IVF specialist, married a lovely Telugu girl from Hyderabad at the FERTYGNAN Palace. And Apurva, I understood most of the words that you used during your lecture, because I also hear a lot of Telugu at home now. So after that, of course, now to begin on a serious note, before you begin stimulating, you have to know what kind of patient you are dealing with. So you have to take into account her age, AMH, AFC, BMI, her previous response, is there associated PCO or endometriosis, and how is she likely to respond with your IVF treatment. And once you have put all these things together, you have to categorize her as a probable normal responder, or is she going to be a poor responder, or is she going to be a high responder. Of course, we know various factors now that AMH has which can contribute to a decline in AMH levels. We have more and more higher incidence of smoking in young girls. Please remember that both smoking and vitamin D deficiency are now known causes of low AMH levels and reduced ovarian reserves. So let's start with the biggest chunk, and I'm sure after the COVID pandemic, the biggest epidemic all of us have seen is the epidemic of poor responders. Means I don't even remember when I last saw a patient with an AMH of 2.5 or 3. Almost 90% of the patients who come to my clinic have low AMH, and therefore it became very important to really learn how to treat this very difficult group of patients. And with the new ART acts and with the huge shortage of egg donors, more and more educated patients not agreeing for egg donation, they want their own biological child, we have to find innovative ways of treating this group of patients. So you're all familiar, but for those of you who are not, to keep it simple, you have 4 groups of poor responders. So you have the Poseidon 1 and 2. These are young and old patients. They started with a normal ovarian reserve. So she had a good AMH, good antral follicle count. You thought you will get 20-25 oocytes, but you do not. So here you have 2 subdivisions. You have a subgroup 1A, where you get 4 or less oocytes, and you have a subgroup 1B, where you get 5 to 9 oocytes. So don't give up, it's not that bad. Even if you get 5 to 9 oocytes, I'll show you a very recent meta-analysis which shows that the pregnancy rate in that group is still very, very good. So you don't have to be disheartened just because instead of 20, you managed to get just 6 oocytes. So the young and old were unexpected. So obviously you didn't give them any pre-treatment, you didn't give your coenzyme Qs, you didn't give them DHEAs, you didn't give them anything, and you are stuck with a situation with a fewer number of oocytes. Then you have 3 and 4, where you know that they are poor responders. So they are young and old patients who start with a diminished ovarian reserve, low AMH, low AFC. So you are very well prepared that she is not going to respond well. You know that, okay, you have to give her good pre-treatment to ensure that she gives you an optimal number of oocytes. So why are oocyte numbers important? Does it really matter whether I get 2 oocytes or 3 oocytes or 5 oocytes? Will the live birth rate actually change? And a lot of data to show that to get 1 top quality embryo, you need at least 3 metaphase 2 or mature oocytes. So this is the importance of getting each extra egg. And you can see that as age advances, you need more and more oocytes to produce just one euploid embryo. So this is where the elderly age group and the Poseidon 4 will struggle, because they will have a low ovarian reserve. You have to keep stimulating them. You have to counsel them that you might need a lot of cycles before you can achieve a euploid blastocyst and have a genetically normal baby. So how do you manage Poseidon 1 and 2 in a subsequent cycle? Okay, you know that she didn't respond well and the cycle failed. So what do you have to do? And this is why the whole management strategy is towards getting those extra 1 or 2 oocytes. So there's nothing miraculous is going to happen, but you will make a significant difference if you focus on getting that 1 extra oocyte. And why? You can see with every extra oocyte that you get, there is an increase in the live birth rate. So with 1 oocyte, if you are at 4%, with 2 oocytes, you go to 9%, with 3 to 12, and so on and so forth. The 4 commonest etiological reasons for Poseidon 1 and 2. Number 1, you started with a low gonadotropin dose. Now please don't make this basic mistake. Now most of you use antagonist protocols. Even if she hyperstimulates, you always have the choice of an agonist trigger, freezing all the embryos. So what are you scared of? Why are you starting with 112.5 and 150 or 187.5 or 75 for that thin, lean PCOS patient where you are so scared of hyperstimulation? You don't have to fear anything. Even if she has 40, 50, 60 oocytes, nothing is going to happen to her. You just give the agonist trigger, freeze all the embryos, and give her a fantastic cumulative live birth rate. So first important thing, the starting dose should be an appropriate dose. Second, polymorphisms. Of course, we know 10 to 20% of these patients will be carriers of polymorphisms, which make the ovaries less sensitive to exogenous gonadotropins. The commonest practical problem is the third reason, and that is asynchronous follicles. And this is most commonly seen with the antagonist protocol. Patient walks in late evening on day 2. You don't want to waste that month. You feel, oh, she may go away somewhere else. So you start your FSH injections on day 2, and then you find on day 7 that one dominant follicle has raced ahead and the other follicles are smaller in size. Remember that the dominant follicle is often selected in the late luteal phase of the previous cycle. So if you are going to start on late day 2 or day 3, as we very commonly tell them, you are not going to get a synchronous cohort. One follicle will race ahead. Then if you wait for the others to grow, you will lose the best oocyte and vice versa. So you have to be very careful about ensuring synchronous follicular growth. And the fourth is, of course, what was the trigger that was used. So let's see each one individually. Remember, your starting dose for all patients across all spectrums, whether it is your thin lean PCO or it is a normal responder, should be 225 if she's a normal BMI under 35 age group. If she is above 35 with a high BMI, you can start with 300 or 450 as well. You no longer have to worry about ovarian hyperstimulation. Also, if you had done your first cycle with HMG, remember one of the greatest advantages of REC FSH is that it is more potent. There are no batch-to-batch variations, and you will get a higher number of oocytes. There is no refuting that. All the Cochrane meta-analysis say final live birth rates are same, but we are not talking about live birth. We are talking about getting 3 more oocytes or 4 more oocytes in a poor responder. So this is one area where switching to REC FSH might help. And you can see papers clearly showing that 200 will give you more oocytes than 100, 225 will give you more oocytes than 150, but 300 may not necessarily give you more oocytes than 225. So in view of cost considerations, you don't have to go ballistic for each and every patient with the dose. How much do you increase in the next cycle? Oh, in the last cycle you gave her 225 and she gave you only 5 eggs. Will you jump to 450 in the next cycle? No, you will not. You just need to increase by 75, maximum 150, and you will see a significant increase in the number of oocytes that you get in the next cycle. Why is follicular synchrony so important? I already highlighted to you, and that's why pre-treatment is very, very important. And you have simple ways of pre-treating a patient before an antagonist cycle. Of course, the best way to pre-treat is to use a long agonist cycle. The gold standard down regulation protocol, which we all started our careers with 30 years ago, is the best way to get a perfectly synchronous cohort. I'm sure all of you who have used the down regulation will agree that there you never have a problem of one follicle shooting ahead. The day you start FSH, all follicles grow at the same pace. But for the antagonist protocol, those of you who refuse to switch to the agonist, you still have 4 options for ensuring follicular synchrony. So the first is the use of luteal estradiol valerate. And this is very simple, just give 2 milligrams twice a day from day 25. And she will menstruate because 4 milligram is not enough to suppress menstruation, but it will suppress the selection of the dominant follicle. So that is what you want. You don't want one follicle to start growing, and that is why you will use luteal estradiol. Then she gets her menstruation, it's a Monday, you don't want to start stimulation because pickup will be next Sunday and I have to come here to give a lecture, so how do I go about it? And then you just continue estradiol till Friday. So I can keep giving estradiol valerate. Her bleeding will stop, she will have a triple line endometrium, but there will be no dominant follicle. You then start your FSH from Friday, follicles will start growing, and then you can stop estradiol valerate at that time. Some studies say you can continue it, it doesn't really matter, and that is how you will ensure follicular synchrony. Second, even simpler, like a lot of women take norethisterone just to postpone menstruation for pujas or functions and all that, is the same thing you have to use. Give it twice a day from day 20. Minimum 7, maximum 14 days. We normally stop on a Sunday, so she bleeds on the Thursday, and Friday you will start your stimulation. So you have to have a 5-day washout, just like with the OC pills when you use norethisterone acetate. Simplest, if you just want to tide over a weekend and you don't really want to push by 1 week unless you are going for ASRM or ESHRE conferences, then you can just give the antagonist on days 2, 3 and 4, start FSH on day 5, restart antagonist when a follicle reaches 14 millimeter or whatever your criteria are for restarting the antagonist. And if you are a die-hard fan of OC pills and you just refuse to listen to any of my lectures that no, he doesn't know what he's talking and I will use estrogen-progesterone combination, then please go ahead, but just give it for 10 to 12 days and don't give more than that, otherwise you will have excessive suppression. And then if you are using a dual trigger or an agonist trigger, it might not give you an optimal outcome. So you can see here days 2, 3, 4 is the pre-treatment group, and the number of oocytes increased from 9.9 to 13.6, and that's a good increase. You got almost 4 more oocytes, and I told you every additional oocyte counts in a poor responder. So again and again I keep saying that yes, the agonist is the best, and please go back and use the agonist. You will really remember me for your poor responders because you will definitely get more eggs, you will get better embryos and a better ongoing pregnancy rate. In fact, what was the reason we gave up the agonist protocol? It was OHSS in high responders. Now, isn't high response what you want in a poor responder? And this is what we all missed, and we just switched completely to the antagonist protocol. So Sankara first showed that of course the agonist protocol increases the number of oocytes by 1, but that was way back. Definitely you get 3 to 5 more oocytes. You maintain low LH and progesterone levels throughout the follicular phase. Perfect synchrony, higher number of oocytes, and it's not just me saying this, there are a lot of studies. A lot of European centers have now started reinitiating the agonist and long protocol for poor responders, and the latest ESHRE guidelines mention that agonist and antagonist are now equally recommended for the management of poor responders. So you can see here, higher number of oocytes, higher number of embryos, and higher live birth rates with the agonist. The best control is always the patient herself. Instead of doing 500 agonists, 500 antagonists, different patients, we decided to study both protocols in the same poor responder, in the same patient. So consecutive cycles were done using a different protocol. If the first is antagonist, second is agonist, or vice versa, and you can clearly see you get 30% top quality embryos with the long agonist and HMG combination as against just 17.5% with the short antagonist protocol. So if you are going to get double the number of top quality embryos, obviously your live birth rate is going to be much better. What about polymorphisms? Of course, we know a lot of polymorphisms are there which make the ovaries insensitive. What you need to do for these patients, of course, your starting dose in the next cycle, if you have a documented polymorphism, it's easy to test now. It's 7,000 to 8,000 rupees and it's easily available. But if you don't want to test and if you just feel, okay, this patient, she had stagnant follicles at 12 to 14 mm and she's probably carrying a polymorphism, you start with a higher FSH dose, but what I prefer and what literature says, you start LH from the beginning. So don't wait for day 7, then see stagnant follicles and then add LH. You start 2:1, 3:1 ratio right from day 1 so as to not get a hypo response and get a better outcome. What about this difficult category of Poseidon 3 and 4? And again, studies have shown that the agonist is better even for this group, almost a doubling of the clinical pregnancy rate as compared to antagonist. How high should you go? I have seen centers giving 1200 IU, 800 IU, 600 IU. It's just like flogging a dead horse. You can't make it wake up. If there are no follicles, they are not going to come. So you don't need to go very high with your doses. And there are a lot of studies, 10 years old studies, which have clearly shown whether you give 300, 450 or 600, your final live birth rate is the same in this Poseidons 3 and 4, where you don't have eggs and she has a very low ovarian reserve. So even the ASHRAE guidelines are very clear that increasing the dose above 300 is not really going to help. And going to 600 very often affects the zona pellucida, and then your ICSI specialist will tell you, oh, the eggs are just bursting, they're very fragile. That is usually because of overdosing with FSH and LH in these groups. So that brings us to LH, which patients need LH supplementation. Again, all elderly women from day 1, all hypo responders, all patients with hypo, and all poor responders is the consensus as of now that LH is important, and all those debates we heard, no LH, yes LH, no LH, are now finally laid to rest. And that brings us to the trigger. Many a times you have 20 follicles, you got only 10 eggs. You had 10 eggs, you got only 3 metaphase 2s. So what do you do here? Now this is where the dual trigger comes in. Remember that HCG, when you give as a trigger, only simulates the LH peak. But when you look at a normal menstrual cycle physiology, there are both FSH and LH surges in the mid-cycle for a perfect meiotic conversion of the oocyte. And that is where the agonist trigger comes in, and that's why you need an endogenous FSH LH to be intact, and that is why you don't have to give too much of OC pill pretreatment, which will deplete the endogenous FSH LH. So here in a dual trigger, in the agonist trigger, you are simulating both FSH and LH surges, and therefore you get a much more physiological response. You can see here when you combine REC HCG with 0.2 milligrams of triptorelin, all the outcomes were better in this Poseidon 3 and 4 groups in this study from 2019. All of us have this mental image that HCG is the best trigger, and agonist somewhere is insufficient, the corpora lutea are not good, she will not get pregnant and so on, but there is data to the contrary now that the agonist trigger, for exactly the reason I told you that it's more physiological, actually gives you higher number of mature oocytes and blastocysts. Of course, you have to do a freeze-all, you can't do a fresh transfer when you use only an agonist trigger, but you will get, as you see here, the blue line is the frozen embryo transfer with agonist-triggered embryos. The red line is with HCG-triggered embryos, and you can clearly see higher live birth rate with agonist triggering. That brings us to one big thing, the dual stimulation, which all of us thought is some kind of magic potion for poor responders. I'll do back-to-back follicular phase stimulation, luteal phase stimulation, pile up a lot of oocytes and get a good pregnancy. The only thing you did was commit her for 2 cycles. Did you really have any other advantage? How many of you actually went and did dual stim and still swear by it? And that is where we need to rethink. Why did dual stimulation come in? That conventional antagonist ovarian stimulation does not take full advantage of the follicular cohort. We then had studies that you will get more oocytes with luteal phase stimulation as compared to the follicular phase. We also had studies that luteal phase derived oocytes were as competent as follicular phase, and in fact you had a higher blastulation rate and more oocytes with so-called luteal phase stimulation. Pregnancy rates were shown to be double. So with follicular phase stimulated embryos 26%, with luteal phase stimulated 47%, and we were so happy, oh my God, we finally have found a magic cure for these patients. They also showed no difference in euploidy rates between follicular phase and luteal phase, and clinical obstetric and neonatal outcomes were also excellent with both the stimulated embryos. Then where is the problem? Why suddenly am I now not sounding so upbeat about dual stimulation? I just told you with the agonist trigger you can't do fresh transfer because it causes abrupt luteolysis. You know, it has a very short half-life, and the next day, within 3 or 4 days, and in the follicular phase in a dual stim, all of you know we give the agonist trigger. Within 3 or 4 days she menstruates, and then you start off the so-called luteal phase stimulation. So there is a twist in the tale now that we never did luteal phase stimulation. We were just doing 2 follicular phase stimulations back to back. So all this data, all these studies are now invalid because they don't make sense, because they do not represent true luteal phase stimulation. If you actually do estradiol progesterone levels 5 days after an agonist trigger, they are exactly the same as day 2 of a normal menstrual cycle. Then how are you calling it a luteal phase stimulation? Plus, now there is a lot of concern about macrosomic babies with frozen embryo transfer in the West. And with the so-called dual stimulation which we had to do frozen embryo transfers. So now the new thing, and which Polizos and Annalisa will be presenting at the ESHRE next week, I already spoke to her, the results seem to be very good, is the first stimulation starts in the luteal phase. So this is true luteal phase stimulation. You start it on day 17, 18 or 20. Give your agonist trigger, pick up the oocytes, she will menstruate, then do your follicular phase conventional antagonist protocol, give HCG trigger and do a fresh transfer with whichever embryos were of better quality, whether they were of the luteal phase or the freshly generated follicular phase. So this is how it has to be really done. Of course, they will not reveal all the success rates and everything until the paper is published next week. So I'm just eagerly awaiting the Copenhagen trip to listen to this particular, is it really going to help our poor responders? Of course, adjuvants, we are all now familiar with coenzyme Q, transdermal testosterone gels, growth hormone, of course, came and went. But now there is again a lot of renewed interest for 3 things. The 3 adjuvants which now seem to be working after a lot of to and fro. One is DHEA, which we all gave up on, saying no, it doesn't work, it's not good, it's coming back. Second is growth hormone. We said it's too expensive, there are too many regimes, as you can see here. There are so many different ways of giving growth hormone. But again, there is rejuvenated interest. And the third, which really works well, is coenzyme Q. But you have to give it in an adequate available dose. So 100 to 200 milligrams of the active ubiquinol component must be there for you, and at least 60 days to get the right thing. So the one study about coenzyme Q which really caught my attention is, can you really turn back a biological clock with aging ovaries? And you can see here, the top ovary is a young ovary, the second ovary is an old ovary. And the third one is the old ovary, this is of course in mice, after 15 weeks of coenzyme Q. So you can see that whole ovary is absolutely regenerated and as if it's become a very young ovary again. So there is definitely a ray of hope that coenzyme Q, if properly used, will give us much better results for these patients. Laboratory essentials, very important. And this is something I feel so strongly about, because most units, only 2 eggs, do ICSI. She's 37, do ICSI. What is the logic? Why? There is absolutely no logic to this. There are so many papers, and last 20 years, and just handful of us left who still do conventional IVF. Did you know that 95% of Indian units do ICSI for all, without any justification? There's more exposure to PVP, hyaluronidase, the atmosphere and everything, but yet nobody listened to me. Finally now, you have no choice but to listen to me, because this is breaking news from day before yesterday. I don't know how many of you attended this online ISAR global initiative. Valerie Baker first time released the data on 1.5 lakh infants born through IVF and ICSI, and I don't have a point. This has a pointer? So you can see here, this is very, very important. You can see here, these are major non-chromosomal cardiovascular genitourinary. Look at the last group, that is IVF, autologous, fresh transfer, ICSI with male factor, and this is the same ICSI done without a male factor. And this is the matter of concern. You can see 1.49. If we consider natural pregnancies as 1.49 means there is a 49% higher risk of an anomaly with unindicated ICSI, and here you can see 56% higher risk of anomaly with unindicated ICSI. Now this has to be a wake-up call for all IVF centers, that please switch back to IVF if it's an IVF case, and just do ICSI where it is indicated. And of course, don't take home a wrong message. When I say 50% more, it doesn't mean 5 out of 10 babies are abnormal. If the previous risk was 2%, means 2 in 100 babies were abnormal, with ICSI you are making it 3 in 100. But in a country like us, where thousands and lakhs of IVF babies are being born, this is a hugely significant number, and it's not fair to the patient when you know that unindicated ICSI can cause concern. And in fact, the highest, I don't have all the slides with me, and it's really, really interesting. You can see here, you will have 56 more major birth defects per 10,000 babies. 91 more per 10,000 babies and so on. And they have very clearly recommended that don't do double embryo transfer. More anomalies in twins is now proven fact. You have to do elective single embryo transfer. You have to make sure you don't do unindicated ICSI. With no male factor, you are increasing the risk by 30%. With male factor, you are increasing the risk by 42%. Of course, I asked Valerie online, what about the corrections for age and PGT and so on. So they are doing a lot of subgroup analysis now. And that brings us to the results, which I told you that do they have to despair the Poseidons 1, 2, 3 and 4. And this is the largest study published 2021 on actual pregnancy rates. And it's pretty heartening as expected. The young group, you still have a pregnancy rate of 27.8% even if they have less than 4 eggs. So very important point here, how important age is in correlating with success rates. If you get 5 to 9 oocytes, excellent at 48%, which is the same as group 5, which is the non-Poseidon normal responder group. So these two really do well. Of course, group 2, group 3, group 4, again group 2 with 5 to 9 does well. Group 3 and group 4 as expected, still not very bad at 20%, 15%, 30%. So there is a ray of hope even for the older generation, older group of patients. So of course, they clearly showed, as you can see here, that 50% lower, just age related. The future, of course, time is running a bit short, but just quickly, intra-ovarian PRP for poor responders. This is the largest paper of 500. Fortunately, we have Dr. Rajiv here who has done the largest series in India. Personally, I find it very difficult to inject vaginally, so I still do it laparoscopically. But I'm sure the vaginal results must be equally good too. And you can see here, you have an increase in antral follicle count. These are all statistically significant improvements in parameters. And mainly, the live birth rate at 34% seems to be very good, again in the younger age group. So under 38 does really well with the intra-ovarian PRP. But FSH should not be very high, AMH should not be very low, at least 1 or 2 antral follicles should be seen to get a successful outcome. And what if all fails? Of course, you have your famous 7 oocytes from that one altruistic donor who is donating only once in her life, only to your one blessed couple, and you are taking only 7 eggs for her, and you are not doing any commercial transaction. So that, of course, is a last hope for all these patients. And then now we've done normal and poor, now just the last category, and that is the high responder group and the PCO group. And here we know we had some major issues. The minute you would give a gonadotropin, the ovaries would explode, she would hyperstimulate, you had to cancel the cycle. This was all, of course, 10 years ago. And you also had a higher risk of early spontaneous pregnancy loss in the PCOS group. Finally, we conquered it with the 3 musketeer approach. So we know that if it's a potential high responder, you cannot touch the agonist protocol. You have to give the antagonist protocol. You cannot dream of giving her HCG or dual trigger. You have to give the agonist trigger, and you have to do freeze-all and subsequent transfer. So you can see here, again, antagonist pretreatment helps in a lot of PCO patients, especially those who have high LH or high progesterone on day 2. You can normalize the levels with just 3 days of the antagonist, and then you will get the same pregnancy rate per embryo transfer as your normal progesterone group. In this category, don't have a fixed day start. So in normal and poor, you must start antagonist on a fixed day. That is the 5th day of gonadotropins. But in PCO, you don't know when she will respond, and you don't want to suppress her further. So wait, keep giving, go from your 225, 300, 375, 400 till you see a response, and then begin giving the antagonist at, say, when you see 20, 30 follicles of 12 to 13 millimeters. Will we no longer be discussing the antagonist? Looks like, because a lot of PCOs really do well now with PPOS, that is progesterone primed ovarian stimulation. You give 10 milligrams medroxyprogesterone from day 2 along with the FSH injections, continue till the day of HCG, and because of the super maintained LH levels, you have much better outcomes. As Chen showed, it is not just suppression and reducing number of injections. Because you maintain low LH levels with progesterone as compared to your antagonist protocol, you actually have higher clinical pregnancy rate at 61% as compared to 47% in Chen's study, and they were quite a reasonable study with 300 versus 152 patients. So there is some food for thought here. You can use dihydrogesterone also if you don't want to use medroxyprogesterone. 20 milligrams is the same. And agonist trigger, as I told you, if you have given OC pill pre-treatment and over suppressed the LH levels, you will not get an optimal response for these patients. Add back HCG doesn't really work and still gives an unacceptably high incidence of ovarian hyperstimulation at 13.6%. I already told you the agonist is of course better, sorry for the repetition. And finally, of course, we have all been taught that you have to use pure FSH, you cannot give LH to PCOS patients. We just have one large trial now, and that is the Megaset HR trial, where they actually compared outcomes with REC FSH versus HP-HMG in PCOS and high responders. Fresh cycle outcomes were similar, but early pregnancy loss was almost half. You can see here 14% versus 24%. Because HMG is less potent, you will get 7 fewer oocytes, translating to 5 fewer metaphase 2s. You will get 4 fewer zygotes. You will get 3 fewer blastocysts, but you will get the same number of top quality blastocysts. So that is the first point that they observed in this large study. When you look at frozen embryo transfer outcomes, again, live birth rate per FET, non-inferior. Again, statistically significant reduction in early pregnancy losses. If you look at cumulative live births, that is one fresh and all frozen in 6 months, it was similar, but these were frozen embryos were all euploid, so they were PGT tested blastocysts, and they found that the same live birth rate was obtained with 43 fewer transfer procedures using 65 fewer euploid genetically tested embryos. Freeze-all, of course, this is one category where we don't have a choice, and we also know that they are prone to premature progesterone rise. The more oocytes that you have, the higher the incidence of progesterone elevation. Freeze-all will definitely take care because the high progesterone only affects endometrial receptivity and does not affect the oocyte and embryo quality. What about various phenotypes? And wonderful study by Dracopoulos and Blockhill presented at the last ESHRE that when you do freeze-all and conventional stimulation, don't do mild stimulations, letrozole stimulations, clomiphene stimulations for IVF cycles, you will find excellent cumulative live birth rate from one pickup, and all frozen transfers put together at almost 70% in all the 4 phenotypes. So today, this is the most successful method of treating any type of PCOS patients which we have. Again, a turnaround, just like no ICSI for all, and HRT FET, please don't do HRT FET for all your patients. We now have genuine concerns that 10 to 20% of patients don't produce as good an endometrium as they had in their natural stimulation cycle. Genuine concern that because you don't have a corpus luteum, because you have suppressed ovulation, higher risk of PIH and macrosomia. And just as we saw the breaking news data on ICSI causing anomalies, you may also in the future have with the same with frozen embryo transfer. So in PCO group, why I put this slide is that you can't do natural cycle because she doesn't ovulate. You don't want to do HRT cycle because of PIH. You have to do a mild ovarian stimulation and then time your transfer as per the ovulation date. This is again a very important slide. You know, most PCO patients have endometrial hyperplasia. All literature, conferences, we only keep talking of thin endometrium. Nobody talks about thick endometrium. So this is something we did at our center. We exploited the anti-estrogenic effects of clomiphene for this group of patients. So if she goes to 18-20 typical homogeneous endometrium, no triple line, just give her CC 100 or 150 days 3 to 7, add a little bit HMG, and 9 out of 10 patients your endometrium will not cross 12 mm. You will get a perfect triple line in these patients and you will restore your pregnancy rates. Of course, this is not yet published, but I hope once we finish 30 or 40 cases, we will publish that. It will be the first publication in the world because nobody has used anti-estrogenics of clomiphene for a thick endometrial hyperplasia in a PCOS patient. Do you need to delay FET? No, you should do immediate FET. Even in a PCO, you have aspirated 40 follicles. There are 40 corpora lutea. Don't get scared. Just start estradiol valerate on day 2 or whatever method you are following and do the transfer. And they have actual papers showing that if you do it in the immediate month following pickup, you have a much higher pregnancy rate. Of course, we already heard about metformin. And so to conclude, OC pills not recommended in PCO high responders. Antagonist protocol is the best. Addition of clomiphene, letrozole, etc. not recommended. REC, FSH and HMG equally recommended, again for the early pregnancy loss part. And routine use of adjuvant metformin. Metformin does not improve IVF outcomes unless patient has an indication for the insulin sensitizer. So this is the very line that you have to follow here. You don't have to just give metformin to every PCO, irrespective of a resistance, BMI and past history. Addition of estradiol measurements not recommended at all. The only hormone estimations I do for my patient, AMH before starting the cycle, beta HCG on the last day. We don't check anything else. No FSH, LH, estradiol, progesterone, nothing is required with all the modern day protocols that we have. Even if you aspirate 100 eggs with the agonist trigger, don't give cabergoline, don't give albumin, nothing else is required for these patients. So I leave you all with some food for thought. Antagonist pre-treatment works very well for poor and high responders. No OC pill for any group of patient. PPOS for all PCOs to reduce the early miscarriages, because we know PCO miscarriages are more often because of mitochondrial incompetence rather than genetic reasons. So PGT is not the answer for them. Just shift to the agonist trigger totally and then try to do a good frozen transfer in a natural cycle so that you have a corpus luteum and don't increase your PIH risk, and immediate FET with mild ovarian stimulation for these patients. So once again, thank you. Thank you very much, everybody, and Ferty9. And I know I took a lot of time, but I had requested for the same, so Jyothi was very kind. She said there will be no bell, no alarm, no. That was my only condition to come here. So thank you once again. Thank you so much.
Thank you, Dr. Jatin. I would really like to comment on one of your statements about the study COJ across the country. And what I have also observed is 80 to 90% all the clinics are doing only ICSI and not IVF.
95% in India.
And I have just downplayed it. More than, it was almost 100% when I was. And I think that's a very, very valid point. All the IVF specialists who are here and all the IVF people, I think you should keep on reiterating that.
No, on that online thing which ISAR had done with Valerie Bakers, there were 1700 ISAR members were online.
Yeah.
So I'm sure it spread like wildfire and everybody is now, going to go back a lot to conventional IVF.
Yeah.
So it's a good thing. We need to know this, and we need our own registry, compulsory reporting, which now with the ART Act we will have that.
Yes.
So we will have our own data because we have younger patients. See, the only thing I was a little worried is that the US group, most of them are 35 plus. So age related, we don't know how much was age related or, exact things.
Correct.
So once we have our own data, we will know what applies to Indian women.
Absolutely. Thank you very much.
Thank you so much, Dr. Jatin. I could not resist commenting. Each slide speaks volumes.
Thank you. Thank you.
It is an amazing talk, and I'm thankful to Jyothi for getting the sir as working as a catalyst. As Shanta has rightly told, you are Shah Rukh Khan of infertility specialist. Thank you, Jyothi, for making this conference, adding ice on the cake with his wonderful talk. One more thing is, Dr. Rajiv has become damad और आप हमारे समधी बन गए. Thank you.
Did you also notice that he didn't take a breath at all for half an hour? Yeah. He was continuously talking.
No, I thought 35 minutes won't be enough. So
And then one thing struck me when I was listening to you for since morning, actually, all of you. So according to our mythology, Brahma is the creator. But I think all of you have taken his job, and I think he's taking rest.
Thank you. Thank you so much. Thank you everybody. Now, sir.
Thank you so much. Thank you. This is my proud privilege to introduce the most charismatic speaker we have. He's president of Foxy in 2011, Foxy representative to Suffolk, Vidya Vibhushan Award by Foxy and ICOG in 2020, of Parchi Institute for Mother and Child Care, managing chairman of People Like Me Who Wants to Retire. You are stimulating, sir. Teaching is his passion, to be a man rather than a great man, but we all know he's a great man forever. Thank you, sir.
River chairpersons, star speakers of this particular great scientific day, Apurva, Rajiv, Ashish, and Sarukha, Jatin, and the interested fellows for this educational program and the team of Ferty9 led by Jyothi. Ladies and few men, I don't know whether they are gentlemen or not. Well, I bring greetings from the place of Lord Jagannath, and This is a place where I was born as a President Foxy way back in 2011. So I felt that it's a homecoming every time when I come to Hyderabad. And there are very, very common topics and complex topics in obstetrics and gynecology where this is true. If you are not able to convince, at least confuse. I'm not standing here to confuse you people, but over the years of my experience and treating such cases, I'll just convey messages, what is true and what is not true. Recent advances in recurrent pregnancy loss, RPL, has become really a challenge to the clinicians and a tragedy to the couple. And till today, a lot of researchers, conceptual advances, technological advances has been there, but still we are dilemma where to find the cause and treatment particularly. But this is true, that every pregnancy is wanted and every pregnancy is valuable. When we were students, there is a topic called valuable pregnancy. I was asking my teachers, is there some pregnancy not valuable? Now we think every pregnancy is valuable and every pregnancy is wanted. If this philosophy is there with the clinicians as well as with the researchers, I think they must think that loss of one pregnancy is a loss of life from the universe. That things will change and we'll get a good perinatal outcome for that. This is the fallacies of human reproduction. You're all fertility specialists present over here. Human reproduction basically is a negative phenomenon in comparison, in contrast to the veterinary, where it believes in multiples. This is scientific data which clearly shows that 100 exposed ova, out of which 84 become zygotes and 60 go to the infertility specialist from the beginning. From 84 zygotes, 69 implant and produce HCG and 15 fail to implant, failure of implantation, which is really a point of ponder research on the fertility specialist and all that. Out of that, 27 about promptly before the next menses. These are biochemical pregnancy, but no clinical evidence of pregnancy. Beta ICG is positive. And 42 persist as a clinical pregnancy, out of which 15 are lost in form of a clinical abortions, malformation, other pregnancy loss, and 27 are the survivors. So today, after realizing this scientific data, all of us should pray the Supreme Creator that all of us are 27 out of 100. So therefore, human reproduction is absolutely a negative phenomenon, there is no doubt about it. Now researchers and clinicians point at certain levels how to reduce this 42% clinical abortion of 15%, how to reduce that. Then the biochemical pregnancy, not clinical pregnancy, what are the factors involved in the embryo decidual talk where there is a defective and how to improve that. And lastly, the improvement of implantation. These are the three areas of concern before the clinicians as well as the researchers for that. So I will be telling about the clinician's perspective, not telling about some data, feedback, all the evidences, literatures and all that. I will not go for that. Basically, I'm a clinician and I want a clinician's perspective. When we come to the pregnancy loss, we divide into a biochemical versus preclinical loss and a clinical loss. Clinical pregnancies are divided into pre-embryonic, embryonic and fetal. And in trimester wise also we divide into first trimester, second trimester and late fetal loss. The division of these points to some common cause because that some causes which is there affecting the pre-embryonic is not related to the fetal loss. And some cases where there is a first trimester loss, the cause are completely different than the late fetal loss. So this is the main point for which we could point out that which is the cause in that particular age group. I am not deliberately omitting these two rare conditions, pregnancy on abnormal location, ectopic pregnancy, and pregnancy of unknown location now has become more common when biochemistry, the immunological beta ICG, as well as the high resolution sonography has demonstrated that neither in the uterus nor outside the uterus, somewhere in the body, will evaluate the case of pregnancy of unknown location for that. That's not my area of concern today. Now, as far as the clinicians, patients ask two relevant questions for that. Doctor, why this has happened? With one pregnancy loss also they ask, why this has happened? And you say that there are many causes out of which the genetic and all that, some defective embryo, defective germplasm is responsible for that. And if you go for a statistics, say 15% of the pregnancy are lost, first pregnancy is lost sporadic pregnancy, which we don't bother about it. So she is convinced. the second important question that, what will happen in the next pregnancy? Am I a baba or mama so that I will say tathastu, next pregnancy will be all right? That's $1 million question now in this era when conceptual advances in reproductive endocrinology, immunology, genetics and molecular biology, innovations of newer drugs and newer techniques, technological advances. Now this is a point of introspection where we stand now. It draws more controversies than consensus, more of guesswork and more of empirical treatment for that. Now the clinician's approach, first important is an evaluation definitive treatment. When you find a pregnancy loss and more so a recurrent pregnancy loss, you have to identify, find out what is the cause. But more important and equally important is the psychological aspects and counseling. Because these are the patients now we are seeing, even with one pregnancy loss, the couple is really depressed and they are very much worried about it with one pregnancy loss also. Because of the advanced age, the marriage, the career-seeking girl and very access to the net and Googles and all that, they consult various people and become confused about it. So this is important as a clinicians, we must find out the cause and at the same time psychological aspects and counseling should be there for that. Because this is, in 50% of the cases we could know the cause. In rest 50% of the cases we do not know the cause. Where out of it 70 to 80% will have a favorable course where they start, Pedersen has given a concept of tender loving care for that. What is a tender loving care? I could understand what is a tender, I could understand what is a loving, I could understand what is a care. But what is a TLC? It's nothing but an empathy, it's nothing but a psychological support and a counseling for that also. That's also have an immense value for that also. I can imagine, I can point one instance of mine, one patient came to me, 7 pregnancy loss, she was completely depressed, attempting suicide twice, rescued, absolutely depressed, psychic, they came, they have a total, I think, hatredness for the doctors, they sat beside me. She didn't like to talk to me. I thought she is repulsive of the doctors for that. And all investigations have been done, everything is normal for that. That's a case where no cause has been found but lost 7 pregnancies. How to deal, how to make an approach? I was confused about it. If I ask something, she will react. So without asking something, I found a locket of Lord Krishna there in the neck. Then I asked one question. Do you know Lord Krishna was being delivered in which pregnancy? She suddenly became cheered up. In 8th pregnancy. Now she has lost 7 pregnancy loss. She is really cheered up when I pointed this question for that. So I told, maybe that I do not know what is the cause, what will be the future. But at least don't commit suicide. Try once. Maybe that the Lord Krishna must be wanting to come in your uterus this time. And therefore try this time. And then you commit suicide. Don't come to me. Do you think, are you sure that Lord Krishna will come to in my body and my uterus? I told maybe. So I created a confidence in the body and mind of that particular person by these single words for that. And fortunately, by the grace of God, and by coincidence also, she conceived within 2 months, absolutely normal progress during whole of the pregnancy. And of course, I didn't allow for vaginal delivery, I did a cesarean section. And a male baby was being delivered, and he gave name of the baby Jagannath for that also. So this is one example of what is called a tender loving care. Without anything, we are always targeting for the treatment part and forgetting about the emotional aspect and the connect with the people in the human part of. Human part is also more important for that. So create confidence in the body and mind of the patient, you will be successful for that. Now confirmation of the pregnancy is another important part for that. Many patients tell that I have lost 2 to 3 pregnancy. How could you know? A period of amenorrhea followed by bleeding for 2 months? Is it a pregnancy? It could be a metropathic cycle, an anovulatory cycle for that also. So first a confirmation of the pregnancy should be there. You see for the reports of previous reports of other biochemical tests, HCG is positive or even UPT positive, sonographic evidence of pregnancy or some histopathological evidence of product of conception. Then only you can say that it's a pregnancy. Then there is a isolated versus recurrent. There is a different cause for that also, because one common cause is responsible for the recurrent pregnancy. Duration of pregnancy, I have already elaborated that. Type of pregnancy. From the history From the history, you can know the pregnancy, because nowadays with the era of technological gadgets, we are away from the touch to tech. So touch and clinical sense is also required gone are the days. So take history, and a classical example is the mid-trimester spontaneous loss and pointing towards cervical insufficiency. So this can be done for that. Sonographic scanning. I'm not a madman talking about sonographic and scanning, just to impress what is that. See the reports of the sonography and previous reports. And there is a difference of radiologists doing a sonography and an obstetrician, you people doing a sonography, there is a lot of difference for that. Radiologists give a sonography impression is that clinical, the sonographic evidence of missed abortion. Below it there are prominent two sentences, not for medical legal purpose, and second to be clinically correlated. So this is the report I am seeing with all my reports in radiological thing. But an obstetrician or you people doing a sonography, you should know whether the gestational sac is there or not, whether the gestational sac is normal or not, whether the gestational sac contains the embryonic pole or not, whether the embryonic pole contains cardiac activity or not. So these all are important. Even presence of yolk sac is there or not. If this is there, difference. If a gestational sac doesn't contain an embryonic pole or a fetal node, it is completely an embryonic pregnancy and mainly attributable to some genetic cause for that. Suppose the cardiac activity is there and then subsequently it has disappeared after 2 weeks. Certainly some of the factors responsible for that, either in the molecular level or in the vascular level or in the immunological level, which is acting on that and target for that. So this is the important for that. Modality of intervention is different. Any investigation, they come with a lot of investigations. Don't repeat the same investigation unless your spouse is a biochemist or a pathologist. Now the definition is a controversy and a consensus. The pitfalls in diagnosis, we have a simplified clinical approach, prediction and prevention. Definitely, we want more of definitive treatment than empirical therapy. Psychosocial issues I have already told for that. Now, the definition, there was a lot of controversy because now it has been solved, whether 2 or 3. Now 2 or 3, the 3 become ASRM of the world, S3 as the world biggest global organizations of human reproduction. And from the beginning, ASRM says that yes, 2 pregnancy loss, we call it as recurrent pregnancy loss, and S3 still resorption old is a 3 pregnancy loss. Now the current task force group of RPL in S3 also agreed with that the 2, and there is no controversy. 2, we call it as a pregnancy, recurrent pregnancy loss. But my point is that whether with 1 pregnancy loss, whether we investigate or not, because now with the changing demography, with elderly women going for a pregnancy at the age of 35, 36, with 1 pregnancy loss, then you say that no, don't investigate. You come and fulfill the criteria of definition of recurrent pregnancy, then I will investigate. That's not important for that. So do some investigations, preferably non-invasive investigations, even with 1 pregnancy loss for that. Now identifiable factors, these are all genetic, immunologic, anatomic, infective and endocrine, are they belonging to the 50% factors, and rest 50% we are very satisfied with the use of what is called idiopathic. Idiopathic, I believe that idiopathic should be obsolete from medical dictionary and should be replaced by what is called a cryptogenic. Our booster antenna is not able to capture those, and that's why we call it as idiopathic. My definition of idiopathic is when the doctor is an idiot and patient's condition become pathetic, it is idiopathic for that also. So these are some gray zones, very early pregnancy loss, embryo or the endometrium, the talk between that, implantation failure, ART pregnancies, recurrent malformations, recurrent molar pregnancies, PCOS, declining ovarian function. Even you see the diminished ovarian reserve, you get a pregnancy, but ultimately the quality of the ovum is such that it becomes a miscarriage for that. This is one of the cause. A defective quality of the embryo is important, particularly in the case of declining ovarian function as well as in a PCOS. Male factor abnormality, I think the fragmentation, DNA fragmentation, some people attribute for that also, but I have done a study of this. I didn't find a correlation between DFI and all that. Stress and pregnancy waste is different. And there are some women, they are destined to lose babies and they are deprived of motherhood for that. I say these are unlucky mother. They have a mixed pattern of loss. I have seen many patients, they have experienced everything. Whatever written in the fetal medicine, they have got it. First trimester loss, second trimester loss, congenital malformation, then secondary infertility, then IUD, late in the labor and all that. This I called an unlucky mother. So in obstetric end result, I say 4 combinations and permutations. Lucky mother and lucky obstetrician, excellent prognosis. Unlucky mother and unlucky obstetrician, worst prognosis. lucky mother and unlucky obstetrician, unlucky mother and lucky obstetrician, mixed prognosis for that also. I imagine where some of my patients who have lost 4, 5 pregnancy and all that, all types of, these type of cases, the patient don't leave me and I say that yes. Then I write, what next? I give a prescription. And she moved to one pharmacy to another and she find, sir, the medicines we have written has not been followed up and nobody understands this medicine for that. Then they came, what is the medicine I have written? Change the doctor. So this is the prescription I give it, change the doctor. Maybe that your star may be very conversant with the other star so that you may get a result for that also. Genetic. When my teachers were teaching genetic, the immunology and endocrinology, this is a very good hypnotic and sedative dose. I don't want to repeat this for that. But remember, there is a lot of battle and lot of debate between the parental karyotyping versus abortus karyotyping. And just for the clinicians, remember in the parental karyotyping, one thing you notice, whether it's a balanced translocation. When you find a balanced translocation, you can be a baba and mama. You can say that yes, next time you will have to abort for that also. And there you send it to Jyothi for some gamete transport, this side, that side and all that. Immunologic, APLA has a strong correlation. Initially, APLA was considered as one of the synonymous with RPL, but now this spectrum is increased to recurrent pregnancy loss, from recurrent pregnancy loss to early onset pre-eclampsia and eclampsia. And eclampsia, remote from term, is a distinct entity related to APLA. IUGR, IUFD, particularly in second and early third trimester, these are APLA particularly for that. And there is evidence-based and there is a treatment, new hope for that. So these LA, SCL and beta-2 glycoprotein there. There are two methods in which you diagnose APLA. One is a clinical criteria, another a laboratory criteria. You do an APLA test and get a positivity result for that. But there is absolutely very variable for that. It's not at all dependable. The clinical is more dependable criteria of that. One or more unexplained death of a morphologically normal fetus at or beyond 10th week of gestation with normal fetal morphology documented by ultrasound or by direct examination of the fetus, or one or more premature births of a morphologically normal neonate at or before 34th week of gestation because of severe preeclampsia and eclampsia or severe placental insufficiency, or 3 or more unexplained consecutive spontaneous abortions before the 10th week of gestation with maternal anatomical and hormonal abnormalities and paternal and maternal chromosomal causes. Any one it is found, think that is APLA syndrome and start treatment with that. There is a revolutionary treatment for that because APLA test is reliability is very question mark for that because widespread interlaboratory variables, 2 tests are required and all these confusions about these tests for that. And these treatment traditionally we are giving prednisolone and aspirin, now heparin or low molecular weight of heparin with aspirin is the rewarding results for that. So both are same, effectivity both are same, both have a benefit and risks also. Heparin when we give, the only benefit is the low cost. But heparin when we give, in 3 doses you have to give it and repeated monitoring is required for that. Repeated periodical PTA, PTT monitoring is required for that also. These are the main demerits. But low molecular weight heparin once a day, 24 hours and the cost is little more, no monitoring is required for that. I remember Santa is here. Santa was the chairperson of the Food and Drug Committee when I was the president of FOXY. And I gave all 27 chairpersons my cabinet ministers. I brought the funds from the different company. One company, you do 25, 50, 100 CMEs on that particular aspect, all over. Santa told, sir, I'm a Food and Drugs Committee. What topic I will make it for that? I remember this is one, at that time, the low molecular heparin was very new concept for that. I told that you do this and take a company with that and pharmaceutical. Did more than 50 CMEs across the country and the name I have designed, low weight and high impact designer molecule, this LMWH. And Santa is the main person. He done a lot of CMEs on this particular thing on RPL. And the companies were also very happy that we could be able to bring the molecule from angina to vagina. From that was used by cardiologists for a very short period for 5-7 days. Now they are used for 8 months. So they are very happy and this has a rewarding results also. We do not promote the company as such, but these are rewarding results for that. And because you see, heparin aspirin versus heparin, 54% increase in live birth rate for that. Increased live birth rate, when to start, how long, what doses. Earlier the recommendation was that as soon as the fetal heart is demonstrated by sonography, you add heparin or low molecular weight. Now there is a change. Even we learn from the infertility specialist, right from the embryo transfer, they are giving some cases with implantation failure. We start little earlier, even before the appearance of the fetal heart rate for that also. Now, anatomic factors, the uterine factors. These are some of the uterine factors. You can see a big submucous myoma, a grade, I think a grade 0, grade 1, or even grade 2, FIGO. I think these are the causes for the recurrent pregnancy loss, and identify these. And hysteroscopic surgery is one of the prominent things where you can do it. And now it is done all by bipolar, not by unipolar with the glycine toxicity and all that. Either with a single sitting or with a double sitting. Now this is again a case where we find this Mullerian anomaly. Mullerian anomaly earlier was being diagnosed by hysteroscopy. Now it can be diagnosed by 3D sonography for that on MRI. So these are very, very rewarding results. The only thing is that it's a 5 minutes procedure for hysteroscopy resection of the septum, and you can get a very good result for that. There are still controversies whether it is recommended for arcuate uterus or not. What is the muscle which is remaining above? Whether by doing a MRI or 3D scan for that. But this is absolutely rewarding for that. Now this is another case where synechia, incomplete synechia, cause of recurrent pregnancy loss. Complete synechia, cause of infertility for that. So these are all very rewarding surgery for the hysteroscopic aspect for that. Cervical insufficiency. When we were reading, we were discussing about cervical incompetence. Now it is replaced as cervical insufficiency. The structure and function are both important for that also. So magnitude of the problem is overestimated, nature of pregnancy loss, diagnostic modalities, and the treatment options for that. This is one of the example where the treatment is during the time of pregnancy, and suture, the cervical encerclase is the rewarding surgery for that in a case of cervical insufficiency. Of course, there are more lot of literature combining with the progesterone versus this cerclase for that. But cerclase, where you put it, when you put it, how you put it, and what materials there is a lot of deviation for that. Where you put it, I think the levels, 3 levels. Initially, it is at the level of the internal os. At the level of the internal os was the first. Then the McDonald came below the level of the internal os, which is becoming easier. And if it fails, high cervicoisthmic cerclase nowadays by the endoscopic procedures, by the laparoscopic procedures. So the different materials are used, starting from the silk to the proline to the sheath, other very sophisticated sheath or sutures which is there used for that, like Marcelin tap. Now, this is a McDonald, very simple. We are using a Aam Aadmi Ka doctor. I never use this Marcelin's, I think, tap, which is very costly for that. I use this number 4. Suture India is manufacturing cervical suture, and number 4 with a round body needle, 30 mm, and just retract the anterior with the speculum, retract the intravaginal wall, and that you can get a length of about 3.5 to 4 centimeter for that. And it's very easy procedure, the McDonald's and cerclase. Now, as an endoscopic surgeon also, I tried where they failed. All the sutures, the earlier sutures they have given, they're still not working in that, or she has underwent some Fodder's repair or amputation where a high suture is required. This is a cervicoisthmic suture by laparoscopy. By laparoscopy, there is a defect in that. The puncturing in the wrong place will have torrential bleeding for that, and it's technically a little difficult. More important is that in case there is an IUD, in case there is a congenital malformation, in case there is a leaking, how can you remove the suture? You have to again do a laparoscopy or laparotomy or a colpotomy to remove the suture for that. So I found as a vaginal surgeon why this cannot be replicated by vaginal route for that. So vaginal route, if it can be given, anteriorly I dissected it, posteriorly opened the pouch of Douglas, and then put the suture in the cervix in the posterior fornix in the vagina, and then the same thing at a higher level, it goes medial to the vessels in the substance of the cervix, anteriorly with the same suture, and bringing down the nut is in the posterior fornix. So this is, I've done almost around 30 cases till now, and the results are very promising for that in comparison to the laparoscopic approach for that. Now the rescue cerclase is there again when there is a bulge, the membranes are bulged, and the rescue circle is by Foley's catheter. You just insulinate it, replace the membranes, and you find I've done almost, but 30% I've become successful. 70% out of this 50% usually ruptures during the time of examination. Or after 1 week, within 1 week, they give present with the leaking for that because of the infection. But at least 30% you get a very rewarding result of this particular thing with the technique of introducing this Foley's catheter and replacing it and find the good length of the cervix. And then after the suture, you remove this Foley's catheter and get a good length of the cervix, and this is done. Infections, torch, say no to torch. It's a myth rather than the reality. And endocrine. Endocrine, apart from other androgen excess, hyperprolactinemia, diabetes mellitus, and other metabolic disorders. Main attention is given for the last 1 to 2 years on progesterone. Any pregnancy, progesterone. So use, abuse and misuse of progesterone is being there for that. I won't want to confuse you. By this time you must be loaded with progesterone, starting from the pregnancy, beginning of UPT positive, till the end in the labor also it produces. Even you give your own partner one progesterone along with that, the pharma people will be very happy for that. So progesterone reproduction, I won't want to tell details about it, but this is a steroid nucleus which is a 27 carbon atom compound clipped to 21 carbon atom compound, all progestrogens, 19 carbon atom compound, all androgens, and 18 carbon atom compound, all estrogens for that also. It's a mother hormone, but the history and nomenclature is very, very interesting. George Corner was the first in 1928 who isolated from corporality of sows and designated named it progestin. 6 years after, the more political group, very highly political group, European group, Botner and Skimmed, isolated the same thing. But they didn't agree with George Corner. And they gave a different name, luteosterone. Sir Henry Dell wanted to compromise and a happy marriage between these two controversial groups. And it took 1 year. In Second International Conference on Standardization of Sex Hormones in London in 1935, he suggested bring progest from Corner and bring sterone from the European group and make it progesterone for that. And since 1935, the matter is solved. We are using the term progesterone, progesterone, progesterone. And these two, I must emphasize. There are 6 groups of progesterone, out of which in pregnancy, we want progesterone, 6-dehydroerythroprogesterone, dihydrogesterone, and 17-alpha-hydroxyprogesterone. 17-alpha-hydroxyprogesterone is well a quiescent effect. That's why it cannot be used in first trimester pregnancy. But mainly with the micronized progesterone and dihydrogesterone, there is a lot of debate of use of that. One says that is superior, one says that is inferior. But lot of trials, the PRISM trial, Premise trial, and the Lotus 1 and 2 has really solved some of the issues for that. Although there are some different subtypes which is required for that. All RPL do not require a progesterone. That is very important for that. Now the main thing which is used in first trimester, what is a progesterone? Progesterone is any agent which is converting from proliferative to secretory changes. And in endometrium there are stroma and the gland. The stromoglandular synchronization is done with 2 progesterone. One is dihydrogesterone, another is micronized progesterone. The rest of the progesterone doesn't cause stromoglandular synchronization. So we select a progesterone which is used in reproduction, particularly when stromoglandular synchrony is required for that also. So this is, you ask yourself, does all pregnancy require progesterone supplementation? And for whose interest is progesterone supplementation necessary? Whether the patient or the pharma or the physician. It is the need of the patient rather than the mood of the obstetrician. That is most a priority for that also. And find out the rational use of progesterone in reproduction, infertility, LPD, LPS, all of you are experts in that. Threatened miscarriage, recurrent pregnancy loss, subchorionic hematoma, and of course preterm labor for that. So these are all which is known to you in following IVF, following IUI. Progesterone supplementation is there for that. I don't want to go into the details of the controversial aspect of this regarding the trial. But this trial is very promising. It has solved the controversies and bringing out a consensus out of it also. So a class of doctrines is not a disaster. It is an opportunity for all of us to find out and have a rational treatment modality for that. But even with that, even we are man of science, and I'm a strong believer of destiny and a strong practitioner of medicine. And even with that, we lose hope. And this is a goddess. I think Apurva must be knowing that. Those are coming from Tamil Nadu. There is a place close to Trichy. There is a temple called Sri Garvaraksha Ambigai. And lakhs of people go there. Only people who have infertility or a pregnancy loss. So this is specialized. Her portfolio is on pregnancy loss for that. So even God has a cabinet, the Prime Minister has distributed different cabinet minister, the Minister of Finance is Lakshmi, the Minister of Energy is Kali, the Minister of Health, somebody else. But this is out of which one particular segment is given to them. And this goddess is given a segment. You only deal with recurrent pregnancy loss. And lakhs and lakhs of people failed with us and they go there, and maybe that the strong belief can make them success for that. Thank you very much, all of you and ladies and gentlemen.
Thank you, sir. Thank you, sir. It's an excellent privilege to be sitting there on the dais with you, sir. But the greatest point that you have told lots of us here, because most of us are not IVF consultants, is the role of empathy, sir. Empathy and the story of Sri Krishna. Yes, sir, we agree. We have lots of seen patients coming with 2 or 3 somewhere else and coming to us with the same treatment, conceiving again, sir. So I think it's a great take home for all of us.
Thank you.
The story of Sri Krishna must be, sir. 8th also is possible. Sir. Thank you, sir.
Thank you so much for such an excellent talk, sir. It is our privilege to chair the session. Thank you.
Thank you.
What a session. Thank you, chairpersons.
Can we take photograph with sir?
Oh, sure. You want to do it on the dais, ma'am?
If possible, lunch together. Jyothi, come.
It was an absolute honor to listen to such esteemed personalities with adept knowledge in the field of infertility. Thank you, sirs, for sharing your knowledge. It will be a great pleasure to listen to you again in our future events.
You overestimated me.
Ladies and gentlemen, now is the time for lunch break. Before we break for lunch, a small request to all the delegates present over here. We would like you all to pen down some of your difficult cases which you have encountered in your day-to-day practice and hand over it to the person on the AV desk at your left side. So that these can be discussed in the panel discussion post-lunch. Thank you, everyone.
I've sent another large.
So welcome, sir.
Good afternoon, everyone. At the outset, I'm really thankful to Ferty9 for calling me up. And it's a huge crowd I am seeing after a long time after the ESAR conference what we had. Welcome all my panelists and my co-moderator Apurva, I will call her up here. This is regarding, we'll do just a case-based discussion. What actually, we don't go into the literature reviews and we will be pertaining to what we do it in our clinical practice, we'll talk about. Yeah, so the question is, she's 28 years, married 4 years, irregular cycles with the severe dysmenorrhea, has 3 failed IUI cycles. Do you feel that if the IUI, what we gather the information prior to the IUI, the tubal testing has to be done and all that thing has been done and she has 3 failed IUI cycles, do you feel the role of the diagnostic laparoscopy should be advised? And what is the pre-operative counseling you will do and what is the mode of the treatment? Because if she has been done the ovulation induction cycles, anything else you wish to ask to me, what details, things you need to ask about this patient, because she's 28 years, 4 years of infertility, irregular menstrual cycles and 3 failed IUI cycles. Anyone can answer. It's not like... Yes, not working.
To go ahead for a diagnostic laparoscopy because she has complaints of severe dysmenorrhea and 3 cycles of IUI have failed. So probably we should be looking to see if there's any endometriosis in this patient. So preoperative counseling definitely is required because we have to counsel, we have to see, and she has irregular cycles as well. So if there's any PCOD also, we should be counseling her that we may proceed and do a drilling also.
Any other history you wish to ask me, like prior to the laparoscopy? Because see, if she has undergone 3 IUI cycles and which has been failed, before going into the diagnostic laparoscopy, any other history you wish to ask? Like you directly, male factors, okay. For male factors you will implode on. Yeah.
It's loud.
Yes.
Yeah, IU has been attempted. So we will go back to see how was the pre-wash and the post-wash sample. Probably that should be...
So before going into the diagnostic laparoscopy, you wish to talk about the male factor evaluation. So already because the 3 cycles are been done, what we take home message from Dr. Rajiv that more than 4 IUI cycles will not increase the success of IUI.
Correct.
So that comes down to the one boiling point that whether we should go with the diagnostic laparoscopy or not. So in your routine practice, do you take the consent of the diagnostic laparoscopy or maybe it is always a diagnostic with the operative laparoscopy per se?
Yeah, but the both has to go in hand. There is no time for us to wait because 3 cycles of IUI has been failed. So mode of treatment will be find out, scan findings should suffice about relatively any endometriosis, any tubal factor involved. Based on that, we will go.
So if
Definitely
on the
operative-
diagnostic laparoscopy, you have done the diagnosis and this is the picture you find it out.
Yeah.
So at that particular point, you call the patient's relative into the OT and talk, this is the picture and this is the modality. What the modality of treatment you like to go in this particular case? That if she is having the grade 1 endometriosis, you can see that there is a peritoneal endometriotic implants. So what is your, like as a laparoscopic surgeon or maybe a infertility specialist, what you will talk to the patient?
Go ahead and do the ablation. We have to go for an operative laparoscopy and first of all
restore
stage
the anatomy and the recurrence for grade 1 endometriosis to recur and the ovarian tubo anatomy can be distorting at any point of time. So we have to be little quicker in giving her the fertility management because 3 IUIs has been done. The next mode would be not waiting much and then we can advise another level of ART if possible.
So in general, when you're talking about the diagnostic laparoscopy, you find it out there is a grade 1 endometriosis. Whether you're still going to do a ablation or the peritonectomy, because nowadays there is a laparoscopic surgeon, they come up with a different thought process and IVF consultant, they come up with a different thought process. What are the precautions, if at all you wish to go with the ablation, what is the management you would like to do? Or if you were going to do a total peritonectomy, whether it is really going to help for the patient or whether it is just a boon in endometriotic surgery?
I think ablation is sufficient for this grade 1 endometriosis because there is not much...
there's no much difference
Anyone?
between...
Yeah.
Endometriosis is a recurrent condition. Whether you do ablation or you are doing that full peritonectomy, the patient will be having recurrence rate. So instead of doing peritonectomy, if it depends on how far the endometriosis.
Yeah, this is the real picture. So what
for only
we
this
had.
picture concerned, we can do only ablation and checking the male factor part. And endometriosis per se, it's a progressive disease. Now only the peritoneum is affected. In further coming years, she may be having ovarian endometriosis also. We have to rule out how the AFC and AMH also for this patient. Depending on that, we will counsel. Definitely when you are doing a laparoscopy, we have to counsel them prior hand. In case if anything is required during the procedure, we are going to do therapeutic procedure also during the OT. So we will take the consent beforehand.
So we'll just ask to the audience, there are the 2 school of thoughts. If you can just do the Facebook or anything, the people there are doing a endoscopic surgery, they will do a total peritonectomy. And those who are doing a fertility preservation will do a ablation of the implants. How many of you think that the total peritonectomy will be helpful for the patients? Because there are the 2 school of thought in here, like the peritonization occurs in 48 hours. So do you believe in total peritoneectomy will be a ab treatment or just ablation? And after that, what is your course of treatment? You will do a wait and watch, or you do a control ovarian hyperstimulation and IUI, or what is your protocol? Because here the factors now of failed IUI maybe it could be because of the endometriosis. Yes.
We don't wait and watch, sir, because it is an endometriosis. It will be progressing day by day. So we don't wait and watch. Obviously, we will be doing active treatment itself. So it is a grade 1 endometriosis. Whatever the necessary treatment should be given, it has already been given. So better we should counsel the patient for the ART.
Yes.
Treatment.
Here I wish to quote one beautiful event that usually happens, that if our endoscopic surgeon is doing the operative, he will always go for a total peritoneectomy. My friends, when you do a total peritoneectomy, it's not a standardized treatment yet. Because what is the proportion that what they're talking about, you are to take the disease out. But the endometriosis, you never know what is the recurrence rate. So it is better in which peritoneum it has been affected, whether it is a nodule or it is just a multiple spots, that is a cherry spots what you are seeing in a laparoscopy, or if it is a nodule. If it is a nodule anywhere, then definitely it has to be excised. And if it is just a peritoneal, what you call as a early endometriosis, because endometriosis has two lesions. First is a pink lesion and then you have a fibrosis. If you see at the fibrosis, then it is definitely old endometriosis. It won't be get curatized, whatever you are going to do. It requires a restoration of the anatomy, and then what rightly said by her, it's you required a COH in a later half. Considering the same, if she is not going for the laparoscopy, what is the line of treatment you will need to offer? Because the early endometriosis is not going to get diagnosed. If it is a endometrioma, definitely it's going to get. So if there is an endometrioma and she doesn't want to go with the operative procedures, what is your...
Endometrioma, not necessarily what we need to go for an operative procedure. Endometrioma less than 4 centimeters can be left alone without any operative procedures before any other treatment we follow. Rightly, if the follicle is
but
not...
endometrioma 4, along with that you will consider something that is only the
definitely.
endometrioma 4 will be my cutoff, or maybe along with that it is the age of the patient, duration of infertility.
Age of the patient.
Symptomatic or not is also important. If the
Yes.
patient is symptomatic, she requires...
So any symptomatic endometrioma, definitely we need to have a surgical management. If at all you wish to go with the endometrioma treatment, for that matter, you have done this is a endometrioma surgery on the endometrioma of the ovary. What precautions you will like to take as far as the endoscopic procedure is considered? And pre-operative evaluation of AMH is good enough to tell the patient that my success of the surgery, because if she is coming from the IT background, she know that my AMH you have to do it because there is ovarian endometrioma. The endometrioma itself causes a poor ovarian reserve. And I will do the endometriosis surgery with you. What is the impact on the AMH to me?
Yeah, because all are very well known about AMH. So right now, definitely before we put a port, first indication would be the pain. Dysmenorrhea is the first indication that we need to put a port, irrespective of endometrioma size. And definitely AMH has a greater impact before we go and do any kind of endometrioma surgeries. And we should be very careful that we do a blunt dissection rather than using any other cautery, so that we are preserving the cortex of the ovary, so that the follicles are maintained.
Cystectomy needs to be done. Cystectomy, no ablation, no incision drainage. And,
so when you do a cystectomy, my friends, the chances of normal ovarian cortex is going to come up. What are the techniques? Even if we are the best endoscopic surgeon, you never assure that the particular ovary is not going to get damaged. So if I do a AMH retesting again, how many months after I will ask the patient if she wants to do it AMH and assess your surgical skill?
Yes.
So after 6 months. Anyone else wish to differ about it?
After 3 months?
Yeah. And if after the 3 months, do you think the AMH will be, if it is a 2.5, come down to a 1.6? So she will be after you that because of your surgical procedures, my AMH will go down, and what you will counsel to the patient?
It may not be entirely due to my procedure because endometriosis itself is a destructive type of
Yeah,
disease.
but madam,
So
you had
because
done the
of that
laparoscopy
also-
for the completion of the procedure. So she will say, you had done my complete procedural completion of endometriotic surgery. So how my endometriosis again in 3 months causing the AMH down?
Sir,
Yeah, perioperatively she said, no, okay, fine, it is a 3.5. Suppose that time it was 3.5. You advised her 3.5 is a good ovarian reserve. She accepted for the procedures to undergo. And after the procedures, the AMH comes down after 3 months. Because it's usually a clinical scenario what we find it out. And then what is the take on that particular patient? How will you counsel? And what is the next line of a treatment?
We can reassure her.
Yeah, no, you can reassure her. But what is the
Because
reassurance
she's
that you will
still not
do?
into a poor ovarian reserve. We can still reassure her because she's within the limits of AMH. Definitely that would strike in an OPD.
See, why I ask this question, whenever you are going for the cystectomy, the standard of care of a cystectomy is not only the drainage. When you do a drainage in a particular patient where there is age is advanced, AMH already been poor, and she's symptomatic, endometrioma. In those, only a drainage will be a possibility. You will not do a cystectomy. But if the AMH is good, she is young patient. What I mean by the good is a normal responder or the AMH comes into that range. And if she is a younger patient, you do a cystectomy. But you need to assure that when you send the cyst wall for the pathologist to diagnose, it is not an endometriotic cyst wall. You have to see how much is the cortex is been come out. So whenever you have to give the report that these are the particular things that have been come out and these are the ways what we are. And after the 3 months, you have to talk to the patients. There is a definitely decrement in the AMH. And that's why I will be selecting the patient in whom the patient is young one, patient is having the normal AMH, and a patient is also having the symptoms. Then and then I will operate. Otherwise, I will not operate pertaining to that of endometrioma. And if at all she is a symptomatic with the older age group with the low AMH, I will operate, but I will just do a drainage. I will not do a cystectomy if at all she is symptomatic. If she is not been symptomatic, I will just do a directly IVF because she is an older age patients. We know the AMH is low. It is better to go with the IVF protocol. So if at all she refused to go all these discussions and she said, I don't wanted to go with the surgical exercise.
It's a best decision, that too, because definitely endometriosis dictum is recurrence. So minimal handling, definitely we'll go with the AMH values and then accordingly. Direct going to IVF is also can be done without a preoperative.
Okay, so my questions from this side. What is the ideal protocol in endometriosis? Stimulation. We'll go one by one fast and then we'll go to the live case that anyone has given to us from the delegates.
we can go for antagonist protocol, and some people may prefer down regulation and then give
What is your choice of protocol? Is
Usually
antagonist
I
protocol?
go with
What about you,
antagonist
madam?
protocol.
Yeah. What about you?
The low AMH is low, we'll go with the mild stimulation protocol and definitely antagonist
Okay,
protocol.
so mild
itself.
stimulation, antagonist.
antagonist.
What about you, madam? Antagonist. Okay. If you do any pertaining to the dose, you start with the higher dose. As Jatin shared, should be a 250 to 300, maybe a 450 or maybe higher.
So, patient with endometriosis, we give 75 international units higher than what we normally decide for that patient.
Why you thought of giving a higher dose of 75? Because she is endometriosis.
So, some risk factors we generally tend to give a higher dose, an additional dose.
Okay. So if the patient is normal, you start with the 150. If the patient of endometrioma, you thought of giving add a 150 plus 75 to 25.
Cystectomy,
No. It's the endometrioma. What is our case is 5 centimeter endometrioma, asymptomatic, but having a poor ovarian reserve. So we start off a stimulation. Both of them was started upon antagonist. She said, okay, I will start with the short protocol. You start with the 75 units of a higher. See, why I wish to ask all of them, you need to understand when we are IVF consultant, we thought of a different angle in a different ball set. The patient is the same. They are both are talking of a different protocol. She is talking about increment of the dose. We'll have the third panelist here. I will ask, okay, you increase the dose. and you have the follicles which is generated on 5 follicles on the 7 on the right side, 4 on the left side with the endometrioma. What is your trigger?
I would like
Antagonist protocol and if short flare up. Yeah.
Okay. I would like to add LH also from the beginning, maybe according with the recombinant FSH. And then coming to the trigger.
Okay, now see, here is the again dilemma. If you wish to have, any one of us are here endocrinologist, proper endocrinologist, DM. In endometriosis, we have a 2 LH, that is called as hump. We have a bilateral hump in LH. If she wished to start the LH from day 2, her oocyte quality will not be that appropriate. So that is the first thing when you're talking about the LH in endometriosis. And the oocyte quality, there is a different altogether papers also. When you are oocyte quality, whether it is hampered in endometriosis or not. Now recently at 2022 papers, they said that the oocyte quality doesn't show any of the changes. What it will show you are the number of eggs retrieved as compared to the which of the protocol. So I will come down to the 2 ladies first. The short flare-up and antagonist. I think I will not go with the antagonist protocol, madam. Somehow I will not liking it. And current literature also doesn't like the antagonist protocol in endometriosis. Can you counteract me, because we have a healthy discussion, it's not a panel.
If I look into the synchronicity of the follicles, if she is having a low reserve with endometriosis, where there is a high chance of asynchronous cohort, then I would definitely go with luteal phase agonist and then synchronize it, long protocol what I can say. If at all she's a young patient, good reserve, and then there is always good...
She's a 35 age, 5 centimeter endometrioma, married for 2 years. And that's why we are doing with the stimulation protocol. Surgery, she said, I don't want it to go with the surgical. So we come down to the IVF protocol. So in this patient...
with good reserve.
Yeah.
Yes, sir? Good reserve, and still I can go with antagonist.
Okay. So mind well, my friends, when you're talking about the protocol, is a agonist or antagonist protocol, why I'm not happy with using an antagonist protocol in this particular frame of time? Because agonist itself is a treatment policy. Secondly, I know the chances of gonadotropin injections will be on a higher side. I do understand that. But mind well, friends, when you are talking about agonist protocol, the chances of M2 retrieval is on a higher side as compared to the antagonist protocol. So I wanted these patients to give me a M2 oocytes on a higher side, because in my mind, when you're talking about endometriosis patient, there are the 2 things will happen. The M2 oocytes, even if it is a M2, the mitochondrial contents of the M2 oocytes is on a lower side. So even if I do the ICSI or maybe IVF nowadays, what Jatin was talking about, is a similarly success rate, but I wanted to have a blastocyst formation. So if I have a M2 on a higher side, my chances of blast formation will be higher. The chances of ongoing repeated IVF cycles are higher. And that's why I will not be little bit disagree. Okay, you may have antagonist protocol to follow. Pertaining to the another panelist, she talked about the LH, whether I should be adding the LH from day 2. Here the endocrine system plays a role. When you're talking about the LH in certain situations, if the LH in PCOS, the PCOS is a different phenotype A, B and C and D. I will not go into that. But in endometriosis, pertaining to this case, the LH has a double hump. If you see the LH of the endometriosis patient is always in the middle it is high, and in the day 2 it is high. When you start stimulating the patients, you do it by yourself, you will come to know. So if initial LH is high, that's why we don't want LH high in our stimulation. What is the rule of 5? The LH less than 5, progesterone less than 0.5 and E2 less than 50. Why we talk about that down regulation? Because initially we required the FSH receptor sensitization and then the LH comes into circulation. Similarly, if you have the LH on higher side, what she was talking about, adding of little bit LH will cause detrimental effect for the oocyte quality, which is, we don't want the endometriosis to happen. So coming down to the trigger, so trigger, definitely you use a dual trigger, or maybe if it is an agonist cycle, definitely SCG is the gold standard. What are the precautions you will like to take when there is a 5 centimeter endometrioma and you are going for the pickup, or a gynecologist send you the patient with the stimulation and she has clearly given the note. There is a 5 centimeter endometrioma on the left side, and then there is a cyst follicles. So what is the precautions? Any anesthesia, any antibiotic, any needle changes, everything we can talk about. Yeah. We'll give a chance to, yeah, you can. Because all of us are colleagues, so it is better that we should discuss rather than asking questions.
During pickup, we should not injure the endometrium. We should not puncture the endometrium. Then post-operatively, we have to give injectable antibiotics.
Anything else? Yes.
Even if we puncture the endometrium by accident, better we take out the needle and better we flush it with the media. And then we can reinsert and then aspirate the follicles to avoid the detrimental effect of the endometriotic fluid. It will affect the whatever oocytes we are going to aspirate next.
So you will finish with the normal side first, and then you will come down to the endometrium.
We'll start
so
with the normal
anything
side
else?
first.
You inadvertently do the puncture, and your andrologist or maybe a embryologist said that it is coming up with a brown color. So what you will see? You wanted to flush the needle, or you wanted to change the needle?
Generally, we flush it, or if the material is very thick and the needle got stuck, then we'll change the needle and we'll start with a new needle.
Okay. Now we'll go. Whatever precautions you had taken, and on day 2, she had come down to you with the pain. The patient may come, no, because it's a live situation I'm talking about, not hypothetical. So what is your first thing in your mind? Because you had sent the patient again to her gynecologist, and she just called you up. She said there is a patient is complaining of pain on the left side again. On the right side, she's pertinently saying that there is a pain on the left side. So what is the first thing you ask the fellow to do it? Which investigations or you are thinking of?
To rule out any ovarian torsion because of that infection.
Endometriosis and torsion, I will not keen about, because endometriosis, fixed disease, peritoneal adhesions, torsion.
We have to
no.
think about any abscess, ovarian abscess. Is there an infection?
Abscess. Yeah, in your notes you are saying I given the antibiotic, I changed the needle. All that thing you have written it down. Anything else? The patient coming, no, and
So
you
it's
have
a case of endometriosis. She will have a day 2 pain mandatory.
Day 2 pain. No, she's not day 2. No, she's day 2 of pickup. She's not day 2 pain. So she definitely that is a pain is.
Day 2 of pickup.
So we should ask other complaints also, not
Yes.
only pain. If
Fever.
she's having any fever, lower abdominal pain,
Yeah.
then we have to do pelvic examination. In pelvic
Yes.
examination, we have to see the tenderness in both the fornices.
Usually on day 1 or day 2 of pickup, every patient's complain. I think Jyothi will say they will complain of pain, because whenever you do a TVS also, they will complain of pain. So it's fine.
It is
She will
also,
complain of
if it
pain.
any pelvic abscess, definitely it is associated with temperature.
Yes.
Then we have to do investigations to see the WBC count.
See, why specifically I talked about day 2, there are the 2 complications. Even if the endometrium is not been infected, there is a peri-endometrium. I have that beautiful video, I'll show it to you. There may be a bowel adhesions, peri-endometriotic tissue. And if you damage the things, usually it is a mechanical injury. The thermal injury, what we used in a harmonic or maybe a bipolar sharer, comes after day 5, day 6. But whenever you have an injury of the bowel or maybe a visceral structures, it comes on day 2 or day 3. And the patient will have a pain with the tachycardia and maybe a feverish symptoms. Then you have to go and investigate later on. So she's now perfectly all right. She came down to on day 2 of the next cycle. Whether you are already planning for the FET. So what is your protocol? You will give a pre-treatment generation analog, or you will just do a fresh ET, or you will do operate again and then do a generation analog and then the FET. Endometrium is still there. Yes. We'll go from that side, yeah, because I think we'll cover all of you. He's andrologist, so I'll come down to that question once our. Yeah.
So, not going for the surgery, definitely not. Better to start with the agonist protocol. Means down-regulated protocol. Will start with Lupride injection, and after that.
No, madam, there is a 2 things which as a patient I'm asking. I'm having an endometrioma. That endometrioma is still there. My embryos are with your bank. So embryos are already been cryopreserved, because I had symptoms for 2 days, a little bit pain and fever. Thank God I'm not landed into any abscess and anything. So everything is fine. So now I'll come down to you on day 2 of my period. And what is your, because endometrioma is there, as you mentioned, everyone, my referring gynec also told me that I'm having a endometriosis. I read with the literature, with the endometriosis, there is always a chance of spontaneous rupture in the pregnancy. Also, I have every literature in my brain because I'm a Google person. So it's what is your thing that you will talk to the patient, because this is a real live patient. So whether you wish to give a leupride agonist, I know leupride agonist causes a decrease in the volume reduction is doubtful, but symptomatic relief is there. I definitely read that also. So if you give a GNRH analog, or whether you will post me again with the surgery and then do a ET, what is your thing in that case?
First, we'll see a scan and we'll see whether the endometrioma size has increased or not. If she has any more complaints like
No, nothing. I'm day 2. I'm very much fine. I don't have any complaint, madam.
And if the endometrioma size is like the same, so then we'll definitely post her for the ET this cycle.
So this cycle you will do the ET preparation and the
followed by the
yes.
leupride protocol.
Any one differ from that?
So because patient is having pain, patient is symptomatic.
No symptoms. That symptoms was there day 2 and that is gone.
Dysmenorrhea is also not there.
No, dysmenorrhea is there because I'm used to that, because it's a day 2. I'm knowing that there is a endometriosis, so dysmenorrhea is not it's a chronic complaint for me, no? So it is not pertaining to this procedure now.
So my perspective, I would like to do an endometrial preparation first. I would like to see what is her endometrial thickness coming, whether the triple line is present or not. If everything is good, if the patient is asymptomatic, I would like to go for transfer. In case triple line is not coming, if the patient is not having good endometrium associated with a 5 centimeter cyst, I'd like to do diagnostic laparoscopy with hysteroscopy, remove the cyst, then again go for embryo transfer.
Okay, what is your opinion, madam?
And if the patient is asymptomatic, I'll go for endometrial preparation and transfer, sir.
Okay, I'll go. I run from 5 centers, 1, 2, 3, 4, 5, and now 6. Yeah.
I will give GNRH analog, and next month I'll go for embryo
So you
transfer.
give one GNRH analog and then, yes, madam.
I would like to prepare her endometrium, and if it's good enough, I will definitely go for transfer.
Okay, now I'll again go, because the 6 centers tell me 3 opinions. I'll go and Google myself and come back again. And I'll come to know that endometriosis having interleukin 1 and interleukins that has been on a higher side, it is an inflammatory process. So I'll ask to the center 2 and 3 where I gone again for, they said you could just come back, I'll do the FET in your case. So I'll give it the reports that the recent studies shows that there is a intermolecular changes, inflammatory reactions on a higher side, and when you do the pickup, your inflammatory markers always on a higher side. So I'll just come with the page saying, so I'll go with this madam, because she's saying that you take a rest for 1 month with GNRH analog. So what is your take on that, madam? Because you are asking me to do the FET immediately. I will say no, I will take a break because my interleukin 6 and 8 is on a higher side inflammatory markers, and that will cause a compromisation in the implantation rate. That is paper is with me.
Actually,
on
definitely for these endometriosis patients, we have to counsel before that implantation rates are comparatively less than the other patients.
Yeah.
So we have to counsel them for lower implantation rates, and we have to prepare the endometrium, and we have to see whether the endometrium is coming up. Usually I like to go with the down-regulated protocol only, FET. So first I'll give agonist, and then see in the next cycle I'll do FET.
Yeah, because initially they wish me to undergo the transfer on the next cycle. So I come and Google, and then I found out fresh and FET with the agonist protocol. So it is better that what I find it out on for 2001 retrospective analysis of the data, that even if you give a GNRH analog for 1 or 2 cycles and then you do a FET, the chances of pregnancy is on a higher side. So I request my co-moderator to be here, and we'll have one more case of those who are written it down on the page. Yeah.
We actually have a couple of questions on endometriosis itself. So this is similar to what Dr. Ashish has said. A 36-year-old married lady, married for 13 years, bilateral endometriotic cyst and fundal anterior intramural fibroid. The right ovary has an AFC of 7 and endometriotic cyst size is 2 into 2 centimeters. Left ovary has an AFC of 3 and the endometriotic cyst size is 5 centimeters. What should be our next step? Quickly we'll talk. We'll not ask about explanations. Madam, we can start with you. So she is 36-year-old, married for 13 years. Let's assume normal males parameters.
Straightforward endometriosis case, bilateral endometrioma, AFC 7+3, 10.
5
So
plus 2 centimeters.
Definitely we will go with IVF, madam, in this
Madam,
case.
for you? What do you?
Yeah, same.
IVF? Madam? IVF? So nobody wants to do a lab? Okay.
No,
So
we'll differ.
is there...
Same.
Okay. So the question basically here is there an advantage of doing laparoscopy but before you do a IVF? So I think even when Dr. Ashish had started this case also, that is the thing. She's had 3 IUI failures, but if she says that I am not going to get another cycle of IUI done after you do a lab, there is no point of doing a laparoscopy in that patient. In that patient, she did not even have an endometriotic cyst. You know, we just went inside the laparoscopy and incidentally found that there is pelvic endometriosis. If you do a laparoscopy, if you see that there is pelvic endometriosis, then at least after that, give her 1 or 2 cycles of IUI. Don't leave her alone and don't say that try naturally. Or at that point, don't say that, okay, I will go ahead and do an IVF now. So, lap in itself, although there are some studies which says that doing laparoscopy in failed IVF patients with endometriosis actually increase the success rates of it. I think the numbers of it are very, very limited. Doing an invasive and expensive procedure before you go ahead and simply change, the course of action is not required. So it's very simple. If the woman is old and married for too long, if she's having an endometriotic cyst also, please go ahead.
Apurva, what about the fibroid there?
Yes, so the size of the fibroid is not mentioned. So I will come to that question in our next thing. But before I move on to my next cases, I have to. Dr. Ashish has not asked Dr. Ashish any questions.
Yeah.
So I have to ask him a question. So 21-year-old female with PCOS. They've been married for a year. The rest, everything else with the female is normal. The husband has had an undescended testis for which he was operated 2 years back. And even now, the semen parameters show azoospermia. How do we proceed?
Is it bilateral or?
Bilateral.
Bilateral. Okay, where was this testis there? Like, was it in the pelvic?
Let's say abdominal.
Abdomen. So there's no way that you can do anything for that, because it will be nubile testis for sure.
So let us say in case if it is in the pelvis and they kind of operate, is it possible for them to kind of operate at this old age and bring them down into the scrotal sacs?
It doesn't help for
Okay.
sure. But the guideline says that to remove that,
Correct.
because the high chances of it becoming malignant.
Sure.
So if you still want to try something in this patient, check for the hormones.
So let us say if there is one testis which is descended in the scrotal region,
Okay.
And then other testis has been removed
Okay.
2 years back, and even now they are in azoospermic space.
Again, just check for the hormones.
FSH is 12, LH is 11.
I'll try.
All of us are trying here. What are you going to try with?
I'll proceed with micro TSA.
So does
Ashish, my questions to you.
Ashish versus Ashish?
No,
Yes.
no, it's not like that. When you are talking about why micro TSA, why not a TSA?
Like before proceeding for micro TSA, I will anyways on table to a mapping TSA definitely. After that only I'll proceed for micro TSA.
Why I wished to talk about, because all of us are doing a micro TSA later. First is a TSA, testicular sperm aspiration we do. And if it is found out to be negative, then we go with the micro TSA. What is the importance of the micro TSA, what you thought of? Because we wish to know as a gynecologist, why micro TSA? Because we need to talk to the husband that these are the particular things you will be doing, that is a cut, you have to evert the skin and going for that particular micro TSA and the recovery, all that thing.
So only at the end of the day, we want to give them their own biological child.
Yeah.
So first, we will definitely counseling about that. So you want your biological child, we need to go with this procedure. So again, so micro TSA is more better is what I think.
Yeah, but in micro TSA, when we talk about there is a pool of a spermatogenesis. We don't have a certain part of the testis. We have a fibrosis and another. That's why we do a micro TSA. We don't do a like previously they just do a TSA or a biopsy. We do it with the microscope. Actually, what you see in the microscope is the tubules. How you identify these are the good tubules and these are the
So again,
tubules
by
which-
look of it, dilated tubules.
Yes.
First, always identify the dilated tubules.
True.
Never, you can't pick up everything you see.
True.
So always go deep layers of the testis. There's high chance that we get dilated tubules.
I'm sure
Thank you.
all of us have great andrologists who can retrieve the best of the sperms for us. So we will not get into too much in detail regarding that. Let us say if I am a gynecologist, I'm not a fertility specialist, I'm a gynecologist, I have a patient like this with me, where the sperm parameters are showing azoospermia. And I'm telling the patient nicely, go to a fertility specialist, but she doesn't want to go because, you know, her generations have been with me and so on and so forth. Is there any one single test a gynecologist can do which will predict the possibility of, so the main issue in azoospermia is either we do an IVF with TSA or we go ahead with a donor.
Yeah.
So is there any one test that a gynecologist can do which will let us know where they will lean to?
Yeah, always better to see whether it's an obstructive azoospermia or non-obstructive. First basic thing. So if you think there is an obstruction by any cause, infection, mumps, or anything, just the general hormonal levels will be absolutely normal in this patient. If there is a non-obstructive azoospermia, the FSH will be skyrocketing. So if you still want to try in this, check for inhibin B levels. So that will give us more idea before going telling anything. For the further procedures, you see inhibin. If inhibin is too low, still there is always a chance that we might
That's
still
okay.
get it. Yeah.
See, you know, anything can happen. You know, if Donald Trump has become the president of US, anything can literally happen. So we are not looking about you know, exceptions.
Yes.
So FSH, LH, and inhibin B. I think these are the three tests that we can do, which will let us know what is the probability of success in a TSA. If you have normal inhibin B, low FSH or normal FSH and LH, that means that this patient is probably an obstructive and
So
has
always
better outcome.
FSH, LH below 7.
Yeah,
Nothing more than that.
sure.
In which case you like to do microdeletion? Because we get to know the microdeletions
Yes.
affect your, even if you
Yes,
found out
yes.
the sperm,
Yes.
we are not here interested in finding out the sperm, we are here interested in formation of embryos. So
Oh.
before that, whether in which particular case of patients you like to do us as a microdeletion of the eggs, because azoospermia, one of the things that one
Yes,
should rule out.
microdeletion, yes. If you think, if you check in the genetic levels, if you think that there might be a chance of microdeletions, just basic examination, start with basic, is the VAS is there or not. So after that only we can go ahead with genetic testing.
Okay, so now again quickly coming back to the clinicians. 28-year-old, 5 years married life. She's undergone a DHL 2 years back. Let's presume that she's undergone drilling also for PCOS. And now she's come back, her AMH is 18. How do we proceed? Madam, start. Where is your mic? So 28-year-old, married for 5 years, underwent DHL 2 years back for PCOS. Now the AMH is 18. Presume normal sperm parameters and normal fallopian tubes.
She's having regular cycles.
What will you do? 18 AMH, she's come to you, she says, I want to get pregnant.
I would like to do ovulation
We-
induction.
you-
I would
see,
like
we
to do
see this-
ovulation induction.
Yes, we see these patients every day. Okay, you do ovulation induction, great. Will you do an IUI or not? Yes, yes. You can be confident and tell that there is nothing wrong. It's been 5 years, she has already undergone a drilling. The first thing is someone who's undergone a drilling If she's not got pregnant in 2 years, then it is actually the onus of the gynecologist, because drilling చేసిన తర్వాత 6 months వరకే LH levels తగ్గుంటాయి, తర్వాత దాని ఎఫెక్ట్ పోతుంది. సో don't tell the patient that I'll do drilling and you go try naturally. You have to follow her up and you tell her that 1 year లోపల నువ్వు ప్రెగ్నెంట్ అయితేనే నువ్వు చేసిన డ్రిల్లింగ్కి యూజు, లేకపోతే నీ మనీ వేస్ట్. It is true. And you make sure that she, after drilling, it doesn't matter, you still go ahead, give her ovulation induction, and if in 3-4 cycles, if she doesn't get pregnant, there's no harm in proceeding and doing or recommending at least an IUI for her. Patient always has the option to refuse. But as, her gynecologist, I think this patient definitely, needs an IUI. I think we will talk about. Okay, so this. So we will be anyway discussing on myoma. So instead of going about a case that we have made, we are going to discuss the case that's given to her. So 1, 2, 3, 7 questions adugunnaru post myomectomy gurinchi. I'll just ask one by one what you guys do. Post myomectomy, anyone lap surgeons? Okay, sir, చేసి ల్యాబ్ వేరే సర్జన్ దగ్గర చేసి మన దగ్గరికి వచ్చారు. షీ హస్ కమ్ టు యూ నెక్స్ట్ మంతే వచ్చింది. After how many months would you start planning for pregnancy?
3 months.
It should be clear. You see, what we can open, the whole point of this conversation is to.
We are discussing. We are not here to just what
That's
we
it.
feel. We also feel the same way. It's not something.
Yes, please.
We'll see the whatever the OT notes first, depending upon the size and the location of the myoma, how invasive it was, how much endometrium was damaged, or how much myometrium was damaged.
So,
depending upon that, we will wait for 3 months at least. And
3 months. You will wait for 3 months.
Yes.
If you open the cavity, not open the cavity, I will not go into that because it's become
see, it's
become
very,
more than.
very simple. I mean, obviously, there is a lot of literature and everything, but with a lot of endoscopic surgeons' consensus, if the endometrial cavity is not opened and you have removed a subserosal myoma or a broad ligament fibroid or an intramural to subserosal fibroid, 1 month tarvata nunchi you can start planning pregnancy. 1 month, 30 days. If the cavity is not opened, if it's not a deep fibroid, you can go ahead. If the endometrial cavity is opened, that is when you need to wait at least for 3 months. మనం 3 months 4 months ల్యాబ్ తర్వాత ఇంకొక 6 months ఇది అయిపోయాక మిస్క్యారేజ్ అయ్యాక ఇంకొక 1 year 2 years ఇట్లా అంటూ వెళ్తూ ఉంటే వాళ్ళు ఏజ్ అయిపోతుంది. ఇట్ ఈస్ ట్రూ. ఒక్కొక్కటి చేసుకుని వెళ్తే ఇంకా అల్టిమేట్లీ దెన్ దే విల్ కమ్ ఫర్ ఎగ్ డొనేషన్. నౌ దట్ ఈస్ ఆల్సో బికమ్ వెరీ డిఫికల్ట్.
Last sentence repeat please so I can understand.
ऐसे करते करते अगर चले जाएंगे ना हर चीज के लिए फिर हाँ बूढ़े हो जाएंगे.
Adding to that point, you need to understand how much is the approximation of the two sides you are done. If there is too much of blood or if too much of space in the myometrial closure, then you require higher healing time. So those who are just observing the surgery also will come to know whether the surgery is doing very well or not. Even if it is open myomectomy or whether it is a laparoscopic myomectomy, the defect has to be sutured well. It is maybe a single layer or maybe a double layer. And what is if there is a pocket in between or maybe a bleeding in the medial, then you have to wait for a longer time. Yeah.
Okay. So madam, any special instructions when she is pregnant? ఏదైనా extra monitoring చేస్తారా? Yes or no?
To see, post myomectomy, there are certain complications during pregnancy we may encounter. Like we have to see placental location and
Very good.
preterm chances of preterm.
So I think 2 things that we are worried about is one, placental location resulting in as a placenta accreta, purcreta or increta, or a rupture happening. Yes. So on continuing on the same topic, section or normal delivery.
We can try.
Still normal ante
always everyone do a section. There is a history of infertility, history of scar uterus. Only you require a lion heart to do.
Don't need a scar only.
No, but now there is already scar inside. Why you are talking about?
Why you are even thinking about? I understand the whole consensus of it. You know, I understand there is idea of doing surgery just at maternal request. You really don't need an obstetric indication to kind of go ahead and do it. But technically speaking, if a patient comes to us and says that, okay, I've had a myomectomy and I want to do a normal delivery, logical ga alochiddam. Cesarean ki myomectomy ki difference evanna unda? Yes.
Definitely.
So yes, there is still, because it is a lower uterine segment and we are looking at if it is a fundal fibroid, it becomes a classical cesarean. Correct? This is the two differences. So location of the fibroid is what is going to matter for us. In case if it is a posterior wall fibroid, it is low down, or you know, it is a corneal fibroid or lateral fibroid or something like that, and the cavity is not opened, you can still go ahead and give the patient a trial of labor. After 9th month lo, మీ sonologist ni, they can evaluate ekkada myoma scar undo, they can evaluate the thickness of it and then they can tell you. See, section ko oppeskunte manaki asal problem e ledu. The problem comes when she insists that she wants to have a vaginal labor. That is when we should be able to give a medical judgment for them. Any
I will add one thing to that.
Yes. Sorry, madam. Yes. Yeah. So that is again another thing important. You have to ask for the placental location and kind of ensure that there is no invasive abnormalities.
Yes.
And the placental location and the invasion of the placenta usually happens when we do a hysteroscopic myomectomies, where we are damaging the endometrium. If you are doing the posterior myoma and that suture has been beautifully done, how we are going to assess the posterior myometrium in the pregnant uterus and what is the length of the myoma? Can anyone answer me? I will be happy to enlighten with the knowledge. That is the first thing. And secondly, if we have the, see, I'm not saying that you should do a cesarean section. I will say that there is a, definitely first we do a NST, then there is a tachycardia, fetal tachycardia, that is imminent chances of gaining way of the sutures. All that thing we always, as an obstetrician, we know about it. But it is a per se that whenever there is a multiple myomas or multiple sutures taken, that is a high risk of a rupture. If there are multiple myomectomies in one, there are 3 myomas and 3 myomas are being removed, a higher chance of having the abnormal presentation, that is the first one. Secondly, chances of giving a rupture is
So I think
another
essentially
thing.
for all practical purposes, we should consider it like a previous LSCS and take it forward from there. They've asked if we can induce the patient. Normally, I think if Evita Fernandez ma'am was there here, she would have told, we'll induce everyone. But so for me, for VBAC, I have this thing that in case if they spontaneously go into labor, they have a non-recurrent indication for LSCS, we do allow them to go. So be very, very vigilant about inducing such patients for delivery. Okay, quickly, 32-year-old male, 30-year-old female, married life 1.5 years. Both are IT. I don't know why madam thought that it is important to mention that. AMH is 1.37, not used any contraception. Fibroids, 2 fibroids, one is 5 centimeters, another is 2 centimeters. Tubes normal. Semen analysis, 3 months back motility was 2%, now motility is 48%. How to proceed? So tubes are normal, AMH is 1.3, age is 30, 2 fibroids and currently normal sperm analysis.
I can answer that IT point.
Sorry?
I can answer that IT point because in a IT couple they usually have different shifts. Yes. One comes in the morning, another goes in the evening. So that is one of the things. That is the usually in Pune also it happens the same way. That's why that is the IT.
Within the same city is still all right. For me, I have couples who are in Bangalore and Delhi.
And they travel also.
And
Only Saturday, Sunday.
Yes. Okay, madam, we'll start from this side. So what will you do next?
So location of the
fibroid undi.
Fibroid
Intramural fibroids, fundal fibroids anukundam. They are not indenting the endometrial cavity. 5 centimeters, 2 centimeters, AMH, HSG, sperm parameters.
It's 2% has become 48%.
Yes, in 3 months. Is that possible? No. So it is possible that one of the labs has kind of given any variation which is there. Is it possible for the sperm parameters to also fluctuate or wave? infection. So infection can be a reason. I think all of us would have seen that ఎక్కువ తక్కువ ఉంటుంది, మెడిసిన్ అంతా ఇచ్చాక ఎక్కువ అవుతుంది, ఇంకా వీళ్ళు ఎక్కువ అయిపోయిందని చాలా హ్యాపీగా ఫీల్ అవుతుంటారు, అంత లోపల మళ్ళీ తగ్గిపోతుంది. సో దట్ ఐ థింక్ ఈజ్ అ విండో ఫర్ అస్. ఇఫ్ సమ్మన్ హ్యాస్ హ్యాడ్ అ లాంగ్ హిస్టరీ ఆఫ్ poor sperm parameters and now you are finding that they have become better, please know that మనకి తెలుగులో ఆరిపోయే దీపానికి వెలుగు ఎక్కువ అంటారు కదా.
English, please, so I can understand. No, I hardly can understand as a Komar.
बुझने वाली दिए का रोशनी ज़्यादा
Okay, yes.
So रोशनी, हाँ, रोशनी ज़्यादा है. So please make sure that you catch that small phase that you have and make sure that you are using that time. Don't waste it. Even if you have to freeze couple of sperm parameters, we can go ahead and freeze them. Okay, let us say the first report was abnormal and ippudu 48% undi. For their sake, we hope it is now. I think the idea here is, should we proceed with a surgery or should we go for any treatment? Natural ga try cheyandi ani odlestama, treatment ki veltama.
So already 1.5 years, it's better she goes for treatment.
Yes.
And AMH is also almost borderline.
Yes.
So 2-3 quick cycles of IUI if she doesn't conceive IVF.
Ashish?
Yeah.
Moderator is asking moderator.
So this is a panelist and moderator now.
No, expert decision.
No, it's always
Yeah.
I enjoy it.
Yeah.
See, there is a AMH which is 1.2.
Yes.
Secondly, there is two fibroids. One is 5 centimeter and another is also 5, not distorting to the cavity. The motility in the per se is very low. I will prefer this particular patient should go with the evaluation of the endometrial cavity. I will do myself with the 3D ultrasonography to know the endometrial, not only whether it is indenting the endometrium or not. I will see that a myoendometrial junction, because my implantation of the embryos happens at a myoendometrial junction and not in the cavity. So if they are not having any said that effect on the endometrium, I will go with the IVF directly. I will not get a time, because 1.2 AMH coming down to very fast. Maybe at this age it's 1.2. We never know. Maybe after 2 years she will land up into POI.
Sure. Okay, so IVF, again, as I said, it's a very individualistic decision as to, we can always offer, patient will accept or not accept is a different thing. But the idea of a 5 centimeter intramural fibroid, it's not subcaesarous or pedunculated. I have had 2-3 patients, who have unfortunately had red degeneration in the pregnancy. They were initially just about 3 centimeters. They're 2 centimeters and 3 centimeters pre-pregnancy. And in pregnancy, from first trimester to second trimester, they increased to 8 centimeters. And she has significant pain. I mean, like pain wherein, it makes endometriosis feels silly. So, I think if the fibroid size is more, and I have heard Dr. Prakash Trivedi talk a lot of times wherein Sir has always said any fibroid means that it somehow will kind of result or affect in fertility. So 3 centimeters kante fibroid ekku unte, and if it is not subserosal or pedunculated and it is there, we might counsel them and give laparoscopy. E patient ki right now IVF kante maybe we can kind of consider in terms of laparoscopy. See, this is 2 schools of thoughts.
No, I'll beg to differ here, because there are the 2 reasons. The fibroids are there. I think all gynecologists can vouch for me. There are the fibroids. How many patients you see with the fibroids and pregnancy going till term and delivering? Yes. We will not thought of them having the fibroids. At the time of delivery or maybe cesarean section, we'll find out there is a fibroid. So only having the fibroid per se, here definitely the factor affecting the infertility is low AMH and that poor guy.
I have one
that is,
point to add.
Who is that? Yeah. Sorry.
Fibroid in this case, though we have the pregnancy in this, the continuation of the pregnancy we have to look for, because chances of pregnancy loss, though implantation can happen.
I will give a try, no, madam. If I am having so many embryos with me,
Okay.
why to add?
That's okay. As I said, I think you cannot ignore it. Let's say that. We cannot ignore the fibroid. I think, don't think that, I'll just take 5 more minutes and we'll wrap it up. Let's just not think that yes, exactly. So let's not assume that, okay, we know everything what is best for the patient. Do have this conversation with them, because it is going to keep you in a safer space. Because if, let us say, I do an IVF for the patient, it doesn't succeed, or she fails, or she aborts, I can't go and show her a trial and say that, you know what, it doesn't matter. She will show me another trial where it shows that it matters. So having that discussion with the patient, I think, is very, very important. Quickly,
This is the first time I agreed with her that we have to talk to the patient. These are the things. This may cause implantation failure and this may not cause. If you do a laparoscopy, I will ask all of you, if you do that 2 myomas removed and you do have a beautiful blastocyst, you do a transparent that fails. Then you taken the IVF effort, you taken the money for IVF, you taken the money for the laparoscopic myomectomy. Yeah. Madam, but it is not impacting on the endometrial cavity.
Okay, as I said, yeah, I think we get the point. So quickly, 23-year-old married life, 1 year, irregular, 45 kg weight to induced with letrozole for 3 cycles. Every time she's ovulated and HCG was given. Semen analysis is normal because she didn't get pregnant in 3 cycles of timed intercourse. Now I have sent her to a fertility center. What else could I have done as a gynecologist? I think, sorry? Yes, I think any patient who is coming to you for pregnant, HbA1c, TSH and prolactin and CBC, minimum change. Because so many patients you kind of detect that they are thyroid when we get pregnant. HSG, tubal testing, I think is something which you can definitely do. Prati month ovulation chesinapudu follicular monitoring ki every month pilvalsina avasaram ledu because that is taxing the patient. And yes, in case if you do have the ability, we can proceed with an IUI in this case. There was one more, I think, very interesting thing. Last 2 questions. How does PPOS prevent mitochondrial damage leading to miscarriage in a PCOS?
Get me.
PPOS, progesterone.
Yeah, progesterone prime protocol.
Yes.
Yeah.
So, when we are doing your IVF cycle, antagonist or agonist are suppressing your FSH and LH production so that there is no endogenous LH surge and there is no premature ovulation. Yetlaite, you can use OCPs wherein your endogenous surge is completely suppressed. Like that only, we can use progesterone also, which is suppressing the endogenous LH surge. So I don't think it is going to significantly...
there are the 2 things I think the question is that you are using an antagonist for suppression of the LH peak. And when you do a agonist cycle, you started from day 21 or maybe from ultrashort protocol day 1 or day 2 of your cycle. When you are using a progesterone prime protocol, the LH is not that much suppressed. They have an endogenous activity which has been maintained between 4 to 5. The LH surge is not going to occur, but the endogenous LH which is required for the initial activity of the granulosa cells to function on in a later follicular stage will be there. And that's why the mitochondrial damage will not be occur in that PPOS.
Sure. So the last question, I think someone has asked, how is a PRP prepared? I think PRP, if you have any hematologist friends or dermat friends.
PRP is prepared, if at all I can answer.
Yeah,
there are
please.
the 2 things. You can take a 20 ml of the peripheral blood of the patient. You have to centrifuge it to the 1800 gyri for 10 minutes. After that, the buffy coat comes and you have to have a supernatant. You have to discard the supernatant and take the buffy coat. Again, you have to resuspend it and do a 1200 gyri. And then whatever is coming is a platelet. You have to see what is the pre-platelet concentration and post-platelet concentration. Anything which is more than 5 lakhs are good PRP. There is called as a temperature activated PRP, in which whatever PRP you make, or maybe a 2 cc or 4 cc usually we have to do it in a cryoprotectant can just above the liquid nitrogen, and then because it goes to the minus degree centigrade, and then you thaw it as what we do it in the thaw FET. You have to temperature at 37 degrees, and this particular temperature change causes activation of the platelets, and this is called as activated PRP, what we do.
Thank you so much, Ashish, and thank you so much for all the panelists.
Thank you, panelists. It's been a wonderful audience for
thank you for all
taking
the
me
wonderful
and
questions.
her as a moderator. Thank you.
Thank you, panelists and moderators. That was a thought-provoking and an engaging session. To the last session, but a very important and interesting session for today, live demonstration workshop. To lead the session, we welcome on stage Dr. Kamalakar Reddy sir. Sir has worked as Assistant Professor at Gandhi and Usmania Medical College. He has been in the field for more than 30 years. There is no one here who doesn't know his name, and he has been training gynecologists for the past 20 years. Will be by case. So we'll start off with a history and then the scan findings and then a discussion on that case.
Let us move forward to the ultrasound session. So this is the first case today. So 28-year-old Mrs. A and 31-year-old Mr. B with primary infertility of 2 years duration. She has irregular cycles. She was given ovulation induction with tabletrozole and gonadotropins. Now let us look at the ultrasound findings.
So let's have a basic idea of what we see on scan on an ultrasound perspective on a gynecologist setup. So we all know it's a basic AFC count. These are the first follicles to be captured in the growth of the face. So primordial follicles, then comes the primary follicles, then comes the secondary follicles. These are the follicles which are very latent, they are resting stage, they cannot be spotted on scan. Once the antrum has formed, scan is being started. Once the antrum has formed, then the follicles get captured. That is the antral follicle count. Antral follicle count should be taken from done on day 2 to day 4. Each measures 2 to 3 dimensions. Okay. After the scan, we'll have the discussion.
Should I talk? Yeah. This is an anteverted uterus. Are you able to hear me?
Yes, sir.
Okay. It's an anteverted uterus. Thin endometrial echo, maybe 3rd or 4th day of the cycle. Yeah. Okay. This is the transverse section. This is longitudinal section. No evidence of any fibroids, no evidence of any adenomyosis. And now I'm going to the right side to see the right ovary. We are seeing multiple follicles, maybe stimulated cycle. 1, 2, 3, 4, 5, another 5, maybe 10 or 12, one side. This is the other ovary. Again, we are seeing around 10 follicles. Yeah. So that's it. It should be. Seventh day of the cycle. So yeah, there's good number of antral follicles, or we can't call it on 7th day, but anyway, good number of follicles. No adenomyosis, no any uterine anomaly. Yeah, so that should be fine. If you want, I can just do a...
Excuse me, sir, can you give us the measurement of the right and the left ovary? What are the landmarks and how to measure it? Right ovary and the left ovaries, basically.
Okay, uterus not necessary, only ovary. Yeah, right. Okay, first you go to the ovary of your choice, maybe the right or left. Now I go on to the right side. Okay, try and get the full longitudinal diameter and then turn 90 degrees to that and get the AP and transverse section. Okay, so now freeze it and then you measure in the volume mode, then you will get the ovarian volume. It's always better you take the ovarian volume because nowadays PCOS, everything is defined based on the volume. So always better you take the volume. We are getting a 7.7. That's the right ovary. Is that okay or should I measure the left ovary also?
Yes, sir. Okay. Okay, sir. So this is a normal volume. So this is a basic scan. On a day 2 scan, we'll see for the AFCs, any cyst we see. When we call cyst, that is more than 10 mm. We have no cyst. And she is a normal reserve patient because of AFC means it's a count from both right and left side of the ovary. So she's a normal reserve. That's all.
Yeah. Should we do on 3D?
We'll be with the second case, sir. Yeah. Okay, 3D scan. Yeah. When do we, the size of the follicle is the important finding. When we have a follicle size, the dimension, it should be taken in an, it's not that, yeah. That is the measurement of follicle. If the follicle is more than 10 mm, then we call it as a cyst. So Dopplers do have a role. We have further cases to say how to take whether it is a functional cyst or a non-functional cyst on the next coming slide. Yeah. Yeah. Sir, please tell us how do we tell it is a cyst or a follicle?
Follicle. Okay. It depends upon the day of the cycle actually.
Yes.
So yeah, in general, if you want to call it a cyst, if it's above 3 centimeters, definitely we call it a cyst. But it depends upon the day of the cycle. But up to 10 mm, less than 10 mm, we can always take it on the 3rd day or 4th day. And then if it comes to 7th day, 10 mm follicle is expected with a stimulatory cycle. Is that okay? Or
yes, sir. Thank you, sir. Thank you so much. Yes. We'll go with the second case, sir. Second case.
So now moving on to the second case. So it is a 24-year-old female, anxious to conceive since 2 years. Started with ovulation induction for an IUI cycle in view of unexplained infertility. So let's look at her USG findings now.
So moving back, AFC do have a role to know whether how much is the predictive rate. AFC is believed to represents the quantitative aspects of ovarian aging. AFC showed the best correlation with women's age and declined linearly at the rate of 3.8 per year at around 28 years. The rate of decline of AFC further increases to 11% around the age of 35 to 40 years. So we can see in the graph that the AFC count decreases with age. So it is as a good predictive value in the further prognosis of the patient.
Over to you, sir.
Yeah. The next patient is she has taken a trigger for rupture, but I think it is not yet ruptured. We are seeing a mature size follicle measuring 2.5 into 2.3 into 2.3 on the right side. And I'll just go to the left side also, just a second. Yeah, even on left side we have a dominant follicle. This is little smaller than the right. Yeah, 1 second, I'll tell you the sizes. This is 2 into 1.7 into 1.7, almost mature size both sides. Yeah, if you are interested in seeing for the color Doppler on the margins, yes, we can see. Just reduce. Okay, we are seeing a ring almost 100%. So it's a nice mature size follicle in the right, and most probably the same in the left. Put on the color. Yeah, here also almost 90% we are seeing. And endometrium, we are seeing triple line, measuring almost 10 mm. Yeah, 10 mm endometrium, 10 to 11 mm. Endometrial vascularity reaching up to zone 4, I suppose. Yeah.
So can you tell us about the Doppler settings that you use for endometrium and follicle?
No, I don't think we need to have a specific protocol. We just go to low settings to see because they are all capillaries. Go to low settings, and if you have the power Doppler and PD or HD flow, you can go to those things. But it will only confuse the picture. Even with color Doppler, I think we can manage happily. Just go to lowest settings possible so that you can see the ring. Same thing with the endometrium also. Because normal endometrium, we don't see much vascularity. Only close to ovulation, we see the vascularity.
Thank you, sir. Thank you so much. So folliculometry, this is a scan that we have been doing with ovulating agents. And so day 2 scan AFC is more important along with endometrial thickness. Day 6 to day 7, selection of the dominant follicle happens. So once the dominant follicle is on 14 mm, the rate of growth of the follicle will be 1.52 mm per day. So these sir have shown clearly how the Doppler takes up on a dominant follicle. So what are the signs of trigger? Basically depends upon the dominant flow, the peripheral blood flow of 75 to 100%, and ovarian stromal PSV more than 10. RI decreases when the dominant follicle are going. This shows a good follicle which supposedly have a good quality oocyte. So that all we have seen, zone grade 1, 2, 3, 4, PFBFs just supporting around surrounding less than 25%, 25 to 50 is grade 2, 50 to 70 grade 3, and more than 75 is grade 4. So we have to correlate between the dominant follicular growth with the endometrial lining. So type A, B, C, this is a patient with just pre-ovulation. Type A endometrium, good triple line pattern. So type A, multi-layered endometrium with intervening area, more echogenic. So yeah, we'll move on to the next case.
This second patient showed us the beautiful endometrium and beautiful follicle. Hope she conceives also.
Yes, she's a right time for trigger as well. Sir, over to you, sir.
Endometrium is just around 7, and it's not a good triple line. Actually, it's a little fuzzy. And okay, we have a cyst in the right ovary, and there's a hemorrhage inside. You can see septations. This should be 1 or 2 days old hemorrhage. So now we call it hemorrhagic cyst. I think you should stop the follicular study. Maybe ask her for a baseline scan on second or third day of the next cycle, see whether the cyst has regressed, and go for the next cycle. Is it okay, or you need anything more?
Yes, sir. This is an ovulation inducing. We had a dominant follicle, and a post trigger it has resulted in the corpus luteum. This is a stage of corpus luteum. Corresponding changes in the endometrium is being noticed. The change in the pattern from type A to type B and the fluid in POD. So these are the changes that we look for post trigger, that the change in the dominant follicle becoming hemorrhagic, or sometimes there will be the loss of the dominant follicle, or that this will take up a clear corpus luteal Doppler. And so this is a clear picture. So there is a varying presentation of corpus luteum. It can be a cobwell, or it can be regular or complete absence of the dominant follicle, the different presentation of ovulation. We'll move on to the third case. 26-year-old Mrs. X, wife of Mr. Y, came with primary infertility of 5 years duration. She has irregular cycles, 3 to 5 per 45 to 60 days. Her BMI is 36.5 kg per meter square. Here we'll go with the ultrasound finding. Over to you, sir.
One second. Yeah, it's an anteverted uterus. Okay, this is a right ovary. Should be the volume should be higher. I'll take the volume.
Yes, sir,
Multiple follicles are seen, and now this is the left ovary. So, okay, it's a polycystic ovary. I'll just take the volumes and then get back to you. Yeah, 1 second. Yeah, it's borderline. Actually, it's not touching the 10, but still the pattern is polycystic, and if you count the number of follicles, it should be around 20. I'll just count them. Yes. You can go from one extreme of the ovary to the other extreme of the ovary, either in transverse section or in sagittal section, either way. Okay, see, now I'm going to one extreme, I'm seeing 5 follicles. Then now another 3, 4, 9, 10, 11, 12, 13, 14, 15, 16, 17. So around 21 or 22 on the right side. The left, I'm going to one extreme, I'm seeing 5. Then another 10 here, 15, around 20, 21 on the other side. So size-wise, actually, they are not conforming to the definition of a polycystic ovary. Even the left also, I don't think it will confirm. 1 second more.
Thank you very much, sir. Most of us have a doubt, how do you count the follicles, and is there a chance that you repeat the count of follicles? So we do, as sir has demonstrated, side to side sweeping of the ovary so that we don't repeat the follicles. So moving on to PCOS, all of you know the criteria. According to the recent ESHRE ASRM criteria, we still follow Rotterdam criteria. Rotterdam criteria are regarding 3. 1, oligoanovulation, androgen excess, is it biochemical or clinical, either way it works, and polycystic ovarian morphology, PCOM. So since this is an ultrasound session, one update that all of us must know is, in PCOM, now we consider FNPO, what is called follicular number per ovary. So each ovary more than 20, or ovarian volume, as sir has just demonstrated, more than 10 ml on either ovary constitutes PCOM. So if the person satisfies any 2 of these 3 criteria, we consider her to be a case of PCOS. So moving on to the next case. We have a 35-year-old Mrs. X and Mr. Y, aged 38 years. She came with primary infertility of 2 years duration. She has regular cycles. with spasmodic dysmenorrhea and heavy menstrual bleeding lasting for 8 days. Let's look at her scan findings.
Yeah, it's a retroverted uterus. There's a large intramural fibroid in the anterior wall of the uterus. Should I give you the measurements? This is transverse section, and then this is the sagittal section. Okay, the length is 5.5 centimeters, AP 4.1, and transverse diameter is 4.9. So, yeah. This is in the anterior wall. There is indentation of the cavity echo. Should we do on 3D to demonstrate?
Yes, please, sir.
Yeah, definitely the cavity echo is deviated to the deviated posteriorly, but the fundal part is fine. But this is located more close to the in the body, close to the cervix, internal os actually. Yeah. Then that's it, Amar. Should we talk?
Thank you, sir. So as sir has demonstrated, this is a case of fibroid uterus. From morning we have had extensive discussion even in the panel whether should we or should we not operate. So fibroid uterus, all of us know the FIGO classification. So to make things simple, what does evidence say? All submucosal fibroids do affect fertility and need to be removed. There is a grade B evidence regarding that. And regarding subserosal fibroids, they do not affect fertility and do not require to be removed. But what about intramural fibroids? Intramural fibroids, we have two categories, whether they are cavity distorting or non-cavity distorting. So in case it is a cavity distorting myoma, we would proceed with myomectomy, and if it is not, we would not, myomectomy is not advised.
Now coming to the next case, 26-year-old lady presented to the hospital with secondary infertility of 3 years of duration. She had one spontaneous miscarriage at 8 weeks of gestation. Presently, they have been unable to conceive since the past 3 years. Now let us look at the scan findings.
Okay. This is an anteverted uterus. This is subseptatum. This is not bicornate. Yeah. Yeah, this is an anteverted uterus. Most likely it's septate uterus. I'll do a 3D and then I'll get back to you. 1 second. It's a subseptate uterus actually. Yeah, your E3 calcification, I think it falls into 2, U2. It's a deep subseptate. It's almost going up to the internal os of cervix. Anything more?
That's it, sir. So we'll, till you arrange another case, we'll be discussing about the uterine anomalies. So uterine anomalies, the estimated incidence in an infertile woman is 8%, but in a woman with history of miscarriage can be as high as 13%. So we have the recent ASRM 2021 classification and CONUTA classification, which is represented on the slide here. But since ASRM 2021 is quite a complicated classification, I would still put this ESHRE classification. This is simple to diagnose and easier to plan your treatment. So now, just now we had seen a case of complete septum uterus. So septum, yes, there is a fair evidence that it contributes to miscarriage and preterm birth. So evidence suggests that septum may also increase risk of other pregnancy outcomes. So should we or not remove the septum? So majority of the studies have suggested that a septum needs to be removed. In case with patients with history of recurrent pregnancy loss or patients with poor fertility outcomes. But again, all subseptate uterus need not be operated. So you will take a decision based on individual case.
Excuse me, how do you differentiate between subseptate and bicornuate uterus?
Septum is different from bicornuate uterus. One, bicornuate uterus and septum, right from 2D scan. If you are doing a 2D scan, simplest, because all of us might not have access to a 3D scan. On 2D, you will be seeing, when you move your probe in a transverse direction, you will have two separate myometrial masses with a separate cavity in bicornuate uterus. But in septate uterus, you will have a single myometrial mass with two cavities. That is the first point which will help you in thinking that this case might be a case of septum or a bicornuate. Then you can further do a 3D scan to confirm whether it's a septum or bicornuate. In bicornuate, there is an indentation of external fundus and also internal septum. Whereas in a septate uterus, the external fundal contour is complete without any indentation. So we'll be moving on to the next case.
Yeah, this is a right unicornuate uterus. If like one or two small points about unicornuate uterus, when you do a transvaginal scan, like to easily get to know it is unicornuate, when you do either an axial section or whether you do a sagittal section, the uterus looks as if it is in a sagittal way. So that's the easy way of first initial doubt to get it is a unicornuate uterus. When you do a transabdominal, if you start from the pubic symphysis side and go up, your uterus will either deviate to one side, to the right or left, depending upon which unicornuate uterus it is. So this is a right unicornuate uterus. I think your ESHRE 4. Yeah.
Thank you, sir. There is...
Yeah.
So we'll be discussing unicornuate uterus as well till they arrange the next case. So regarding unicornuate uterus, what are the problems that we encounter? One, unicornuate uterus patients have diminished muscle mass, and two, they have abnormal uterine blood flows, and also they have a high risk of cervical incompetence. So unicornuate uterus have lot of pregnancy complications. Rather, they do conceive. It is said that patients with fusion anomalies do conceive, but they have problems with their pregnancy. But patients with recanalization defects like septate uterus, they have problems even with conception. So unicornuate uterus, usually we advise in cases that we are planning for IVF or any fertility treatment to go for a cervical cerclage immediately after the NT scan, and also if we are planning an IVF to go ahead with a single embryo transfer. So we have a couple, 33-year-old lady and a husband, 38-year-old, with primary infertility of 5 years duration. She has regular cycles but severe dysmenorrhea. 3 cycles of IVF done, failed to conceive. Over to you, sir.
Yeah, this is an anteverted retroflexed uterus. Then left ovary, we are seeing large cysts with hemorrhage and another big cyst with internal echoes. It could be endometriotic cyst with a fresh hemorrhage into one of the locules, or this locule could be an hemorrhagic cyst separate and then an endometriotic cyst separate. And the uterus and ovary, they are adherent. See, this is easily demonstrated by pushing. So I am pushing it in and out. The uterus and ovary are moving together. And the right ovary is also adherent, but right ovary there is no endometriosis. Maybe कुछ procedure करें क्या आपको पहले? Laparoscopy. Right ovary में भी कुछ problem था? Okay. So right ovary is fine. Left ovary we are seeing one large cyst and two cysts with internal echoes and fine septation. So it could be a fresh hemorrhage into a pre-existing endometriotic cyst, or it could be an hemorrhagic cyst. Given a chance, what I'll do is wait for maybe 1 month and see again and to see whether this will clear. Otherwise, the whole thing can be endometriosis. Anything more?
Sir, can we see the rectum here? Any involvement of the rectum?
Okay, that, yeah. We have to try and go into posterior fornix, which is a little difficult. Yeah, and I have not gone much into the, you want to see whether the posterior uterine ligaments are affected. Yeah, but no, I have tried earlier, but I have not really picked them up much. MRI may be better. One thing is that both ovaries are adherent, and it is a, I think even the bowels might be adherent. It's all very rigid here. Very poor view of the posterior part of the uterus. Yeah, all the bowels are coming into place, so I think it's difficult.
Thank you, sir. That was a very neat demonstration of a sliding sign that you have shown us. So we have seen that this is a case of endometriotic cyst, left-sided endometriotic cyst, which is adherent to the uterus. On sliding that, we can see that the entire uterus is also moving along with the mass, TO mass. So even bowels are being adherent, so could be POD obliteration. So we had an extensive discussion in panel regarding endometriosis. So endometriosis in infertility, ASRM 2012, women less than 35 years with stage 1 and stage 2 endometriosis, expected management with superovulation plus IUI. Women more than 35 years, stage 1 and 2, better we suggest only 1 or 2 cycles of superovulation plus IUI followed immediately with IVF ICSI. Stage 3, stage 4, their POD is obliterated straight away for IVF ICSI. So there are differential options that we see. Ready? We'll go with the case. The next case is ready. We'll have a discussion. Case next one, 36-year-old lady present with primary infertility of 8 years. Duration has regular cycles but associated with dysmenorrhea. Male partner evaluation was normal. Her scan findings are. Over to you, sir, please.
Okay, this is anteverted uterus. I don't think there's much wrong in the uterus actually. It's all looking fine, or anteverted or almost neutral position. Then this is right ovary, looks quite normal to me. Then this is left ovary, quite normal. Yeah, here I will show you that they are moving easily. Now when I showed you an addition, now I can show the normal ovary. See, the uterus and ovary are moving in two different directions. So that shows it's moving freely, right?
Okay.
So yeah, here small hyperechoic areas seen in myometrium, but yeah, they suspected adenomyosis, but I don't agree. There's mild echogenicity of the endometrium close to fundus. It could be a small polyp.
Okay.
Close to fundus, very small. We can't demonstrate the vascularity for such small polyps. Yeah, it's quite small. I'll just measure it for you. Maybe just 3-4 mm.
Can we
Close
have a
to
3D
fundus.
scan for this, sir, please?
3D, yeah? Okay, just 1 second.
She had spasmodic dysmenorrhea, ma'am.
It's a very small polyp, very difficult to pick up on 3D actually. 3-4 mm is very difficult.
Okay, sir.
1 second. I'll just try a 4D cut. I'm doing a polyline along the endometrial echo. You go just beyond 1 centimeter beyond the uterine outline so that you get a nice section. Yeah. There's a small hyperechoic area in the fundus if we invert it, yeah. But not very clear.
Okay,
It's
sir.
better we see again in the next cycle, I suppose.
Thank you, sir.
Ultrasound features of adenomyosis. We have MUSA guidelines, what is called a morphologic uterine structural grading. So in adenomyosis, we have two types of features. We have either direct features or indirect features. Direct features are we have myometrial cyst, hyperechogenic islands and echogenic subendometrial lines or buds. The indirect features which most often we see is one enlarged big globular uterus, asymmetrical myometrial thickening, either the posterior wall is larger than the anterior wall, and we have fan-shaped shadowing, also called forest, rain in the forest appearance or Venetian blind appearance, and also translesional vascularity, irregular junctional zone and interrupted junctional zone. Moving on to the next case, we have a 34-year-old lady and 39-year-old gentleman with primary infertility of 10 years. On laparoscopy, she had endometriotic cyst 4 years ago, surgery done, one IVF done, failed to conceive. Previous report showed persistent fluid in the endometrial cavity.
Yeah, this case, it's an anteverted uterus. We are seeing a triple line endometrium. Uterus size looks fine, no adenomyosis, no fibroids. Then now I'm going to the right ovary. Ovary looks fine. There is a tubular cystic space occupying lesion in right adnexa, most probably hydrosalpinx. That's around 3.5 centimeters in length and around 7 mm in width. And I am also seeing a hydrosalpinx on the left side. Left ovary also looks normal. This. Yeah. Here it's 2.7 into 1.3 centimeter. Yeah, I'll just do a same polyline. We'll do a polyline just to show the hydrosalpinx. It will come very well. Yeah. See, that's the hydrosalpinx. Okay. Anything more on this case?
Thank you, sir. So, regarding discussion on hydrosalpinx, so what is the possible management? One, right now there is no role of tubal repair surgery for hydrosalpinx. So, what we need to realize is hydrosalpinx affects fertility in multiple ways. So, is it a unilateral or a bilateral hydrosalpinx? Is there a fluid coming into the endometrial cavity? These questions guide our decision. So, we have options of either salpingectomy or unilateral or bilateral tubal clipping, that is we delink the tubes from the uterus. So both the procedures are beneficial according to the Cochrane. So either clipping or salpingectomy can be done. But mind you, when you are doing a salpingectomy, we should take care to preserve the blood supply to the ovaries. Moving on to the next case, we have an interesting case. I will start the discussion after the scan.
Yeah, what we are seeing here is an anteverted uterus, very thin endometrial echo, and there are endometrial calcifications and minimal fluid in the cavity. Yeah, if you are suspecting Asherman's here, then I think if we infuse little fluid, we can see the adhesions more clearly. But what I am clearly seeing is calcifications in the subendometrial area and minimal fluid in the cavity and thin endometrium. And right ovary, I am seeing one cyst. Left ovary, little one another cyst. Yeah, more than 3 centimeters, I suppose. 1 second. No. I don't think we can call it a cyst, just around just 2.5 centimeters on the left side and maybe a follicle on the right side, subendometrial calcifications. No, it's more neutral position, you won't get a good 3D. Is not really adding to all this thing. Yeah. Okay.
Thank you, sir. So this was a case of Asherman syndrome. Actually, on the scan, you could see fluid in the cavity, whether it was persistent or not. Since we have been following it up, we know that. And this patient had a previous history of multiple DNCs, 3 miscarriages and repeated curettage. And then following up, she ended up with secondary amenorrhea. So she doesn't get her period. So we did her scan and now she is posted for hysteroscopy. So regarding Asherman syndrome, morning we had an extensive discussion. So I would not be repeating the same. So we'll move on to the next case. The next case is a complete septate uterus. Earlier we had a case of bicornuate uterus. So we thought if you could see a complete septum uterus, it will be ideal as well. Some interesting things about ultrasound. As you can see on the screen, there is a green mark. Wallison-Eaton is there. Just you can see a green mark. So how do you decide whether it is anteverted or retroverted uterus? So all of us has this doubt. So in any scan machine, there is a symbol which indicates the side of the bladder. So in this image, the right side is a bladder symbol. So if the uterus is pointing towards the bladder, it is an anteverted. If it is away from the bladder, it is retroverted uterus. So we go by that symbol on ultrasound. So we can rotate the image. We can rotate, put the bladder to our right or to our left, depending on our operator convenience. So let us look at the next case.
Yeah. Okay, this is antiverted. Yeah, as you were telling, like towards the bladder and away from bladder, actually the indication is by this Voluson Eaton mark is there. That will indicate I have kept it to that side. So when I do ultrasound in transvaginal scans, I keep the cranial end towards the opposite side because that's how I am accustomed to doing, and so now I can't change myself. So yeah, so that's how I am doing it. Okay, so now this is antiverted and 1 second. Normally. This looks like 1 second. We'll do a 4D scan. There's a minimal fundal dip with 2 cavities. It's not really confirming to, maybe we can say bicornate, but the dip is too less actually. So if the dip is equal to that of the myometrial thickness of the fundus, then maybe we can say bicornate. But we are seeing 2 cavity echoes extending up to the internal os of cervix, so maybe more of a septate uterus. And ovaries. Ovaries, they don't look polycystic or anything, they are not even adherent. Only it's a septate uterus, the septum extending up to the internal os. Cervix looks single.
Thank you, sir. Thank you for explaining all the cases in detail regarding the scan findings. So, as sir has discussed, in this case, the external fundal dipping is not significant. Usually, if the fundal dipping, we look at it in relation to myometrial thickness. If more than 50% of myometrial thickness dipping is there, then we consider there is some dipping. Similarly, septal extension is also considered in relation to myometrial thickness. So, that we'll end our session for today. We'll now move on to vote of thanks.
For extending her constant support and encouragement for conducting CMEs, which are important to upgrade ourselves. My heart fills with lot of gratitude and respect for our guest speakers, Dr. P.C. Mahapatra sir, Dr. Jatin Shah sir, Dr. Kamlaka Reddy sir, Dr. Ashish Kale sir, Dr. Rajiv Agarwal sir, and Dr. Apurva ma'am for not only sparing us their valuable time but also for enlightening us with their commendable talk on the subject. Thanks all of you for clearing our concepts and enhancing our understanding pertaining towards fertility treatments. Really, we are highly obliged. Next, I would like to thank our respected delegates for accepting our invitations, coming to this CME and encouraging us by your gusto. Special thanks to Mr. Tirupati for helping us in organizing today's event. Now I would like to thank the torchbearer of this event, our beloved Dr. Jyothi ma'am, founder, medical director, Ferty9 Fertility Group of Hospitals, for leading us and inspiring us towards the goal of clinical and academic excellence. We as a team of your students, your doctors, want to thank you from the bottom of our heart for sculpting us to what we are now. No event or conference can take shape without hard-working leaders. It was the dedication and enthusiasm of our chairpersons and our panelists which made this event a huge success. We extend our heartfelt gratitude for them. Conducting this CME would have been impossible without the zealous efforts of managing team led by our visionary CEO, Mr. Vinesh sir, who has devoted lots of time and energy for this program. So above and beyond, let's not forget the backbone of the CME, organizing committee, finance committee, reception committee members who went an extra mile, worked their tail off and made this dream a reality. Thank you so much, everyone. Furthermore, let's not forget, have a special recognition for our in-house speakers, my colleagues, my team, for powering this CME with knowledge and dedication. This vote of thanks would be largely incomplete without expressing my gratitude for the staff members who have really worked hard and carried out all the allotted duties very diligently. Needless to say that Mr. Kumar has taken care of audiovisual system very nicely. Special thanks to our media partners who have always helped us to make our programs noted. Thanks to our photographer, Cube TV, who has taken beautiful pictures of the event, that members and this program remain fresh on our mind but not also on paper. Thank you.